Hello and welcome. Suswagatam, Abhinandanam, Bienvenidas, and welcome. It's a wonderful occasion. We are moving on to day 2 of the conference. We had an exciting day yesterday and look forward to the same excitement and interactions in today's meeting. So we will start today's proceeding with our first session, Innovation in Diabetes Care, by various stakeholders. And to invite first, we'll have Snehal. Can I have the slide, please? Snehal Nandagavli, Mumbai chapter lead, Blue Circle Diabetes Foundation. We have, and before Snehal starts, we have the experts with us, Dr. Vijay Dave. Dr. Vijay Dave is Assistant Professor, Biomedical Engineering Department, Government Engineering College. Dr. J.S. Anand. Dr. J.S. Anand is Consultant Physician, Anand Multi-Speciality Hospital and Research Center, Gandhinagar. We have other experts, Dr. Vinay Mukhekar, Leading Medical Professional, Medical Affairs, Indian Subcontinent, Medtronic, Mumbai. Dr. Krishna Avatar Sharma, Rajdhani Hospital, Dausa, Rajasthan, and Mr. Sunny Shah, Chartered Accountant, Swasthya Diabetes Center, Ahmedabad. So over to you, Snehal, for taking us through Blue Circle Diabetes mobile app.
So hi everyone, thank you for giving me this opportunity. The topic I'm presenting today is the Blue Circle Diabetes mobile app. And I'll just share my screen so that we can get started. Okay. So as you can see, when we talk about innovations in diabetes management, the first thing that we could think of was a mobile app. Now you may ask, what's the use or what's the benefit of having a mobile app, right? So when we talk about people who are living with diabetes or patients who have diabetes, they have a lot of data that they need to collect. Maybe their insulin dosage, their blood sugars, they have to keep a record of that, what they have eaten, when they have exercised. So all of this data needs to be accumulated in one place. And when they go and visit the doctor, they have to share this data with them. So in the Indian market, when we entered, we did not see a one-stop platform for all of this data collection so that we can easily share it with the doctor. The traditional methods included taking notes in notebook, and many of the times it becomes boring. It becomes really tough to keep a track of in which book you have written. You have to carry a pen with you. So we always have your mobile phones with us. So the mobile phone application would be the best solution for that. So that is how we came across the idea of developing the Blue Circle Diabetes mobile app. So brief introduction about the app is that it is India's first app which is completely made by people who are living with diabetes. All our beta testers were diabetics. So that it gives me immense proud to say that we collected all the issues, all the concerns from the patients who are living with diabetes, and then we decided to introduce each of them as a feature in our mobile app. This app is available for free. It's available in both Android and iOS. It is, like I said, it is research, designed, beta tested, all by a team of people who are living with diabetes. As of now, the app has around 11 million glucose records, and the number is always increasing. We have also taken feedback from the community and tried to implement all those features as they have always shared with us. So as and when we come across new feature ideas, we keep on adding them to the app. I'll walk you through all the different features which are available in the app as well. But basically the main point here is to have one platform wherein we can collect all the data that people living with diabetes need to keep a track of, and it is easy to use, user friendly, and you don't have to have the hassle of carrying notebooks, pens, and then remembering where to write what, and in a consistent format. So the data is also available in a user friendly and a consistent format, and our app has been used by thousands of people, not only across India but also globally. So I'll start with app features one by one. So the basic app features would be record keeping or taking a log of all the things like blood glucose, meals, exercise, insulin. And as you can see in the screenshot here, This is the front page when you open the app. So it also gives a very beautiful graphical representation of the time when you were in hypo, that is hypoglycemia, that is low sugars, when you were in hyper, that is high sugars, and what was your time in range. And this all these calculations is given in percentages. And the number 100 that you see is the average sugar overall, like the current sugar for now. And also you can take a log of the meals, so you can easily click pictures, save them in the app, and you can also write the macro count for the meal that you had, the count for carbs, proteins, and fats. Also, the next slide shows how you can take a log of insulin, exercise, and like we already saw, how you can uh, take pictures of the meals and enter your macros. So all of this information is very important when you are connecting with your doctor and going for consultation with your doctor, because without this data the doctor won't be able to help you with the insulin dosage adjustment or any other issues that you face. Also, as you can see here, there's an option to set a reminder for you. So that is the another feature of the app, that is you can set reminders to check your sugars, and it gives you notification on your mobile screen saying that you have eaten your food and now it is time to check your blood sugars. And it also gives us some happy inspirational messages like good job, your blood sugars are in range. I think this is very important, such small happy reminders when you're living with a chronic condition like diabetes, which can easily cause burnout. The next feature is calculations for ISF and ICR. Now, these ratios may not be much useful to other people, but for people living with diabetes, especially type 1 diabetes, these ratios are very important. So we have a feature in the app wherein it automatically calculates the ISF and ICR with you. So the ISF is the insulin sensitivity factor, and ICR is the insulin to carb ratio. And over here, we also have given a small definition of what these ratios mean, so that if anyone doesn't know or if anyone is new to diabetes, they can easily get a hang of the jargons to understand. The next feature is a very unique feature, I would like to say, is that we also have a facility to add followers, which can be your friends, family members, and they can keep a track of your live blood sugars in real time. So let's say if you are staying away from your family, you're staying alone, and you want to share your live blood sugar readings with your families or friends. So this feature is very helpful here, and there is no record for follower count. You can have hundreds of followers, and here you can see a screenshot of me sharing the me sharing my blood glucose readings with my sister. So this is the screen that she can see. She can get a live readings of my blood sugars, and she can take a call if I'm going low, then she can give me a call and ask me to check my blood sugars and eat a sugar. The next feature is also very important when we talk about going to have a doctor's consultation. Is there's also a feature to generate reports in the app. So on the extreme right, you see a continuous chain of blood sugar readings, that is the quick reports. And in the center, you see a weekly graphical representation of your blood sugars. So as you can see, it is very user friendly, visually appealing, because in the bar graph, you can easily see how much time you were in range, which is the green one. The red one is where when you were in hypo, and the yellow one is when you were in high sugars. So it is very easy to understand, like how much time you were in range. I think that is one of the important factors to have tight blood sugar controls. The next feature is something which we have added, taking the feedback from the community, is the nutritional information and carb counting information. So as you can see, there's a nutritional information tab in the app wherein you can just search for whatever food you want to select. Here is an example taken for apple, and you get all the list of apples which are available in the global database, and the macronutrients for them, which is the carbs, fats, and proteins. And you can easily select any other ingredient that you want, and you can get the nutritional info for that. So now no need to go on Google and have a separate search option for checking the nutritional information for everything that you eat. Another feature that we have added is taking into consideration the feedback that we received from our global community members. So in India, we usually follow the metrics of MGDL, but in few countries um, we have the blood glucose metrics for mmol per liter. So we have recently added this feature. So in the settings, as you can see in the screenshot here, you can easily update which metrics do you want to use. You can also update the range that you want to put in. So each person can decide their own low and high blood sugar range, and this helps us to get a good control over our blood sugars. The next feature is something which is very close to my heart. It is the Buddy Project Helpline. It is India's first psychosocial helpline for all the people who are living.
The time is up. Please quickly finish. Thanks.
Okay. Yes. So the Buddy Project Helpline is a helpline for people with diabetes, and which is led by the volunteers. As you can see in the picture, we have these many dia buddies who can connect with you for issues regarding diabetes and mental health. The next feature is the recipes. So we have around 100 recipes shared by the community, and you can take a quick look at the recipes if you don't know what to cook for the day. And this is just the feedback that we received from the community, all the community members using it and saying that it has been very helpful for them. And also success stories of people who have shared with them by using the app, as well as being a part of the Blue Circle Diabetes Foundation community, how their HbA1c has lowered. So these are just two examples. And in conclusion, I would just like to say that the app is one such thing that everyone living with diabetes needs, and it has definitely helped everyone to have a better diabetes control. So with that, I would like to end my presentation.
Thanks, Nehal. One or two quick questions from experts, please.
So it's a good initiative, Snehal. Do you also share this data with the doctors who are treating these patients?
So as of now, no doctor has approached us for this data. Like, you can, for your personal consultation, you can build the report through the app and then share it with the doctor.
Yeah, because that would be useful, because
Yes.
you cannot share the clinical decisions, right? So that will make your app more friendly with the doctors, as well as they will get the right decision.
True.
But it's a good initiative.
Thank you.
Snehal, our group, our institute and other people in the group, they can help you out. You may contact Dr. Sushil, Dr. Yash for the same.
Okay, sure. Thank you so much.
Snehal, which software platform you are using for the development of this application?
I'm not aware of that. We have a tech team who takes care of it. Yeah.
Perfect.
Great. Please type your questions if you have further to manage the time better, so that we can take care of those questions in chat box. Let's move on to the next talk, Innovation and Clinical Method, Diabetes Care and Negotiating Skills. Dr. Labdi Kumari Pawar, Penza University. Over to you, Dr. Labdi Kumari.
Hello everybody. Myself Dr. Labdi Kumari Pawar, pursuing my studies from Penza State University. First of all, I just want to thank the organizing committee for allowing me to present my views here, to present myself here. We are at the first international conference for the innovations in diabetes care by NGOs. Here's about my presenting views: innovations in the clinical method, diabetes care, and the negotiating skills. The pathway through which we will go through is the introduction, then startup, rationale, then about the 7 main principles, method, ambivalence, training, discussion, and the finally wrap up. People with the type 2 diabetes have a 2 to 4-fold increased risk of the developing cardiovascular diseases, and also increased risk of the microvascular complications compared to the general population. Diabetes in their risk of developing such complication. This approach provides an opportunity for patients and healthcare providers to benefit from more targeted and effective treatments, potentially delivering more healthcare gain and improved efficacy for the healthcare system. New testing mechanisms and new treatments have made rigorous metabolic control in diabetes possible, so that the patient becomes a prime target for diabetes-related education and technological innovations. Also, patients become stigmatized as difficult, or it is also unwilling. Some patients are unwilling to accept the illness. Some points here are to consider are research in the field of diabetes related professional-patient interactions. It reveals a complex picture in which the patient is. Also, there is great diversity over patients' acceptance and understanding of diabetes. Next is one's own diabetes is perceived as less serious than the other's diabetes. Also, short-term comfort or the security is often preferred for the long-term health. Their knowledge about diabetes bears a little relationship to the personal use of the information. Patients' goals often differ from the professional goals. Good continuity of the care is valued and can influence metabolic controls. Also, testing out of the evidence of the professional is a normal response to new information, and initial impressions of the success or failure are powerful influences on the PECON. Belief in the importance of the metabolic control is often reflected in the level of metabolic controls. And last one, electronic spying on the patients undermine their sense of autonomy and the control. Patient-centered interactions with the doctors are often more effective than the doctor-centered interactions, but doctors and nurses also vary as much as their patients. And hence a detailed definition of patient-centeredness has remained fairly elusive despite encouraging evidence for relevance to the clinical outcome. Rationale for further development of the clinical method. So, motivational interviewing emerged as an alternative to direct persuasion. The practitioner was encouraged to help the patient resolve ambivalence about behavior change rather than present arguments for or against the change. Patients are known to vary in readiness to change a given behavior. Here are the 7 principles and development of the negotiating technology. First one is the clinical care needs to be sufficiently patient-centered to permit the airing of important psychosocial issues which are felt to influence diabetic control. Second one, patients' readiness to change lifestyle habits cannot be taken for granted. Explicit goal or the target setting is only sensible if it is acceptable to the patient and achievable by the next review. Fourth one is the complexity of the therapeutic goals in diabetes means that a menu of factors for consideration or choice must be explicit. Fifth one is the method must be suitable for all age groups or it doesn't have to think with the literacy level. Sixth, the style of interaction between professional and the patient should be influenced by motivational status of the patient. And the last one, the questioning patient is a learning patient even when the choices challenge conventional and medical wisdom. The methods, they are based on the 7 principles, and these principles are used as a next backdrop to a series of workshops where a subgroup of the research team developed the support materials with the help of a graphic designing.
Dr. Labdi Kumari, 1 minute left.
Here is the agenda setting chart. It is suitable for all the educational levels. What does it explain is, it is a visual set of options for the easy discussion and the priority setting. Clinicians who apply this chart correctly will encourage the patient to clarify which factors are relevant for him or her. The priority items are which and why they are prior for him or her. This will be followed by encouragement to set the modest target for the chosen item. A target should be achievable by the next consultation also. About the ambivalence, it is an extremely common phenomenon when it comes to changing a cherished behavior. However good the reasons may be far so doing. The ruler helps to bring feelings to a cognitive level by identifying the reality of the ambivalence, even in the face of expert opinion. Experience with the technique suggests that individuals who perform it conscientiously usually move up or down the readiness to change scale and they seldom remain static. The urge to try to push the patient in a desirable direction should be curbed to allow the process to occur at the patient's own pace. About the training. So the initial training took the form of the open exploration of how the team felt about the care of the people with the diabetes in their practice and how they organized it. In most of the practices, there was a genuine interest in these patients, but frustration about the difficulties inherent in achieving the necessary lifestyle changes. The training team also has indicated their willingness to demonstrate the method through role play with one another or with primary care team members. All practices which are opted at last 2 training sessions, each lasting 1 to half an hour. The distribution of training hours is shown in the next table. Here is the number of the visits approximately in 1 and 1.5 hour. The patient visiting for training sessions number of the practices, it is in the percentage given. We can see here. And for follow-up sessions by nurse or for helping doctors, number of the practices, it is also shown in the percentage here. It is described the evidence base for our trial, the development of the method and training for those participating in the intervention arm unknown until the late 1996. We have therefore addressed these issues as fully as possible, and we hope that this will prevent an element of post hoc reporting bias when the trial and results are published. Acceptability is not proof of efficacy. However, so while we await the results of the trial, we would like to engage other clinicians in trying our tool and in commenting on successes or the failures of it. People hold different values, and for many, short-term convenience or comfort is traded unwillingly for long-term health gain. And about the wrap-up, so health professionals often forget that modern society tends to believe that paying tomorrow for what you can get today is an efficient way to use a resource, that is health here, and that devalues our time. Health economists call this discounting, and promoting healthy lifestyle choices in the people with the diabetes and many focused and sensitive long-term implications, but the principles of the health promotion are the same, and it behoves the professionals to research every avenue that may help patients make well-informed choices. And this contribution to the development of clinical method is made in that spirit only. Thanking you.
Thanks, Dr. Labdi Kumari. Questions for Dr. Labdi Kumari? Experts, please.
So yeah, I think I can go ahead. So Dr. Labdi Kumari, I think change is always the most difficult part, but I couldn't see the data. So have you seen at your interim data, or are you what kind of results you are expecting, and what is your metric of success in change management?
It's the starting time of the our innovations here. We had proceeded this thing on the diabetes patient recently, so we just haven't viewed it like you can say it's statistical way. We haven't just viewed it till now, but it's the processes that we had done, and this is the pathway by which we had gone through it, the principles and the methods through which we are going, and what we are expecting and what will be there. So it's all about.
No, I agree with Dr. Vinay, because we really look forward to the data, because the topic was related to negotiating skills and how these skills really make an impact for improvement of clinical research. So that outcome, I think if you can help us with, that will be of really help. Dr. Dave, you want to ask anything?
Yes, I'm totally agree with Dr. Vinay, and you have to produce the data where, and be clear with the system. Okay, you are proposing this system, or you have already started working on the system, and what is the actual outcome of that thing, so that we would like to see. What you're proposing sounds very good, and it sounds very fruitful. But we would like to see the results on that.
Yes, it's not there in India. So we are not, this process it is taken out by the our university in Russia. So we are having the databases and the what the outcomes will be there. It will be based on their patients there. So right now,
And one more suggestion I would like to make, maybe you can select a particular area, like maybe insulin initiation, which is a big challenge. Going to
yes.
the injection phobia or targeting very specific aspects, I think that will really help you to demonstrate whether the change management strategy works or it doesn't work.
Agree, Dr. Vinay. Thank you so much, Dr. Labdi Kumari. Let's move on to another exciting topic, that is smart nudging to achieve sustained diabetes-friendly behavior. It is very well linked to the previous topic, for which I would invite Mr. Harsh Molik, CEO and founder, Hum Life 360. Welcome, Dr. Harsh Molik. Over to you.
Thank you so much. Dr. Gupta, give me a second to share my screen, and we should be. Okay, hopefully you can see my screen, and I will try to keep my presentation to less than 5 minutes, but I have to start with a personal story. I am a diabetic. I have been a type 2 diabetic for about 11 years. My mother, who was a diabetic herself and a doctor, diagnosed me. So why do I start with the story? For a few years, everyone thought that I would be able to control myself using standard medication and medical protocols, because my mother expected that. But she was a person of unusual willpower, and she could control her diabetes. It turned out that I could not. And that became a problem, because my mother often said, the only thing that I can say is, you can bring the horse to the water, but you can't make the horse drink the water. So we had everything. We had resources, doctors, advice, medications, but the last mile delivery of, I have to get up in the morning, I have to take the medication. I travel a lot, so I have to make sure that my daily life, my daily routine follows a certain diabetic friendly behavior. I just couldn't do it. And that brings me to the problem that we saw. We are a behavioral company. Hum Life 360 is a behavioral company. We do not step on the doctor's domain. We do not necessarily step on the nutritionist domain. We do not necessarily step on the psychiatric's domain, but we work in the middle of all of this. And our job is to be a friend to the customer, to our patient, and help them actually take those 4 or 5 steps or do those 4 or 5 things every day. We call it a smarter way to deal with diabetes. And essentially what we do, very simply, we understand what keeps the customer going. So we use a behavioral framework, which is fairly established in the market for the last 20, 30 years. And then we use a whole notion of nudging and motivation, which includes a lot of components, because we are talking about human life. So we understand the customer, we figure out how best to nudge them, and our whole objective is, for that particular day, can we motivate that one human being to do that one thing that will help him manage his diabetes? And the key word is manage and balance. That's what we do. Our objectives are very simple. Our objectives are not to bring the blood sugar down to 110 or whatever is the ideal number for that region of the world. Our objective is to help the customer achieve a diabetes-friendly daily lifestyle. The second bigger objective is to give them the ability to sustain that lifestyle day after day after day. There are festivals and there are vacations and there are holidays, but still, how do you achieve a sustainable lifestyle that brings your blood sugar to the best possible balance that you can achieve? We are able to share our customers' data with their doctors and support groups. We do combine a lot of medical information, dietary information, psychological information, but all we do with that is to help the customer realize an optimum range for their lifestyle. Because if you push someone beyond a certain point, you're not going to get any returns. And finally, one of our objectives is, because we work on the behavioral side, we are focused on the behavioral side, we actually have helped a lot of people to prevent becoming diabetic. Probably just like everyone else, we do have an app. It's very well built. We do provide our own suggestions around what we should do. But once again, the focus of what we do is we have a bunch of people, and I'd like to speak about that for 30 seconds. The whole notion is to be friendly. The whole idea is to have a friendly approach to nudging. And that means that we're not prescriptive. We don't use anything like you have to do this, not at all. We have to work at the pace of the customer to make sure that life always comes first for them. Diabetes will always come second. We have to make sure to make the customer comfortable with whatever it is they are doing, whatever, for example, changes they wish to make, with our friendly nudging help. We have real people. We are actually in the process of developing Humbly. She is our voice assistant, so we have automation there as well. Technologically, I don't know if I want to go through this, but there's a whole bunch of technology that my team uses, including artificial intelligence, natural language processing, so on and so forth. But the big factor, and that's why I've mentioned that separately, the need for human empathy will never decrease. There will be an extent at which there will be a point where the need will decrease a little bit, but it will never go away. So we always will have people who will help someone on the phone in a way that helps that customer to maintain a motivational, diabetes-friendly behavior. These are examples of some of the seminars that we've conducted, some of the sessions pre-COVID, when our friends, Hum Life 360 friends, i.e. the coaches, were able to go and visit the customers personally for educational reasons and so on and so forth. So far, it's about 225 patients now, 27 to 70 years. We were able to bring down A1Cs by about 1.2, up to date about 2 points over a period of 7 months. And on the behavioral side, we had set ourselves 4 challenges. So we have helped them establish new daily meal patterns, new recreational activities, taste substitutions. The one thing that we could not do, and maybe this because of the screen, you may not be able to see that. The last thing that we could not do very successfully was portion control. It's the most difficult thing for people to accept. But I think we are making some progress on that as well. And this is over the last 200 plus patients over the last about 1.5 to 2 years.
30 seconds to go.
Yeah. We have testimonials from customers, from doctors, from patients. And the thing about behavioral solutions for diabetes is that almost axiomatically, almost by definition, it has to be naturally personalized to that human being. It can be delivered remotely. It is useful in prevention. It can be adapted to any size of community, to any level of education. We are talking about behavior. We have to be able to relate to that human being, and we can impact behavior. We can make it affordable and profitable. And finally, I think smart and proactive nudging is a very long-term and very effective solution for mass management of diabetes. Thank you.
Great talk, Mr. Harsh. We open this to our experts for questions.
Mr. Harsh Malik, you said that you use the combination of the 4 behavioral aspects, like the food and the exercise and the recreation and other things. So what is your output that, I mean, which factor that you found that contributed significantly for the diabetic friendly behavior? Was any thing, I mean, any research done on that?
I will give you a very frank and practical answer. All of these things have a big impact. As of today, so we keep analyzing this. As of today, frankly speaking, our biggest motivational trigger that makes a customer go, oh my God, I have to do this, in India, is basically when we start talking to them about their children and their grandchildren and what they want to do after they retire. That conversation, I won't get into the details, but I'm hoping you get the point. That conversation is the triggering point. We call it life satisfaction. We call it life, we have a whole formula around it. And then we leverage a lot of those concepts and we bring them down into exercise, diet control, so on and so on. But biggest thing for that age group is this concept of, okay, what's going to happen to the family?
Mr. Harsh, yes, please. Sunny, you want to go ahead?
Yes, sir. Yes, ma'am. Sir, I am a chartered accountant, so I am not able to understand the technical aspects of the diabetes. But whether you are running this organization in a form of an NGO or it is a startup having a vision in future.
Good question. Thank you for that. So we are, number one, we are not an NGO in the sense that we are a for-profit company.
Okay.
That's number one. Number two, but the way we have set up the corporation and the way we have set up the operations, we acknowledge and recognize that in India, as in other parts of the world, there will always be a huge population of diabetes people who will require this service free of cost. So we have a very large, wide, free service kind of a deal, which is why we were invited to this conference. So there is an NGO version to our work, but we are essentially a startup.
Okay. And in case of the profitable version, what would be the cost for a normal patient? If that person wants to take a subscription of your organization, then what would be the cost for a diabetic patient? Because what happens is the concept is very good, but to implement this concept, a huge cost is supposed to be incurred for developing this kind of application to gather the team and everything. So I just want to understand what would be the cost for a patient if he wants to subscribe for the profitable part of your organization. I'm not talking about the NGO side, but for the profitable or the subscription portion, what will be the cost for a patient?
So very briefly, 3 plans. One is the free plan, which is, you can call it the NGO plan. The 2 other plans are ranging from 700 rupees a month to 1,250 rupees a month. But there is one rider, as your performance improves, your monthly subscription goes down and you can actually have all the services available for 1,225 and not pay anything because you are in good shape.
That is a very good motivation for the patient.
That's great talk, Mr. Harsh. Just one question from my side as well, because I know we are running short of time, but one quick question that these apps definitely help people with diabetes to improve their outcomes. However, what about the comments about the data integrity and data confidentiality? Do you have any comments about that?
Oh, 100%. Nothing is shared, very briefly speaking, absolutely nothing is shared without the express permission of the customer. We have that in every version of Indian language. If they're not educated enough, we still have to ask them, our friends, our counsel has to ask them, are they okay with that? And only when they say yes, we can share it. That's number one. As far as the security is concerned, we are on basically at Amazon level security. So we're not too much worried about that right now. Does that answer your question, ma'am?
Yes, thank you so much. Great insights and great work being done. Thank you so much, Mr. Harsh Malik. Let's move on to the another talk by Ms. Diksha Dev, who will be talking on behalf of Ms. Jazz Sethi, Blue Force Network Unique Children's Initiative. Over to you, Diksha.
Thank you for the introduction, ma'am. Hi, my name is Diksha Dev. I'm the head of community engagement at the Diabetes Foundation. And today I'll be talking about Blue Force Network, which is our youth wing. So can I please share my screen? Can I have the rights?
Yes, ma'am.
Thank you. So we will be talking about Blue Force Network, as I told you, the Diabetes Youth Wing. So a brief introduction about the project. It ideated from a simple conversation of adults living with type 1 diabetes, talking about the fact that if we got a platform to talk about our diabetes when we were diagnosed with it, what impact, what change would have it made in the lives of other people. So as we all know, type 1 diabetes is a condition with a high prevalence of diagnosis in children. Yet we have always found that it's just the adults talking the talk. And when a child is diagnosed, it comes with that overwhelming sense of loneliness. Representation in media and support groups is a crucial way to bridge this gap. And our latest project from the Diabetes Foundation is an effort to bridge this gap and give a strong, bold voice to the primary stakeholders who are affected by this condition. So the purpose of Diabetes Youth Wing is to bring a young, fresh face of advocacy and awareness. Our youngest stakeholders have very unique, strong views and perspectives about their condition, their lived condition. And this platform basically allows them to communicate, educate, and advocate about their stories of type 1 diabetes and in their voice. We believe that children are not our future, they are our now. So what are the materials and methods that we use in the Blue Force Network? So the first is the way children see their condition is so unique and their challenges are unique. I have been living with type 1 diabetes since last 21 years. When I was a child, my challenges were pretty different from what I'm facing right now. So that is their platform to talk about their challenges in their voice. This platform allows them to have an unfiltered zone for them to identify the shortcomings and use their creativity to course the correct plan of action. So whatever challenges they are facing, whatever shortcomings they identify, it's their canvas to paint on, to pave a path and find the solutions. It is also a project where we want to study what happens to children and their confidence with their condition when they have agency and empathy. So these are a few methods that we use. So the program is again divided into a few key silos that work simultaneously. They are all interconnected. First, we have the awareness team within the Blue Force Network, which takes care of things like webinars, arranging events, social media, and more. We also have a team that facilitates back to basics. That's a project specifically for one-on-one education and counseling. A lot of times, since we were talking about, that sense of loneliness that a child goes through when they are diagnosed with a condition, to bridge that gap, to make people feel that they are being heard and they have other friends in the community, this project works wonders. And then they break the ice with newly diagnosed children. This is what exactly I was talking about, and offer them basic awareness and education in their language and style. Because if I talk about type 1 diabetes education, it would not make a lot of sense to a child. Probably a child telling them that this is what diabetes is for me and this is how I have been taking care of it, it makes much more sense. So here is the project in action. So this is one of the snapshots of the Instagram account where they create content which they feel is relevant to the condition, and again the content is pretty engaging. So this second snapshot is from a webinar that they planned about inside insulin, a part of their basics Stubby Basics campaign. So every month they have a theme on which they do a webinar, which is broadcasted on live on YouTube or other platforms as well. And this, since we were talking about back to basics, this is a snapshot of a session conducted with a newly diagnosed 8-year-old girl, guided by BFN members to ease her anxiety and offer her support. And of course, there were a bit of education also, telling her how many times to inject, how many times do they monitor, etc. So this is our team. We have Ankul Mukherjee and Srishti Pandey, who are the leads for Blue Force Network. And this is basically our team. The age group is from say 7 to 8 years to 18 years. So we have a variety of voices and who can talk about their challenges according to their age group. So this is the result that we have found after we started. Since we have implemented Blue Force Network, this is the result which we came up with. So we started the confidence and the skill level of the entire BFN team before and after they joined the project. That was one thing that we measured. We found collectively that there was a higher and stronger sense of empathy and agency within the group itself. They found themselves in, of course, the driver's seat and actively participated more towards bringing that change, not only within the community, but also within their own management. So when we talk about type 1 diabetes destigmatization, these are the voices that we need. And we have seen that, putting them in driver's seat actually catalyzes that change. And of course, it also helped them with their own management. So these were the few testimonials that we have received from the team members. First is how has it bettered their knowledge and skill of type 1 diabetes. A lot of people have said that, they have been diagnosed since a long time and they did not, of course, know a lot of things about type 1 diabetes. Just a second, there's some issue. I am so sorry, there has been some technical issue with my laptop. Can I have a moment, please?
Yes, please. Your time was up actually, Dr. Diksha. But
okay, I'll just quickly run you through the testimonials if I can get a moment. Yeah. Thank you. So if my screen is still visible.
Yes.
So we have talked about, how has it bettered their knowledge? How has it actually helped them to help the community? And how has being a type 1 diabetes leader changed them? So they have become more calm. It has basically made them understand there are different situations and how to deal with those different situations within their own sphere, and also helping other people at the same time. And of course, they feel more confident about themselves and their diabetes now. And they have, apart from the skills of diabetes management, there are other skills also that they have found to be extreme importance to be inculcated in them while they're working with BFN. So yeah, so the conclusion is that, in a juvenile condition such as type 1 diabetes, it should be children who should be the voices, whose voices should be heard, and it gives them a great sense of empowerment and equips them with the skills and attitude that needs to be, that helps them to deal with stigma, misinformation, and taboos. And through BFM, we are definitely trying to cultivate a network of children with type 1 diabetes who can be and lead the change. So these are a few projects that IRSCs work on.
Thank you, Diksha. Wonderful presentation indeed. Dear experts, if you have questions for Diksha, please go ahead.
Diksha, it was a good presentation with good highlights of the outcome of the project. I just want to know how many students or like how many children actually participated in this system for your proposed system.
So as of now, we have around 12 to 15 members who are actively working in BFN. Of course, when they saw, we have seen that, you know, when a lot of other children saw these people taking webinars or on social media, spreading awareness, a lot of other children who are living with type 1 diabetes wanted to join. So we will be, you know, once they cross the age of 18, probably will take in more children.
Great, thanks, Diksha. So if we understood correctly, it's more of a peer group sport and creating awareness and education for children with type 1 diabetes, right?
Yes, of course, by using their own voice, because
understood. Yes.
Yeah. Why should adults have all the fun?
Great, really, but that's so true. And it is linked with IDF as well, is it?
Yes, it is an IDF project as well, as far as I know.
Thank you. Very interesting, Diksha. So let's move ahead to the next talk, which is again a very interesting topic: AI-enabled multispectral autofluorescence imaging device for rapid detection of bacteria causing diabetic foot infections. Unfortunately, Ms. Geetanjali couldn't make it, and in place of Geetanjali, the representation is by Dr. Bala. So, Dr. Bala, over to you.
Yeah, thanks a lot for the introduction. Hope you can see my screen.
Yes.
All right. Good afternoon, everyone. It's a pleasure to be here. I'm Dr. Bala. I'm currently the CTO of Whatever Diagnostics. We are a social impact company with the aim of making diagnostics affordable, even for low resource settings. The first product that we have leverages artificial intelligence and autofluorescence, so that you could reduce the time of bacteria detection from 2 to 3 days to 2 minutes. That's 100-fold reduction. So as we all know, wound care is a big problem, and especially in diabetic foot ulcers, 1 in 4 diabetics are at the risk of amputation. And worldwide, if you look at the numbers, quite staggering. You have an amputation every 5 minutes because of diabetic foot ulcer. So a lot of it happens because we don't know what is the infecting agent. And even for getting information on the infecting agent, we have to rely on culture, which takes a long time. And culture labs may not be available in low resource settings. So what we found that the current solutions, either they're not accessible, or the solutions that are present, they're quite expensive and not really customizable for low resource settings. So the objective of this device was to ensure we have a low cost and rapid handheld staining solution that can detect and classify bacteria directly on the wounds. I'll not go into a lot of technical details, but the principle of this is just a label-free technique. The bacteria themselves emit certain autofluorescence markers. So when you excite with certain wavelengths of light, they have a slightly different expression of the autofluorescence. So based on that, we built a device. And so just a little bit of science, right? You can see the different bacteria. There is red highlights slightly differently depending on the bacteria. And this is what we capture using our device. So once we build the device, we call it novel optical biopsy solutions, the world's first AI-based device, which can rapidly tell what is the bacteria. Currently, it can do gram type recognition, whether it's a gram positive or negative, within 2 minutes with 90% accuracy. It's a patented technology. I would like to quickly show a video. Please, just 1 second. I might not have enabled the sound. You can see the screen, I suppose.
This guy is a treated leprosy patient. He developed this very hypertrophic ulcer, which is not healing despite multiple courses of antibiotics. So we've taken the image, and now the device is just going to use its artificial intelligence algorithm. We'll get to know whether the wound is infected, and if it's infected, where it's infected. Before this device, we would actually have to take a biopsy. It might take as long as 7 days to help grow the slow-growing bacteria. This takes a minute.
So antimicrobial resistance actually can be attributed to one of the causes, basically could be misuse or overuse of antibiotics, which is not needed. So this device can help in this regard.
So this is the baseline image. This green image shows the amount of infection the patient has. And in a span of 40 minutes and over serial images, we can see with the help of debridement how the infection is going down. You don't need to give the patient any antibiotic. And in the span of about an hour or so, he's here, you've cleaned the tissue, he can just have it dressed and go home. It's a very positive outcome for him as well as us. The patient goes home satisfied. So this guy is a
right. So one of the goals of this device is to reduce antimicrobial resistance, because when the doctors don't have information on hand what bacteria is infecting, they tend to prescribe generic antibiotics, right? And we all know the impending antimicrobial resistance problem as we are running out of antibiotics. So we are helping doctors to make better decisions in terms of what antibiotics they should prescribe, especially for repeat visits. When the patient first comes, they may do a culture test, but when he comes subsequent times, either they are not able to afford, the doctors typically don't prefer sending it multiple times. So this device can aid the doctors in multiple things. One, to see where the infection is. Second, if it's a gram-positive or gram-negative bacteria, and tailor the antibiotics. And number three, after they clean the wound, they can also see effectively if they have, debrided the wound, so that the patient doesn't have to come back multiple times. So we've tested this device in a clinical study at multiple hospitals. And the reference is a culture test using either a deep tissue biopsy or a swab. And we also see that a lot of bacteria that is present on the wounds, right? Staphylococcus, Pseudomonas, these are the bacteria that develop huge antimicrobial resistance. In fact, in the hospital, we see 30% of the patients are resistant to first line of antibiotics. It's quite scary. So the idea is, if we can detect and classify this bacteria early enough, then we can tailor the antibiotics. So the device currently has close to 90% accuracy. I'll not go into a lot of technical details. But it helps doctors to make better decisions. And importantly, it also detects biofilms which are not culturable. And a lot of wounds don't heal because they have biofilms, right? Irrespective of how many antibiotics you pump into the patient, even after 4 weeks, the patient doesn't respond because the bacteria has made a protective layer, and the procedures that you typically follow does not help in healing the wound. And eventually the leg gets amputated. So this device can also help detect biofilms. Some of the results of this device, you can see with naked eye, you cannot see that there is a huge bacteria, but when you use our device, the bacteria lights up, right? And that's where the doctor knows that, yes, this is where the bacteria is and have to treat. We have done for both gram-positive, gram-negative bacteria. So just as a conclusion, this novel handheld device helps doctors in making better decisions, both in terms of how to manage the wounds and also how to treat the wounds. So we are very excited about this device, and we have already given it to multiple doctors. And we also run camps for free screening, diabetic food screening in association with various hospitals. Thank you for your attention.
Thank you, Dr. Bala. Great work, and it is the need of our great insights indeed. So, Dr. Dave, Professor Dave, if you want to ask questions.
Yes, it was actually, in fact, a very good device. I just wanted to know the accuracy, like you have said, the overall accuracy of the device is around 90% or maybe 85%, you said, fine. So, and you are working on the AI and ML, if I'm not mistaken. So, have you applied all the algorithms related to AI and ML, and you have obtained this accuracy? Or maybe if you change your like SVM or like any other KNN algorithm, you may be able to obtain some better accuracy in terms of result. What do you think?
Yeah, thanks, Professor. Excellent question. Just to give background, we have started with machine learning techniques using random forest, SVM, and other techniques. And we found that the accuracy is close to 85%. Now we are also using a deep learning framework to not only detect whether it's a gram-positive or negative bacteria. We are seeing preliminary results where we can recognize certain bacteria with close to 90% accuracy, so that you can directly tell what bacteria is present instead of just gram-positive and negative.
Is there any chance of false positive results?
Yes, there is certain chance. So we, especially if they are using cleaning agents like betadine, etc., and they are naturally fluorescent, that could be one false positive where we typically tell the doctors and the nurses to ensure that this is cleaned properly. Second is if there is skin, right, which is just developing, it may show certain autofluorescence because of collagen. So what we are doing right now, we are training deep learning networks to recognize it's a wound or a skin so that we can compensate and reduce the false positives.
In case of culture sensitivity report, we identify the bacteria and also which antibiotic is sensitive to that particular bacteria, whether it is possible to identify.
Yeah, thanks, Dr. Anand, for the question. So we are developing another platform based on same principle. We call it rapid antibiotic susceptibility testing platform. So essentially the idea is similar. We look at metabolic markers, and when the bacteria, you add antibiotics to the bacteria, the metabolism of the bacteria changes. So from that, we are making another device which can tell whether it's a susceptible bacteria or a resistant bacteria. And not only that, you also have to tell what is the concentration. We call it MIC. That also we are planning to incorporate in the device.
Nice, thank you.
And is your device commercially available, or it is just
Yeah, it's
a prototype?
commercialized.
And what
It's
is the cost of the
commercialized.
device? What is the cost?
So there are multiple business models. So depending on the hospital, either we give a CapEx model or we can do a rental model starting anywhere from 15,000 per month. Or it could also be per patient cost, the 500 rupees we can charge. We can work out, various business models that work for the end customer.
Thank you.
Dr. Krishna Sharma, do you have any questions? It was really an interesting topic. Do you have any question to Dr. Bala?
No, ma'am. No, ma'am.
Okay, thanks. Very interesting, Dr. Bala. Thank you for being with us and sharing your experience and expertise in the field. Thank you so much.
Thanks.
Let's move on to the another important topic, that is strengthening continuum of care of non-communicable diseases within urban health systems in Mysore, Karnataka. And for this, we have with us Dr. Swaroop N, Thematic Lead, Comprehensive Primary Health Care, Karnataka Health Promotion Trust. Over to you, Dr. Swaroop.
Thanks so much. Please permit me to share my screen. Good afternoon to all. Thanks a lot to the organizers for this wonderful opportunity. Today, I'll be presenting to you about an innovative public-private partnership based model, which looks at strengthening continuum of care for diabetes and hypertension in urban Mysore, which is in the state of Karnataka. As we all know, 63% of all deaths in India can be attributed to NCDs, and especially diabetes and hypertension. They have a lot of economic impact as well. And compared to rural areas, we see the burden is quite high in urban areas. And there is a limited number of continuum of care model available for comprehensive NCD care in India. With this background, the goal of our initiative was to develop a model that will result in high coverage and quality of NCD services across prevention to care continuum. The specific objectives are to improve efficiency and quality of health services across the NCD care continuum, promote equitable health services by facilitating access and coverage of services to the entire population, and most importantly, understand mechanisms and strategies to scale up across the state and thereby motivate the country to take it up for scale. The initiative is being implemented at Mysore, which is about 160 kilometers from Bangalore. We started off this intervention with a population of 58,000 under one urban primary health center area. Later scaled up to 5 more facilities, but this is the facility in which it was initiated. So hence I'm going to present the data related to this facility. And we have covered about 12,000 households in this facility, covering 1,700 people with diabetes, hypertension, or both. So the three key elements of this initiative is we adopt program science approach right from designing of program and implementation of program, so that we generate the continuous evidence. And we believe health system centric approach is essential for strengthening continuum of care, and patient centric approach is much essential for better metabolic control. The other hallmark is working with the government. So this is a public-private partnership model. So we work within the government health system so that they are involved right from designing and active participation in implementation as well, so that they know very well about the prospects of this interventions, and they can take it up for scale in the later stages. The key aspect of this program is strong community connect, and we have good community engagement program to improve the community outreach and mobilization, especially the underserved. The population which was selected is underserved for this initiative. So these are the different phases of the project. The first year went into situational assessment, and then we were able to develop the intervention model at the end of year one, along with the consultation with Government of Karnataka and other experts. Since then, we have been implementing this intervention for almost 2 years, and this intervention will also have a monitoring and evaluation component to understand which are the components that are working well and that could be taken up for scale. So this is the continuum of care model that we have adopted. Household level screening for diabetes and hypertension was conducted using point of care devices and mobile platform. And then they were referred to the PHC, wherein we had set up confirmatory diagnostics. So the diagnostics that has been set up are the HbA1c, which is done every quarterly for the known cases of diabetes and hypertension, and annually lipid profile, albumin creatinine ratio, ECG, and diabetic retinopathy tests have been done. All of these have been point of care devices with inbuilt artificial intelligence, and the cases that are suspected to have complication, now we have established referral networks with the secondary and tertiary care hospitals within the city. So the patients are referred there for free consultation and treatment. Once the diagnosis is confirmed or complications are detected, the treatment initiation will happen, wherein we have trained the PHC doctors and even the private doctors on the treatment protocols, and we have established electronic medical record to capture the treatment history as well as the test results. And after that, there will be continued monitoring and adherence in the form of continuous counseling, regular counseling, a digitized monitoring system, as well as community engagement activities in the form of wellness activities in the wellness centers. The long-term management and disease control is ensured through regular follow-up visits at the facility and community. So in order to ensure this continuum of care, we adopt a community-based approach, wherein the people with diabetes and hypertension are first identified, and then they are enrolled by a cadre of community health workers. So we have one community health worker dedicated to about 100 people with diabetes and hypertension. So they dedicate about 2 to 3 hours in a day. They are part-time workers who work on an incentive basis, and they're all from local geography. So they know the geography well, and even the people very well. During the enrollment, HbA1c, blood pressure, BMI, and all other relevant socio-demographic information is collected. And then with the help of a digital application, so they do the needs and vulnerability assessment. So the risk assessments includes clinical, behavioral, psychological, and social risk, as well as the vulnerability parameters. We have identified 9 vulnerability parameters. When the resources are constrained, we need to ensure that the maximum time and efforts are put into people with vulnerabilities. Once this need assessment is done, the app helps in developing micro plans for the outreach efforts. So based on the clinical and other vulnerability parameters, the app will prioritize the patients So the people with poor metabolic control and more vulnerabilities will receive more visits by CHWs and intensive efforts at the facility as well. Following this, the regular outreach and follow. So customized behavior change communication is done by CHWs at the households on a regular basis. And the patients are referred for regular testing like HbA1c, blood pressure, and annual tests. And counseling is also provided, especially after COVID. We are seeing a surge in mental health issues. So counseling is provided at the facility. And patient support groups are organized on a regular basis. So the CHW mobilizes them. It's a platform wherein the patients can cross-share their challenges and the best practices, and also opportunity to cross-learn from their peers. They're also mobilized to health and wellness centers that we are set up in the urban municipal areas, wherein they are offered wellness activities like yoga training and other physical activities. Healthy cooking practices are demonstrated. And a lot of stress is given on treatment adherence, lifestyle modification, and prevention of complications. So during the COVID pandemic, there were a few hurdles, but we overcame them, including the BCC through virtual calls. And also, instead of having the testing done at the PHC, we were doing it at the outreach centers. And wellness activities were being conducted in smaller groups. And we also activated interactive voice response system so that the information and education is provided to the patients through this platform as well, along with the home visits. So this is the technology platform that I was mentioning. So it has 4 interfaces. One is with the community health worker at the community level who does household registration, enrollment, needs assessment. It helps in doing BCC activity, mobilization, and I also get a dashboard to look at the progress made by individual patient with respect to metabolic control over a period of time. It helps them to take course correction. It also does automatic incentive calculation. So we also have a cadre of CSW coordinators, one for almost 5 to 6 CSWs. So who provide supportive supervision to the CSWs, and they also have their own interface. And we also have a web portal wherein the program managers look at the overall progress of the entire project and also performance of each of the CSWs and CSW coordinators, and really make strategic decisions with the help of the dashboard and reports that are generated. And finally, we have the electronic medical record at the facility. So the CHWs, the data entered at the community level is made accessible to the counselor at the UPHC. So the counselor also is aligned with the needs and risks and vulnerabilities the individual possesses, and counseling happens accordingly. Similarly, the data entered by counselor and all the test results that are entered by counselor at the facility are available to the CHWs live, so real time. So this helps in real planning, real-time planning by the CSWs. So these are some of the salient features of the technology platform. It aids in real-time data capture, inbuilt analytics for decision making, insights to view the progress on a daily or weekly basis, and integration with electronic medical records at UPHC, inbuilt behavior change communication messages and videos, inbuilt analytics for incentive calculation, and it's in the offline mode, GPS enabled, and with dual language support, both in English and the local language. We have a strong and robust monitoring and evaluation system to monitor the progress as well as evaluate if the interventions have been successful. So it is a real-time data that is captured regarding all the programmatic aspects, and we have a dedicated monitoring and evaluation team so that retrieves this data, analyzes and shares them constantly with the program team, so that the same thing is discussed with the community health workers and the field team, and course corrections are done. So the entire data is secured in our cloud-based server.
30 seconds left, Dr. Swaroop.
Yeah, thanks. So some of the initial results. So we screened about 33,000 adult population, and we have around 1,700 patients retained in care, and about 42% people showed clinical improvements between first and second round of follow-up, and 50% between the next round of follow-up with respect to diabetes. And similarly, hypertension, around 35% improvement is shown. With respect to more than 1% HbA1c improvement and more than 10 mmHg systolic bar 5 mmHg diastolic improvement, we see almost 19% improvement and 16% improvement respectively. So these are the wonderful resources that have been developed and has been adopted by ICMR for their national task force project, and also taken up by government of Karnataka for their training, and a lot of policy changes have happened in Karnataka because of this initiative. And in conclusion, so we have the patient and health-centric approaches, tools and processes for implementation, digital solutions, and we have collaboration with government and all the relevant stakeholders, both at the Mysore city as well as in the state. So we are ready for replication and scale up, and we are offering technical support to many other partners and municipal corporations in the country, like Pimpri-Chinchwad Municipal Corporation has approached us. So we are open for partnerships and collaborations in terms of providing both the technical support as well as we can also act as an implementation partner, since our DNA is working closely within the public health systems. And so we have a MOU with the government of Karnataka. We have established innovation cell. So wherein both of us jointly design, develop and implement programs and then take them up for scale. Thanks a lot for this wonderful opportunity. Look forward to the questions.
Thank you so much, Dr. Swaroop. It was great listening to you and the work which has been done. And we really look forward to scale up of this project, because that will really help the needy people in the world. So starting from India, of course. So over to you, Dr. Anand and Dr. Sharma, if you have any questions to Dr. Swaroop.
Whether it is chargeable for the patient?
No, sir. It is completely free of cost.
It is sponsored by state government.
Yeah, certain resources are put in by state government, and we also received fund from international donor.
Okay.
The way you had a question.
Yes, Dr. Swaroop, I mean, what was the time duration to achieve those results that you have described, I mean, in terms of improvement in blood pressure and diabetes? So what was the total time duration when you applied this model and you obtained these results?
So it's about 18 months of intervention, sir.
18 months.
And it's an ongoing project. We started in 2017 with situational assessment and then consultation and developing the model. But interventions are ongoing, and they are being scaled up to other PHCs as well.
Dr. Vinay, you have any questions?
Yeah, I was looking at like since you are dealing with people who may not be very comfortable with handling technology or understanding diabetes, or so like how do you ensure the stickiness of whatever interventions you are doing?
Yeah, that's a good question. So we selected CHWs who are at least 10th grade up to the graduation level. And we had a 18-day intense training curriculum for them. We had developed 3 training modules, and we had a separate training curriculum on the technology platform as well. And repeatedly, we have refresher trainings, and weekly we have review meetings to address the issues and challenges they come up with. So it's an intensive training curriculum plus a regular and robust supportive supervision that helps us to build the capacities of CHWs.
Wonderful.
Great. Thank you so much, Dr. Swaroop, for being with us and sharing the great work which you and your team is doing. We really wishing you best for the scale up of this program, which is really the need for people. Thank you so much.
Thank you so much, ma'am. Thanks to the wonderful organizing team for this great opportunity. Thank you so much.
Thank you. Rajdeep Samadar, who was our next speaker, due to some exigency, he could not make it. So we will move on to the next talk, that is dangerous diabetes. I'm not curable. For this, I would invite Dr. Ayushi Garg from MZN Medical College, Panchkula. Dr. Ayushi, please.
Hello, good morning, each and everyone, the respected jury, respected doctors, residents, each and every member. Today I am going to present on the dangerous diabetes I am not curable by Dr. Ayushi. Outlook of diabetes. Diabetes is a condition that impairs the body's ability to process blood glucose known as blood sugar. Diabetes research and care through the ages. As has been well established, the Diabetes Care Journal's most visible signature event is the Diabetes Care Symposium held each year during the American Diabetes Association Scientific Session, held this past year on 10 June 2017 in San Diego, California at the 77th Scientific Session. This event has become one of the most attended sessions during the scientific session. For this past year, our 6th annual symposium, I felt it was a time to provide a comprehensive overview of our efforts in diabetes care to determine first and foremost how we arrived at our current state of management. I also felt the narrative needed to include the current status of management, especially with the focus towards cardiovascular disease. And finally, we wanted to ask what the future holds. Towards this goal, I asked 4 of the most noted experts in the world to provide their opinion on the topic. This symposium started with a thoughtful presentation by Dr. J. Schuyler entitled A Look Back as We How Got Here, and Dr. Matthew Riddle entitled Involving Concepts and Future Direction for Cardiovascular Outcome Trials according to National Diabetes American Association. Next. 3 major diabetes types can develop: type 1, type 2, and gestational diabetes. Type 1 diabetes, also known as juvenile diabetes, when the body fails to produce insulin. People with type 1 diabetes are insulin dependent, which means they must take artificial insulin daily to stay alive. But type 2 diabetes affects the way the body uses insulin. While the body still makes insulin, unlike in type 1, the cells in the body do not respond to as effectively as they once did. This is the most common type of diabetes according to the National Institute of Diabetes and Digestive and Kidney Disease. Gestational diabetes. This type occurs in women during pregnancy when the body can become less sensitive to insulin. Gestational diabetes does not occur in women and usually resolves after giving birth. Risk factors for type 2 diabetes are being overweight, family history of diabetes, having a high density lipoprotein, history of high blood pressure, history of PCOS, being of African American, Native American, being more than 45 years of age, having a sedentary lifestyle. Next. Your classical symptoms are polyuria, more than 3 liters of water intake per day, polydipsia, more than 6 liters of water intake per day, polyphagia. It's not a classical symptom as it is not measurable weight loss. For diagnosis, classical symptoms, this renal blood sugar should be more than 200 mg%. For asymptomatic, fasting blood sugar should be more than 126 mg% after giving 75 gram glucose to our value more than 200 mg%. For asymptomatic patient, HbA1c should be more than 6.5%. For normal, HbA1c less than 5.6%. For diabetes mellitus, more than 6.5%. Next. WHO response towards diabetes. Next. WHO aims to stimulate and support the adoption of effective measures for the surveillance, prevention, and control of diabetes. To end this, WHO provides scientific guidelines for the prevention of major non-communicable diseases, including diabetes, develops norms and standards for diabetes diagnosis and care, builds awareness on the global epidemic of diabetes, making World Diabetes Day, conducts surveillance of diabetes and its risk factor. Next. Fast facts on diabetes. For the total diabetes, 34.2 million people have diabetes. Out of them, 10.5% of the US population. For diagnosed, 26.9 million people, including 26.8 million adults. And for the undiagnosed, 7.3 million people. Out of them, 21.4% are undiagnosed. And for pre-diabetic, total 88 million people aged 18 years or older have pre-diabetic. Next. Principle to assess the value of screening for type 2 diabetes are the disease which represents an important health problem that imposes a significant burden on the population, recognizable preclinical stage during which the disease can be diagnosed. Tests are available that can detect the preclinical stage of the disease. The tests are acceptable and reliable. Next. These are the diabetes screening tests. For the test, fasting plasma glucose test for screening the diabetes, 75-gram oral glucose tolerance test has been taken for both suitable tests for diabetes. However, fasting plasma glucose test is preferred in clinical setting because it is easier and faster to perform. Fasting plasma glucose more than 126 mg per deciliter is an indication for retesting, which should be repeated on a different day. If the fasting plasma glucose is less than 126 mg per deciliter and there is a high suspicion for diabetes, oral glucose tolerance test should be preferred. A 2-hour post-load value in the oral glucose tolerance test more than 200 mg is a positive test for diabetes and should be confirmed on an alternate day. Next, frequently asked question, how does COVID-19 affect a person with diabetes? Although having diabetes may not necessarily increase your risk of contacting COVID-19, if you do not get the virus, you are more likely to have more severe complications. If you contact COVID-19, your blood sugar likely to increase as your body is working to clear the infection. If you contact COVID-19, contact your healthcare team and early to let them know. Next. Embrace your lifestyle with diabetes. Next. Eating a diet high in fresh, nutritious foods, including whole grains, fruits, vegetables, lean proteins, low-fat dairy, and healthy fat sources. Avoiding high-sugar food provide empty calories or calories that do not have other nutritional benefits. Refraining from drinking excessive amount of alcohol and keeping less than 1 drink a day for women or 2 drinks a day for men. Engaging in at least 30-minute exercise a day on at least 5 days of the week, such as walking, aerobic, riding a bike. Recognizing signs of low blood sugar when exercising, including dizziness, confusion, weakness, and profuse sweating. Next. In every modern medicine, it is an old advice that prevention is better than cure. First of all, we should inquire about the pathological report related to the patient. We have to manage patient on prevention and drugs. Next. Drugs such as metformin, gliclazide, glimepiride, glibenclamide. Next. Long-term management of type 1. Regulate the amount of carbohydrate intake and give insulin proportionate to it. Insulin replacement given subcutaneously. You can give on anterior abdominal bone, arm, anterolateral aspect of thigh, buttocks. Also, you can give in form of insulin delivery. Insulin pump, insulin pen, inhaled insulin, multi-dose vial plus 1 ml syringe. Next, metformin. For type 2 diabetes, a doctor may prescribe metformin as 500 mg, 850 mg, 1 gram. Maximum dose should be 2.5 gram per day. It contributes to lowering blood sugar, making insulin more effective. Also help in weight loss. Having a healthy weight can reduce the impact of diabetes. As well as diabetes, a person may also have health risk and they may need medication to control this. A doctor will advise the individual about their needs. Next. Conclusion. Diabetes is frequently not diagnosed until complications appear, and approximately 1/3 of all people with diabetes may be undiagnosed. Although the burden of diabetes is well known, the natural history is well characterized and there is good evidence for benefit from treating cases diagnosed through usual clinical care. There are no randomized trials demonstrating the benefit of early diagnosis through screening of asymptomatic individuals. Nevertheless, there is sufficient indirect evidence to justify opportunistic screening in a clinical setting of individuals at high risk. Also, clinicians should be vigilant in evaluating clinical presentation suggestive of diabetes. Thank you.
Thanks, Dr. Ayushi. Our experts, if you have any questions to Ayushi. Thanks, Ayushi, for taking us through your talk. It gives me immense pleasure to invite our next speaker for the topic Science of Wound Healing and Hyperbaric Medicine, Ms. Brooke Cobb, Chief Operating Officer, Innovative Healing Systems USA and India, Program Director, Wound Healing Institutes. Ms. Brooke, over to you, and we warm welcome you.
Good morning, everyone. How are you? Can you hear me okay?
Yes, very much.
All right. Thank you for the opportunity to present with you guys this morning for me and this afternoon for you here from the United States. I'm the Chief Operating Officer of Innovative Healing Systems for our US and oversight of our India programs. Our objectives today are really to just establish the difference between traditional wound care and evidence-based practice and recognize what a chronic wound is and how we move that chronic wound back into an acute phase so that we can heal our patients and have limb preservation. Some of the advanced modalities in wound care include biologics, negative pressure, growth factors, total contact casting, and hyperbaric oxygen. When we talk about the difference between traditional and evidence-based practice, we really want to think about what is current evidence-based practice, and not just what we've seen in expert opinion, but really what do the studies show and how does that impact the care to our patients, and making sure that we incorporate this evidence-based practice into our daily practice in our wound care centers. We always like to share this slide just to say we put the cart before the horse, or you have to put the boat in the water, right? First, not the truck. Here we talk about those 3 phases of wound care and how we get the wound to heal, right? We have the inflammatory, the proliferative, and the remodeling phase. In an active normal wound, we have the metabolic active cells. We have increased growth factors and appropriate levels of pro-inflammatory cytokines. In a normal wound, you're going to see hemostasis, and then into the inflammation stage, proliferation, and then remodeling, where you see the scar tissue. Where in a chronic wound, you're going to see inactive cells, decreased growth factors, and that causes this inflammatory response and phase to be prolonged. And what do we have to do for that? These chronic wounds are anything from pressure ulcers, venous ulcers, but today you can read through those. We're going to talk specifically about diabetic foot ulcers and how do we get that wound from that chronic phase with the extended inflammation back into an acute phase. And why does that happen? We have repeat trauma, ischemia, bacterial contamination, and swelling and edema. When we look at the schema of the chronic wound, you're going to see that we have stuff here on the left that we want to get rid of all the things on the right so that left side can come across and heal those patients. And really getting back to this little diagram here where we're talking about how do we get it back into the acute phase. The pathophysiology of the diabetic foot ulcer, we really see here where atherosclerosis and peripheral vascular disease are going to affect the patient's ability to have the oxygen that is needed at the site to heal those wounds. Right? And at every stage of the wound, we're going to see that oxygen is limited. And that's what we have to impact. You can see here in this diagram where the green arrow is, where it really shows that's where our parasympathetic and our sympathetic is shunting blood away from these small vessels. And when you shunt blood away, you decrease your oxygen and your oxygen tension at the wound site. And then what is affected, right? So back to the different stages of wound care and the wound healing phase, all of those are affected. So when we talk specifically about our diabetic patients in India, we talk about the highest number of diabetic patients as of 2019, right? Greater than 75 million Indians are dealing with diabetes. And 1 in 4 of them will develop a diabetic foot ulcer in their lifetime. And there's a reoccurrence of greater than 50 to 70%. So what can we do? 1, we can educate, right? Teach all the great things, nutrition, proper foot care, all of those things. But here we're talking about debridement. This can be done by a surgeon or somebody who is surgically trained. There are different kinds of debridement, and our goal in debridement is really to remove any overlying skin, necrotic tissue, and get that wound back into a acute phase so that we can get it back into through the inflammatory stage and back into the proliferative stage. We also need to do offloading. We talked about that trauma and edema. Offloading can help us do that. You can see here the pressure in the foot changes, and you don't need all the fancy technology necessarily. You can do this with good inspection. And we have the different types of offloading devices. And you can see here in the center, we have the total contact cast. That is our evidence-based practice, right? Putting a total contact cast on to do the offloading to prevent pressure, edema, and increased swelling. So things to consider. If we don't get to that 4-week healing threshold that we're really looking for through the total contact casting, nutrition and debridement and other advanced, maybe possibly biologics or negative pressure, what do we need to do next? This is where hyperbaric oxygen comes in. And in hyperbaric oxygen, they are breathing 100% oxygen under pressure. This is increasing that oxygen tension that we talked about earlier, where it's limited in all phases of care with the diabetic foot ulcer. It's absolutely needed for normal wound care, wound healing, and you're going to just see such a rapid increase in healing when you add hyperbaric oxygen because of the increased oxygen at the tissue level. What are some of the benefits? Collagen deposition, angiogenesis, bacterial killing, the edema reduction. When you increase with oxygen, we know that it decreases that inflammatory response. We use hyperbaric oxygen in our programs in the United States and in India under these specific 14 criteria. We do not do off-label diagnosis. Today, obviously in the yellow, we're specifically talking about the diabetic foot ulcer and necrotizing infections. We are supported by CMS, Joint Commission, and the Undersea and Hyperbaric Medical Society. Who's at risk? Here we know the diabetic foot ulcer, especially those that's longer than 30 days to heal. And then we classify that through a Wagner 3, looking at a diabetic foot ulcer that has a cellulitis, an abscess, or an underlying osteomyelitis or greater with localized gangrene or extensive gangrene. Here's a patient that underwent advanced modalities with debridement, hyperbarics, with a necrotizing wound and went on to heal. We do have 3 local programs in the metropolitan areas in India. And thank you for the opportunity to present with you guys this morning.
Thank you so much, Brooke. It was very interesting and enlightening session. And it's really enriching to know that India is also part of your data generation and the device treatment. So great. If our experts have the questions to Brooke, that will be of help. Anyone from the experts? So Brooke, just to take little one step further, you said, if you could just go back to your previous slide wherein you showed the Indian centers, and if you could share your experiences there in Indian setting will be of great help. I think you are on mute.
Can you see my slide?
No.
Oh, sorry. Apologize. All right, so if we go here.
Yep.
Okay, so one of the things that we really see is that we impact families, right? We impact the patient, the family, and how that changes the projection of their life. Because if we preserve a limb, we provide that person the chance to go back to work or to provide for their family. And we also prevent the fact that the family is going to have to change their course of working to take care of someone. So it's so nice to see, one of the things that, as a nurse, as a previous professor of nursing, and in the COO role here with Innovative and over in India, we just see the impact to the patient and their family. And, wounds are chronic. And these patients deal with them for a very long time, many times before they come to us. And when they come to us and we have the opportunity to change their activities of daily living, taking care of their family, it decreases depression and it just changes the trajectory of their life.
Great. So aerial activity living is the improvement that you could witness very quickly, right?
Absolutely. Absolutely. Yeah. Because when you have function to your life, it changes.
Yeah. A great gain, actually. Dr. Patel, do you have a question?
I really appreciate that what the care they are looking after and the things around. The question is when they are talking about the infrastructure, what they are putting forward. So what is the primary cost of one infrastructure setting and what could be the cost of one limb for the whole, how many sessions and for the one session of the same?
So one of the things that we like to think about is that we would like you to refer the patient. The only cost would be to the oxygen, right? We would work with the referring physician. Our team in India will work with the referring physician to make it almost no cost, just the oxygen. We have oxygen tanks there in the center.
You can be specific. What we are talking is innovations, and the innovations is based on the necessity. So how can we reach to the maximum people out there? That is a question. And when we are talking about India or the developing part of the world, then what we are focused is how we can cover the mass. So for mass, what are the numbers you are speaking about? That is what the specific question is.
So the specific questions would, I guess the specific answer would be that we want to treat all in the community. So I don't have a specific number necessarily for you, but there is no limitation to what we treat. We can treat up to 7 to 10 patients a day in the hyperbaric chambers because they are monoplace chambers and they can be individualized care. In the wound care side, we can treat up to 30 to 50 patients a day.
Thank you. Yes, to the time constraint, we can move
Thanks.
the further
Rajesh
questions.
also has one question. Rajesh, if you can ask, please.
Yeah, thanks, Brooke, for the nice presentation. How much time patient will take for the, I have two questions. One, how much time patient will take for healing with the addition of hyperbaric therapy? Number one, and you answer this first.
So I guess our goal is always to get patients to heal under 12 weeks. So with a hyperbaric treatment, they get 5 days a week, and they're in the treatment for diabetic foot ulcer for 120 minutes. And then that's 5 days a week consecutively. They should heal. Our goal is to have them healed in 5 weeks.
Okay. And in India, how many patients you have treated so far on this?
So we've been in practice there in India for 9 years. 10 years. And sorry, in 9 to 10 years. And we've treated over 100 patients easily.
Over 100?
Yes.
Dr. Shah is on. He might be able to answer some of those questions. He's local.
Yeah, definitely. Dr. Rajesh, it's like we have treated more than 100 patients at all our centers. Like, it's located at major cities at Mumbai, Delhi, as well as Ahmedabad. So it's more than 100. Yeah, definitely. And
Because
next question,
in 9 years, 100 patient is too less.
So that was I was asking for. The concern is really about the workability and the we would see on the innovations. Yes, the cause work what you have done, we really appreciate. But how we can reach it to the mass and make it to the viable and workable to the community, that is what we look for. So can we move to another session, please?
Yeah.
Exactly. My question was related to Dr. Yash's question only, reaching to the masses. That's why I asked you the next question, the number of patients and all. Thank you, Yash. So why means I want to understand what is the limitation? Why so less patient? Means is there more effort needed in popularizing this, or what is the challenge you are facing?
Yeah, definitely. Like basically what we are facing is basically it's a tertiary care. So usually if any patient goes to a diabetologist or a general surgeon, they usually go with that line of treatment, and eventually when there is no non-healing wound, he would be suggested for HBOT. We are trying to promote by ourselves with other means, but obviously we are trying to create that awareness. But obviously eventually it depends on the physician also. When we talk with the physicians, they tell us directly that they do have read in the books, but they want to go for like at previous level with some antibiotics and some dressings. And eventually when they come to know there is a non-healing wound or ulcer, they suggest that you can go with HBOT. So that is one of the main reasons.
Okay, so there it is getting reserved as last line of therapy.
Yep.
Okay. Yes, bhai, any comment from your side?
So we have another session from them only. The next seems to be from the same group. Let's evaluate and build up for the same. Is it the same?
Sure, sir. Yeah.
Thank you. Thank you so much, Brooke, for an interesting presentation. It was a pleasure to have you here with us. Thank you.
Thank you.
Our next session is delays in reaching specialist foot care lead to poor outcomes. Yes, of course. So for this, we have Dr. Annie Phillips with us, Associate Professor in Diabetes, Ideal Diabetes, Birmingham. Over to you, Dr. Annie.
Thank you. I'll just share my screen with you. Okay, thank you very much for inviting me today on behalf of my colleagues who work for Ideal Diabetes. Time is tissue, and we know that very clearly, and particularly from Dr. Cobb's presentation, as we've just seen. Delays in reaching specialist care are something that we became very passionate about. We're a multidisciplinary group of people working within diabetes in specialist roles, but also we involve people with diabetes to hear their viewpoint, to get a 360-degree point of view to our work. So we know there are three main problems when people with diabetes develop a foot problem. Whether they are aware they have a foot problem, whether the healthcare professional is aware and makes a decision to refer or not to refer, and particularly delays during the referral process. So delays relating to a person with diabetes, which can reduce access to specialist care, but also obviously deterioration in the wound, is that maybe people don't recognise that they have a wound, particularly if they have neuropathy and can't feel the wound. And delays occur because of failure to recognise this, but also the lack of appreciation of how important or how serious it is. And if we haven't been able to provide education into populations, people with diabetes often have not been advised what to do accordingly and how to receive help. Delays with healthcare professionals might be that they have a delay referring to specialist care because they're unable to also make a diagnosis. And also healthcare professionals may fail to recognise infection or ischemia, particularly in the absence of pain because of neuropathy. And delays can result from difficulty in access. Maybe this is due to reduced communication. This is a difficulty in referrals. It might be reduced access to specialist care because of a lack of multidisciplinary foot care teams, or people, particularly healthcare professionals, lacking the education that is so essential. So the way forward is ideal. We decided that we needed rapid recognition of a problem by people with diabetes and also rapid and informed assessment by all healthcare professionals. So the ideal group is Insights for Diabetes Excellence, Access and Learning, and we're an independent multidisciplinary team of experts. We're aiming to improve diabetes care across the UK, but also internationally, but also to improve foot care and education to try and reduce the number of major amputations with people with diabetes because they are completely avoidable. So the Act Now acronym really came from direct input from a person with diabetes who had experienced foot ulceration. And ACT Now, and I'll go through what this means, is designed to help recognise the warning signs that might lead to an amputation and prompt urgent referral to specialist care, but also to provide clarity of referral pathways, particularly from primary care and community care, to promote rapid access to multidisciplinary foot care teams, particularly with people with feet at high risk of ulceration. So this is ACT Now. It's really picture graphic to say, had the person sustained an accident? Is there a change in temperature or colour? Is there a change with new pain? Is there any oozing that occurs? Is there an actual wound? And that forms the Act Now. So this is the assessment tool, and this is where A is for recent or history of an accident or trauma that might be missed because of concomitant neuropathy, particularly if there's a change in the shape or swelling of the foot, particularly if there's suspected Charcot, for example. Temperature is very indicative of potential infection, and we know that infection can spread very quickly in people with diabetes. And from the presentation of an initial wound that gets infected to the point of an infection and an amputation can take as little as 5 days. Is there new pain present? Is it localized? Is it generalized? Is this infection? What color is any exudate? Is it potentially infectious? Is it bloody? And is there any odor? And also to document the size of the wound, the shape and position of the wound. And anybody can fill this checklist in, either a person with diabetes, a carer, a community worker, or a healthcare professional. So our message is act now, do not delay. And if any of these things are present, then refer for specialist assessment. ACT Now has had many endorsements and awards, and we've been exceptionally lucky that we've been endorsed by the Royal College of Podiatry, the International Diabetes Federation, DFOOT International, Primary Care Diabetes Society, Diabetes and Research. And we also won an award for innovation at the recent Diabetes UK annual professional conference. And it's important to recognise these endorsements because it validates the adoption of Act Now and Act Now across communities. So delays not only result in poor mobility, but also mortality, but we want to try and prevent unnecessary amputations. And we feel that the present situation has resulted in an unacceptably high number of suffering for people with diabetes, but also major amputations. So we feel that if healthcare professionals and people with diabetes and their carers and families can act now and refer quickly, we can save feet. So as ideal, we would really like everybody to adopt and use the Act Now checklist and really have a profound impact to reduce the effect of potential ulceration with people with diabetes, to have timely assessment and referral for effective evidence-based treatments as required. We have a number of resources available to you, and this is the website to access these. And we would really encourage you to be able to access these resources, use them, download them. They're all available free of charge for everybody to use to try and share the message about acting now. Thank you very much for your time today.
Thank you so much, Dr. Annie Phillips. It was a great presentation, great tool, and the checklist to prevent the fatalities that can be prevented. Great. Do we have any questions from our expert side?
Dr. Anne, your
Hello.
proposed your proposed system of Act Now factors, like you are proposing 6 factors like the checklist to improve the overall healthcare system related to the diabetes. So what has been your outcome and what is your result so far that you have obtained based on this?
We organise this assessment checklist to make it as easy to use as possible. And we wanted to involve as many people with diabetes as possible to alert their knowledge and information about checking foot checks, and also in particular thinking about access for their own health to self-promote and self-refer as required. The adoption worldwide so far of Act Now has left us feeling very impactful, because we know that Act Now is being adopted by communities, it's being adopted by various healthcare professionals and also people with diabetes. And we want as many people to be able to have access to Act Now, to be able to promote early referral. And as you could see from the slide of the endorsements we have, many are international, particularly the International Diabetes Federation, for example. So we know that Act Now is being rolled out and endorsed accordingly, which is exactly what we want it to do.
Yash, you have a question?
Yes, Dr. Anna, really wonderful presentation. And being part of DFOOT International, we know how Act Now has been taken further level, and all associations, recognitions, and all are part of it. I have one concern on that aspect, that the concept is based, how we instrumentalize and reach to the last zero level of the developing world or underdeveloped world. What is the vision behind the same, or how we can make it?
What we're hoping is, obviously it's printed in English at the moment, but it has been adopted in many European and international countries, and the pictorial images are what we want to promote rather than the words. The message is still there, but we want in every community to be able to have access to Act Now, and pictorially to be able to see the impact also. And that's one of the reasons we tried to keep it as easy to use as possible, so people could literally just see it, pick it up, trigger a thought to think, right, I now need to act now. And we've had feedback from many international countries that they found they have translated it, they've kept the pictures the same, and it is having an impact in their local communities. And that's exactly what we wanted it to do as Ideal Diabetes.
Wonderful. So it is one of the awareness tool and handy tool to look for, and how we can make it to the preventive aspect. That is what you are building onto. Really appreciate it. Thank you.
Pleasure.
Thank you so much, Dr. Anne Phillips, once again to be with us. It was great pleasure indeed to listen to you. Thank you so much. Let's move on to the next talk, that is peripheral neuropathy assessment of diabetes patients using perception of vibration. This will be given by Dr. Ms. Darshana Darji, Government Engineering College, Gandhinagar. Ms. Darshana, over to you.
Yes. Hello everyone, myself Darshana, and my topic is peripheral neuropathy assessment of diabetic patient using perception of vibration mechanism. So first is what is
Darshana, put it
yes,
on slideshow mode.
okay. I did not get the option. Just a second.
Press F5.
Hello, Miss Darshana.
Yes,
If you can share the screen, we cannot see the screen.
yes, just a second. Now, okay.
Perfect. Please go ahead.
Okay. So myself Darshana, and my topic is peripheral neuropathy assessment of diabetic patient using perception of vibration. So outline. Let's start with introduction. What is diabetic peripheral neuropathy? Peripheral neuropathy is nerve damage caused by chronically high blood sugar and diabetes, and it leads to numbness, loss of sensation, and sometimes pain in your hand, feet, and legs. It is the most common complication of diabetes. The symptoms of peripheral neuropathy. These are the symptoms of peripheral neuropathy like tingling, stabbing, numbness, muscle pain. And these are the diagnosing method for detecting diabetic peripheral neuropathy. The first one is 10-gram monofilament. Second is tuning fork. The third is biothiometer. Limitation of existing technique. 10-gram monofilament. First one is fabricating fault and atmospheric effect. Second is tuning fork. The method variation. The third is biothiometer. This technique takes too much time, and biothiometer is more expensive instrument. So my problem statement is patient with diabetes are at greater risk of complications. The most important them are diabetic peripheral neuropathy that lead to foot ulcers. So early detection helps better prevention. So aim is to detect diabetic peripheral neuropathy of diabetic patient by using perception of vibration mechanism and to determine the level of diabetic peripheral neuropathy. So our proposed idea is we develop a standard new accessible vibration sensation mechanism by representing tactile platform using vibration motor. We designed two tips, and two tips are settled in a tactile platform. And patient places index finger on the tips in such a way so that two tips covers by the first joint of index finger. Variable amplitude and standard 128 Hz frequency generated to drive the vibration motor. And tactile stimuli are generated up to the 15 seconds from higher amplitude to lower amplitude. to detect diabetic peripheral neuropathy. And tactile stimuli are presented with the help of start button and asked to patient to report when perceived vibration fade out. When patient indicate vibration have faded, then push the stop button and time in second will display on display screen to determine the level of neuropathy. And on the basis of time period, level of neuropathy can be determined. If suppose patient cannot able to feel the vibration between 0 to 1 seconds, then they have a severe sensation loss. If patient cannot able to feel the vibration between 1 to 6 seconds, then they have a moderate sensation loss. And if the patient cannot able to feel the vibration between 6 to 9 seconds, then they have a mild sensation loss. And if the patient cannot able to feel the vibration between 9 to 50 seconds, then they have no sensation loss. Means patient is normal. This is the block diagram of our proposed idea. Placing finger on the tip. This is the circuit mechanism. Providing vibration to the finger up to the first joint and ask patient for the response. And according to the patient response, the level of neuropathy can be determined. We provide a vibration to the hand. The reason is receptors are densely distributed in human fingers, especially in the tip of the fingers. And fingers are more sensitive to various kinds of stimuli. And Pacini and corpuscle receptors has a sense modality of a vibration. And, this is the difference between existing technique and our proposed idea. In our proposed idea, we have only one mode to detect level of diabetic peripheral neuropathy. We are using standard 128 Hz frequency. Our device provide level of neuropathy. We design our own tip to provide tactile platform, and we use coin vibrator. This all are work done by me. Frequency decision, hardware component, and all that. These all are the hardware components used in our mechanism. AVR microcontroller, vibration motor, LCD display, and all that. Software used in our mechanism is Arduino IDE and Autodesk Fusion 360 Eagle software. So we design a different type of tip to provide vibration on the finger, in which thickness of all device equal to 3 mm. We design 10 mm tip, 12 mm tip, and 18 mm tip. And we finalize 1 mm tip to provide vibration on the finger, as it has no vibration loss over the tip. This is the printed circuit board of our device. This is printed circuit board assembled with the all electric component. And this is the case design in Autodesk Fusion 360. First one is top part of the case design, and the second is bottom part of the case design. This is the final device. A patient places index finger over the tip, and we press the start button to provide the vibration. When patient indicate vibration have faded, then stop. We press the stop button, and time will display on display screen. And according to the timing, level of neuropathy can be determined. This is the frequency graph of our mechanism. We use standard 128 Hz frequency to detect diabetic peripheral neuropathy. This is the vibration output in terms of voltage versus time. We are providing higher amplitude, that is 1.2 volt to 1.2 volt to 0 volt to lower amplitude 0 volt up to the 15 seconds. This is the graph of voltage versus time. We have collected data of 54 diabetic patients and 8 non-diabetic patients from Swasthya Diabetes Care under the observation of Dr. Yash Patel. And this is the data of diabetic male patient. And this is the classification graph of male data. This is the data of diabetic female patient, and this is the classification graph of female patient. This is the data of non-diabetic patient, and this is the graph of non-diabetic patients. So inference from all graph is generally patients with diabetes from less than 5 years are classified as mild sensation loss or normal. Another conclusion is patients with diabetes from more than 5 years have moderate or severe sensation loss. Another important point is HbA1c test result. Patient with diabetes less than 5 years and HbA1c test result is greater than 9, then they have a moderate sensation loss. Comparison of male and female classification. So in our database, number of patients with moderate neuropathy is higher in male group compared to female group. Number of patients with no sensation loss means normal is higher in female group compared to male group. And number of patients with mild neuropathy are almost equal in both groups. So the conclusion is we measured a decreased level of actual sensation of the finger tip of the index finger and try to determine the development of diabetic peripheral neuropathy on the basis of time period. And future work, a number of tips will be increased to check the sensitivity of diabetic patient. Second parameter that we can take into the consideration is vibrator by changing the vibrator and making the mechanism miniature and compare the result with current technique. And another parameter that can be added is area of index finger to check the sensitivity of tactile sensation of diabetic peripheral neuropathy. These all are the components used in our mechanism: vibration motor, Arduino board, power supply, circuit, and all that. References. Thank you.
Thanks, Darshana. Very good presentation and insights from the data. Any questions from the experts?
What is the sensitivity?
Sensitivity means have a patient able to feel something, anything.
No, but the data sensitivity, suppose if you are testing 100 patients of diabetic neuropathy, in how many patients you have identified positive results?
I got the data of 54 patients only.
Can I add on that, Dr. Anand? Wonderful questions. And as it was under observation of ourselves, what we saw, the parameter of measuring the neuropathy was legacy in the time duration, not compared to the voltage. So those both matching the efficiency of the sensitivity and specificity. So when this is specificity, that was something in the question, but the sensitivity is much more 100% to near to 98 to 100%.
Okay,
and
nice.
That was also in the upper limb. The lower limb, we are not able to make it to, but in the upper limb comparison to the voltage to the legacy was matching out. In the specificity, we are talking on sensitivity, not the specific. Yeah.
Thank you.
Wonderful question. And thank you for asking that. What other base thing they have done is they have made the instrument from the minimal cost usage and working on how to make it to the replicable level. So beta testing to the replicable level. And that is where, and this is one of the, I would appreciate that conference has given the opportunity to present the engineer person to present in the medical as well as innovation.
Yes. Thank you so much.
Thanks, Dr. Anand. That was a great question.
We can ask even Darshana, if you can share till time, what cost or what have you invested in beyond your time, your efforts, your graduation degree? What is the fund you have invested till time in the instrumentalization the device? Yes.
So around 7,000 to 8,000 only.
And if we can get the response from the professor, that what is the scope of this replication to replicate in a short duration?
Uh, well, Dr. Yash Patel and other doctors, I mean, we are thoroughly working on it now. I mean, I'm happy to announce and news that we have got a research fund to make this project and like to develop this product from the Department of Science and Technology, Government of Gujarat. And we are thoroughly working on the like the validation of the each and every component associated with this, and the like the I mean, one of the doctors, I mean, Dr. Anand, who said the voltage and the frequency component identification and their validation, because that is the most crucial part, and the kind of fabrication that we are supposed to develop over this tactile platform, because we'll start with the one tactile tip, two tactile tip, and we are planning to develop around 8 to 10 tactile tips which can cover the entire index of I mean first joint index, so that we provide this vibration stimulation to all over those areas, and we would like to measure the neuropathy level. So right, I mean, and of course, I mean, particularly once, I mean, now we have the fund to make this project, so we would like to go with as much as accurate components of electronics and vibration motors and like the fabrication, which was earlier costing us a lot, but we at that time we tried to like reduce the cost, but now we have the fund, so we would be able to make it in a more sophisticated and more validated way with the help of Dr. Yash Patel, and of course we'll have the EQDC, like the Electronic Quality and Development Corporation validation over. So certainly,
yes. So I would just add on that what cost you are talking is in the dollar to understand the all available faculties as well as the delegates around. The total cost on the I'll say the instrumentation spared in the, I'll say the resource, the material is less than 100 US dollars.
Absolutely.
Yes, yes.
Absolutely.
And
Yes.
what you are looking forward is not only the upper limb, the lower limb, and the generalized sensation. And the vision is to build up not the time lag, but from the mitochondrial level, what can be possible.
Possible. True. Yes.
Wonderful work.
Very true.
Any questions, please?
Any question?
Great insights, Dr. Yash and Professor Dave. This looks like indigenously developed device, and in near future, what are your plans for getting the marketing authorization of this?
All right. I mean, okay. So I mean, so far, I mean, I'm planning to extend this research because I want to incorporate, I mean, to other factors with these studies, like the electromyogram study of the same patient and the nerve conduction velocity of the same patient, and would like to propose an AI-based system where we could identify this neuropathic level at an early stage, and we can propose a pharmaceutical and non-pharmaceutical solution at an early and accurate stage. That is what our idea is. But of course, I mean, with the help of Dr. Yash Patel, we can identify the upcoming market capitalization and other things. I mean, but as of now, we propose. I mean, I would like to work intensively in a detailed way regarding like EMG electromyogram study and the nerve conduction of sensory and motor nerves for those.
So to make it to understandable to general all the audience around, what he is talking is to make it the machine more into the specificity. Okay, the detection early is possible, but how specific it could be, that is where we would like to work for. Yeah.
Great, Dr. Yash. Thank you so much, Darshana, for a wonderful presentation. And we move on to the next talk by none other than Dr. Yash Patel, Director, Consultant Diabetologist, Swasth Diabetes Care, All India Institute of Diabetes and Research. Dr. Yash Patel, over to you.
Good morning, good afternoon, and good evening. Today, I am presenting Project Shravan as an All India Institute of Diabetes and Research Institute, as well as from Swasth Diabetes Care Group. As an All India Institute of Diabetes and Research, we do plenty of activities which involves mass training, doctors training, healthcare providers training, even type 1's empowerment and training as a Make My Life project. Conquer Diabetes project is empowering the individuals from reaching to from inside to out. Even diet exhibitions to lifestyle modification camps, even training their pregnancy individuals or the pregnancy take care providers or Anganwadi workers to the school teachers. I am today presenting one of our projects, Save a Leg. So Save a Leg project where we train diabetic friends to how to take care of their friends for preventing the getting to feet ulcer, how to wash it, how to take care, how to swipe it, how to cut nails, what footwears to be wear or how to wear socks or put on the socks. Such kind of activities had been doing regularly. Though we train the diabetic friends also as well as the doctors also, still the outcome of this project was limited. What we see the data as the International Diabetes Federation as well as DFood International, every 22nd one leg is amputated all over world due to diabetes, and such a high magnitude is there. So the impact is such high, but still we feel that we have been not working up to the mark. In that note, I am sharing a Chinese saying also. What it says: the inferior doctor treats the full-blown disease, the mediocre doctor treat the disease before evident, and the superior doctor prevent the disease. So where we are as a consultant was a real question. Taking in that frustration ahead, when we observed one of the Harvard paper, which showed that every friends with diabetes was accompanied by one of their friends, family members, or their take care providers. In that note, we found out Indian mythological story also, which was showing that Shravan, who was one of the mythological character, who was taking their parents' care at utmost. He was carrying their parents in such an extent that he is a representation of parents' care. In that note, we identified Shravans from the community. So these Shravans were unique people who were accompanying the friends with diabetes or their family members, who were willing to take care of their parents or grandparents or gurujis or friends fit when they go through the diabetes care. So they regularly took care of the feet. We are training those Shravans, we are empowering those Shravan, and we monitored that how they do it. So this was Project Shravan, was one of the extension of Save a Leg project where we trained the Shravans. We did first ritual of Project Shravan was specifically focused that each friends with diabetes were paired with their take care providers or care providers, in which the Shravans were trained, empowered, and here we see the photos of that first ritual where 5,000 people participated. 108 pairs were generated from the community where the Shravans are taking care of their parents or grandparents, where the specific medical step of feet care was narrated from the speaker, followed by Sanskrit sloka related to that medical step, and its vernacular translation were created and generated to the whole audience. This ritual was for 8 minutes and it is available on YouTube also. Here I am sharing some of the photos for the same. Even in this ritual, one unique trio pair was there where the grandmother's feet were taken care by her son, and her son pair was taken care by her granddaughter. And this is one of the unique presentation of that. Herewith I am sharing those Shravans projects further extension. So what happened? These Shravans were so motivated, and they even empowered and trained other Shravans also. They were enrolling Shravans, and there are unique Shravans who have empowered and trained more than 50 Shravans under him. So these Shravans were taking and performing rituals all over globe, and such rituals till time had happened 132 in this last 6 years. So specific ritual where the pairs of the Shravans were brought in, followed by Sanskrit sloka and the vernacular translation in that medical steps. Till time, there are documented 3,568 Shravans who are under this project, and they are taking care of their diabetic friends. Even our Prime Minister, Mr. Narendra Modi, also represented such extension of Project Shravan in one of his project also. To the further note, one of our faculty, Dr. Christian Weinecke, who is renowned diabetologist from Denmark, she was so empowering that she nominated Project Shravan for her photo competitions, where she put a photo of her competition, and she narrated that if this photo wins in the competition, then the prize money would be donated to Project Shawan. And with all of your support, the photo won the first prize all over globe in e-voting, and that prize money was donated to Project Shawan for empowering the Shawans and to take care from them. Even the Indonesian schools, where on the Mother's Day performed the Project Shawan ritual, where the children were washing the feet of the mother and quoted the Project Shawan for preventing the feet and the taking care of the feet in those individuals. I really appreciate all of your supports, and thank you for making this Project Shawan is one of the empowering project for innovations. So as a Project Shawan, what we represent is an innovation for team building in diabetes care, where community is involved in the by and through enrollment conversations of diabetic food care. Thank you all of you, and we invite you to join Project Shawan as a Shawans to take care of your diabetic friends. Thank you, everyone.
Great talk and really unique project, I must say that, and so well connected and related to our mythology. Dr. Yash Patel, kudos to you and the team.
So the funda behind, the funda behind was the same only. How we can generate the community project, cost-effective, preventable project, and to enroll to the mass level to take it to the further level.
Great, great, great. So any questions anyone has from the experts to Dr. Yash Patel on this? If no, then it was self-explanatory. Let's move on to the next talk, which is effect of overt diabetes and gestational diabetes mellitus on pregnancy outcomes and progression by Tausif Nabi, Srinagar. Dr. Tausif, I'll hand over to you for your talk.
Is my screen visible?
Yes, please.
Good afternoon, dear respected chairperson, judges, and delegates. I thank the organizing committee for giving me the opportunity to present my paper, which is on effect of over diabetes and gestational diabetes mellitus on pregnancy outcome and progression. As we know, GDM is defined as a diabetes diagnosed in second or third trimester of pregnancy and is not either pre-existing type 1 or type 2. The International Association of Diabetes in Pregnancy Study Group defines over diabetes as pregnant women who meet the criteria for diabetes in the non-pregnant state but were not previously diagnosed with diabetes, while as WHO gives the term diabetes in pregnancy for this over diabetes. Over diabetes during pregnancy represents a severe form of diabetes. The differential diagnosis between over diabetes and GDM during pregnancy should be performed because these are distinct clinical conditions. Women with over diabetes in pregnancy are at higher risk of reproductive and subsequent metabolic derangement, and early identification will improve health outcome with the help of both preventive and intervention strategies. So studies have focused on women with over diabetes on pregnancy outcome measures from the Indian subcontinent are scarce. While the other studies from rest of the world, there were some of the limitations that all of the studies were retrospective, and they have also included pre-gestational diabetes mellitus in this. So this has not given the clear picture. So the aim of the study was to study the clinical characteristic, outcome, and incidence of postpartum diabetes in women with over diabetes and GDM. This was a prospective cohort observational study of GDM patients. We recruited 178 consecutive patients with GDM diagnosed after first trimester. Subjects were divided into two groups of patients who had GDM and patients who had over diabetes. The study duration was 2.3 years. Various demographic clinical variables, fetal maternal outcome were recorded. The postpartum glycemia was determined at 1 and 6 months. GDM and over diabetes was defined as by ADA definition, which gives that after 75 grams of oral glucose tolerance test, if fasting is more than 92, 1 hour more than 180, and 2 hour more than 153. If any one of the above value is more, then we label patient as gestational diabetes mellitus. And over diabetes was defined as blood glucose fasting more than or equal to 126, 2 hour postprandial more than or equal to 200, or HbA1c more than or equal to 6.5. Eligibility criteria include all the subjects more than 18 years of age diagnosed as GDM as per American Diabetes Association criteria. We excluded patients who had pre-GDM, GDM diagnosed within the first trimester, that is less than 12 weeks, patients who are suffering from chronic systemic diseases including essential hypertension, drugs, patients who are on the drugs like which can alter the glucose metabolism like steroids, and medical or surgical conditions that can affect the glucose metabolism. The study was approved by the Institutional Ethical Committee, and informed consent was taken from all the recruited subjects. The detailed study design include that we took all their clinical parameters, which included their anthropometry. We took the history, obstetric history. We did the clinical examination. Then we assessed the maternal outcome, which were assessed were gestational hypertension, preeclampsia, eclampsia, preterm delivery, antepartum and postpartum hemorrhage, while the neonatal outcome, which were assessed by the route of delivery, fetal birth rate, small for gestational age, large for gestational age, NICU admissions, hypoglycemia, spontaneous abortion, and stillbirth. Then the various parameters, biochemical parameters which were done were CBC, KFT, SMBG, and HbA1c. Ultrasonography was done for fetal well-being, amniotic fetal index, and fetal weight. Treatment, all the patients in the both groups were treated with the standard care of treatment like lifestyle modification, which included diet and exercise. If they were not controlled, it was followed by metformin and or insulin. Postpartum glycemia was determined at 1 and 6 months using 75 gram OGTT as per ADA criteria. These were the various definitions which were used in the study. Statistical analysis was performed by SPSS. Coming to the results of the total 219 patients, the end result was we had 178 patients. We excluded 41 patients. Over diabetes was present in 32 patients. GDM was present in 146 patients. This is the table showing the baseline clinical and biochemical parameters of the subject with over diabetes and GDM. We can see the age was significantly higher they were older in over diabetes. They had pre-pregnancy obesity, higher weight. They had gestational age diagnosis was lower in case of over diabetes. While family history of diabetes, previous history of GDM, and obesity in pregnancy was also significantly higher in over diabetes. Similarly, history of PCOS, signs of insulin resistance, need for insulin treatment was again significantly higher in over diabetes. Glycemic parameter, as we know, over diabetes will have a higher glycemia, which was seen by higher blood glucose values at fasting 1 hour, 2 hour, and HbA1c at all levels. Coming to the maternal outcome, we did their HbA1c before delivery at 36, 37 weeks. You can see HbA1c over diabetes before delivery was 6.2. In GDM, it was 5.7, which was statistically higher in over diabetes. Although the glycemic goals of less than 6% was achieved in 78% over diabetes and 90% in GDM, but it was not statistically significant. Similarly, was the goal of less than HbA1c 6 as laid by ADA criteria. In the maternal complications, only the gestational hypertension was significantly higher in over diabetes as compared to GDM, while the other maternal complications of preeclampsia, polyhydramnios, preterm, antepartum, or postpartum hemorrhage were not significant. Coming to the neonatal outcomes, we can see large for gestational age babies were significantly higher incidence in over diabetes. There was a higher incidence of neonatal hypoglycemia within the first 24 hours, and spontaneous abortion was also higher in patients subjects of over diabetes. This is the postpartum glycemic status of the 178 patients. 148 patients followed at 1 month. That's around 78% patients, and 126 out of 178 followed at 6 months. That's around 70% subjects. You can see postpartum diabetes was significantly higher in subjects with over diabetes, that is around 15% versus 3.5%. And similarly, at 6 months, it was again significantly higher in subjects with over diabetes as compared to GDM. So there were around 18% subjects women with over diabetes as compared to 82 subjects with GDM. Women with over diabetes while older had higher frequency of pre-pregnancy and maternal obesity, family history of diabetes, previous history of GDM, polycystic ovarian syndrome, signs of insulin resistance and need for insulin treatment. The prevalence of gestational hypertension and frequency of spontaneous abortion and large for gestational age neonates was significantly higher in women with over diabetes than GDM, despite achieving the comparable glycemic goals. And the postpartum diabetes at both 1 and 6 months were significantly higher in women with over diabetes than in those with GDM. These are the various studies which have been done from the rest of part of the world. What were the factors which were significant studies can be seen from this table. So there were some limitations as well. That is that we do not include the controls for the comparison. A relative small number of over diabetes patients were there only. There were 32 patients only. So this should be considered while interpreting our results. Another limitation was some of the patients were preterm received glucocorticoids. So this may have affected the glucose levels while estimation. So we could not exclude those patients as we already had fewer number of patients. And SMBG assessment was not included in interpreting the result. We included only HbA1c at pre-delivery for assessing the glycemic goal. So the key message would be over diabetes during pregnancy in Indian women is associated with adverse maternal and neonatal outcomes. Women with over diabetes need early and aggressive management of glycemia and delivery in an institutional setting where expertise and modern neonatal facilities exist. The incidence of postpartum glucose intolerance in women with over diabetes is also high, and there is a rapid conversion to diabetes in the early postpartum follow-up. Thank you.
Thank you, Dr. Tausif. Wonderful presentation. I would want experts to give their comments. Dr. Yash Patel, you had some comment.
So it was like Dr. Taufik, thank you for, sorry, pardon myself. Dr. Tausif, thank you for being there. And we really appreciate what flavor you are adding on to the these presentations. And to make it to the innovations, we got it that your contents are more scientific. And we are looking forward the much more sharing in upcoming conferences from the Srinagar. And it is indeed pleasure that you are representing the Srinagar and the valley of around there.
Thank you, sir.
Thank you. And to the side, we have all panelists for the this meeting around. Dr. Vinay ji is around, Dr. Vijay is around, Dr. J.S. Anand is there. So we can summarize the whole innovations what had been shared for last 2 days, and you can provide your inputs on the same. That would be much more empowering for others to share their innovations in upcoming years. So what could be the much more on the sharing side, and what can be much more appreciated for the scientific content of the conference? So we can start with Dr. Vinay, if you want to start with, and then Dr. Vijay, then if Tusharji, Dr. Tushar is around.
I think this is a great.
Sorry. Yes, please. Yes, Vinay, Dr. Vinay, go ahead.
Yeah, sorry. No, I think this is a great initiative where I think new ideas and every stakeholder is involved. So I think diabetes is such a big battle which cannot be won alone. Not even one stakeholder can work and others can see. So it's like, I think this is a very unique a platform where all these ideas and even the doctors as well as the patients as well as so everybody can learn from each other. So it's a really great opportunity. But I think as you already mentioned, from the output, I think then we can start collaborating with each other more so that I think we can at least devise next 1, 2, 3 steps which we can implement. So I think that's. But it's a great initiative. I would like to thank Dr. Yash Patel and as well as Dr. Mayur Patel for this. So it's amazing. It's really exciting.
Hello, everybody.
Don't take it to ourselves only. It is just a teamwork.
Everybody,
so, yeah, everybody. It is all teamwork. So, Professor Vijay, if you want to share on the same.
Yes,
yes,
Dr.
Bhushan
Yash.
sir, welcome. Yes, just concluding the session. Yeah.
Yes, Dr. Yash Patel and Dr. Mayur Patel. I mean, it was really a wonderful session. I mean, it was.
Can you hear me?
It was really glad
Yes.
to see
Good
the very
afternoon.
innovative ideas involved in the field of diabetes management and the detection and the prevention. Fine. And today's presentations were also good. Like we had Dr. Harsh Malik for Amlog 360, and like we saw the Blue Circle Diabetes Foundation, and we saw the AI-based detection of bacteria causing diabetic foot infections, and so many. I mean, all the presentations were good. I'm just highlighting few of them, and it was indeed, I mean, a common platform where we all can interact with each other and can get the more and more information from each other. And like Dr. Vinay has said correctly, all the stakeholders are being benefited from this. I mean, the doctors and you Dr. Yash Patel said correctly. This is the only engineering project which is put for this. Conference. And I would like to add one more thing into that. Though your title is innovation by NGOs, we belong to government organization purely. So we belong to government engineering colleges. Right? So in that way, rather than keeping ourselves limited to NGOs and government and non-government, it is like let us work together towards the benefit of the society. That is what our intention is. Fine. So we would like to see more and more participations from the industries, from the doctors and communities, and the more importantly education and engineering colleges as well, so that we can build such a good platform over here in our country where we can come up with a good device or technology or any good machine, and then we can treat the diabetic related disorder in India.
Wonderfully said that it is not only the medical innovations, it could be instrumental innovations, and we have our representation, Dr. Bhushan Punani sir, who is the master of communication innovations also, and the mask work innovations also. So those kind of sharing also, like enrollment or the project innovations, any can be possible. Like Dr. Ann shared about the prevention drive innovations, that can be, or the awareness or education awareness, that could be one of the opportunities to look for. Yes, do we have Dr. J.S. Anand to conclude the session? Otherwise, over to Dr. Meera. Yeah.
Thanks, Dr. Yash. Great summary and great session indeed. Very interactive and very innovative. Let's move on to the next session, that is NGO formation, financial resources, and management. For this, we have our chairpersons, Mr. Bhushan Punani, Assistant Professor, Biomedical Engineering Department, Government Engineering College, Mr. Mukesh Majitia, Founder and Director of Zen Group. Over to you, Dr. Punani, sir, and Mr. Mukesh Majitia, if you're there for the next session.
Thank you very much, Dr. Neeraj and Dr. Yash. First of all, I'm grateful to the organizers for giving this opportunity, because in the present context, forming NGO and running NGO is a very big challenge. The present government wants NGO to be under full control, and there are a lot of statutory compliances which have to be fulfilled. They are definitely very difficult to manage, but if you are in a very upright organization, if you follow all the laws, all the regulation, there's a very good chance that all those NGOs which are not very effective, which are not for good purpose, they'll be weeded out, and good NGOs will have a chance to survive and grow. So this present system is for the organization which can comply, which can follow all the statutory compliances in the best manner and in a timely manner. So I appreciate the idea of the organizing committee to keep this session, because this is most relevant, because a lot of health related institutes, hospitals are themselves NGOs, or they have set up the NGOs. The NGO word is very, very common in health and education. These are the two prime areas. So when there's anything on health and understanding NGO is not just now an entity you form and it runs. It has a lot of implication. And I'm very happy that we have four very eminent speakers who know the subject very well. And without taking any time, because we have 15 minutes each for each speaker, there are 4 different. And I must appreciate Yash Patel and his team for selecting the topics in a very meticulous way. and also arranging the speakers in a very good sequence. So without taking any time, I invite Shri Kaushik Bhai Patel. Kaushik Bhai, can you little lower the camera so we can see you full? Very good. Now, Kaushik Bhai is a great friend, is a guide, is a supporter, and I'm very proud he's my donor also. So Kaushik Bhai knows the law very well. He is known for registering so many organizations. There cannot be a better person than Shri Kaushik Bhai Patel to talk on regulatory framework for NGOs. Kaushik Bhai, floor is yours.
Can I put something on that cherry, that Black Forest cake, a cherry on it? So
Yeah,
to
yeah.
all of the delegates and the participants, we have 32 countries joined in, and non-governmental organization as well as the healthcare administrators as well as the governmental organization and health ministries are part of this forum at present. What we are building up with this session is also how the Indian NGO or the charitable foundations work are based on the financial structure, and what is Dr. Bhushan Punani had shared about is what are the fundamentals to build up on that aspect. Yes. Over to CA Kaushik Patel.
Kaushik Bhai.
Thank you, Punani Saab. Yes, at the outset, I am grateful to AIDR and MHF for giving me this opportunity and to be amongst the crowd of doctors. So I am rather an odd man in this professional group of doctors. But anyway, really it is an interesting experience for me to share my experience. In fact, in this subject, Dr. Punani is a more appropriate person, having more practical experience in dealing, because he's running an NGO, which must be facing all various issues in complying with the regulatory requirement. In fact, it is I'm on the other side of the table where I am advising my client, whereas Mr. Punani is on that side of the table where he must be experiencing the real problems in complying with the regulatory requirement. And he has very rightly said that NGO is, I think in our country, they are being now looked upon with some suspicious eyes. And government is coming out with more stricter requirements for NGOs, be it an income tax or even FCRA, or even the contributions under Companies Act also, they have made it more stricter under CSR. So having regard to all these things, we have to, NGO have to work and find their own course of action. So without wasting on much of time, let me start with my presentation. Yes. Is it visible? Share.
Yes, well visible.
It's visible, sir.
Visible.
Use the full screen. Double click the presentation and use the full screen. Go ahead, sir.
Yours mic is mute. You can unmute yourself, and then in the right bottom next to zoom in zoom out, there is a window click. You can click over that. Your mic is yes, right bottom.
Right, but mute me.
No. To your presentation. The slideshow. Yes, lower. Right side. Yes, the first window. Thank you.
Has it come? Yes. I think still full screen has not come. No?
It is taking time. Yeah. Yes, go ahead. It's a presenter mode. Yeah.
So let me start basically with the question, why the regulations? And I think initially we discussed that the regulations are very strict in our country. The government intentions are to regulate the NGOs in various manners. But what I see is that basically first is the principle of trusteeship that Gandhiji announced, that under the trusteeship principle, the NGOs are the particularly governing body members of the NGOs are the trustees, and they have to act in that manner. And so in that context, some monitoring mechanism is required. Another intention appears to be preventing misuse of funds by the NGOs. Third is the governance for effective utilization of funds. Then I think FCR is concerned, it is in consideration of the national security. We have also seen that under the guise of a charity, the business activities are being carried on by the NGOs, some of the NGOs. There are always black sheep, so which has to be controlled. And supplementing the various government programs, government is taking the help of NGOs. And for that purpose, various regulations are being prescribed. The topic I have divided considering the three major aspects: regulatory provisions applicable to setting up of an entity, applicable to sources of funds, and various operations of the NGO. In a summarized form, I have tried to bring out the regulatory requirement for setting up of the legal entity. Basically, there can be three forms of the entities. One can be a trust, another can be a society, and third is the Section 8 company. The statute applicable in case of trust is the State Trust Act or the Indian Trust Act. In our Gujarat, it is the Bombay Public Trust Act. There is a Gujarat Public Trust Act, but it is still not implemented. Then at the national level, we have Societies Registration Act 1860 and also Companies Act 2030 for company format. The jurisdiction of the authority under the Trust Act is the Charity Commissioner. Then there is a Registrar of Society. I think in the Gujarat, it is the Charity Commissioner also holds the charge of Registrar of Society. And we have Registrar of Companies for the Companies Act. Documents for creation of the entity is the trust deed. In case of society, it is the Memorandum of Association and rules and regulations. In case of company, it is Memorandum and Articles of Association. Briefly, so far as trust is concerned, it is called a settlement, where there is a trustee, there is a settler who settles some property on the trust, hands it over to certain persons who are called trustees, and there are beneficiaries. In case of charitable trust, public at large is considered as beneficiaries. Number of members required for setting up: in case of trust, minimum 2 trustees; society, minimum 7 members. In case of company, if it is a private company, there are 2 members, or if it is a public company, there are 7 members. The manner of appointment of board of management, it is by way of its election or selection, as the trust deed provides. Then appointment of election by members, that regulations will provide in case of society. And under the Companies Act, it is election by members of the company. Source of fund, in case of trust, it is majority through donation. In case of society, either if it is a large number of members, and membership fee and donation. And in case of company, it is share capital, membership fee and donation. There are also restrictions on the investment of funds. In case of trust, the Trust Act provides the manner in which and the form in which the investments of the trust fund can be made. Similar is the case of a society, where the trust, it is required to be registered as a trust. So Trust Act provision will also be applicable. Under the Companies Act as such, there is no regulatory requirement, but investment beyond certain limits can be made with the approval of the members in general meeting. I'm not going into technicalities of these aspects. Now coming to first, that was first aspect, regulatory requirement relating to setting up. Second aspect is the sources of fund, which is very important, I think, for the participants to understand. The sources of fund are broadly into 3 categories: donations, foreign contribution, and government grants. Donations can be further subdivided into donation by NGOs, donation by households, and donation by corporates. Foreign contribution, there is a Foreign Contribution Regulation Act, and government grants will deal with it separately. Coming to regulations relating to donations, they can be further classified into general donations, corpus donations, and specific donation for acquisition of asset or for any project. A small provisions has to be kept in mind is the charitable trust that is charitable institutions having a sole object of medical relief, they are not liable to contribution to the Office of Charity Commission. There is a provision that every charitable trust having income have to contribute 2% of their gross income to the fund maintained by Charity Commissioner. In case of medical institution, this is not applicable. Coming to important provisions with regard to income tax, so far as the donations are concerned. The income of the NGO is generally exempt from income tax on fulfillment of certain conditions, and these are to be strictly followed. The activities should fall under the definition of charitable purpose as per the Income Tax Act. It must obtain the registration from Commissioner of Income Tax. This is very important, and you must be aware that recently the government has amended the Income Tax Act, requiring the registration of charitable institution every 5 years. And now for the first time, that provision is effective from 1st April 2021. And now all the trusts are required to get themselves re-registered, I would say, re-registered under the Income Tax Act, and which will have to be done now at the end of every 5 years. And third important condition is that it must apply for charitable purpose 85% of the income during the year. So whatever the income has been earned, it has to be spent on the object of the trust during the year. What would happen if 85% income is not applied? First option government has given is that you accumulated the income for a period of 5 years and specify the object on which the income will be spent, and you keep that amount invested in safe mode as per the provision of section 11(5) of the Income Tax Act, but have to ensure that within that said period of 5 years, it is applied for the object of the trust. It may so happen that if you are accounting the receipt on accrual basis and expenses on accrual basis, so if you contend that if you have spent 85%, but income is not received, then that can be deemed to have been applied for the purpose of income tax. And the consequences, if you have not utilized the amount during the period of 5 years, then it will become liable to tax in the year in which there is a default in application. There are some special provisions with respect to exemption, and popularly it is first is the section 1023C entity, which deals with the exemption of income of certain entities, which includes hospital and other medical institutions. This exemption is available to the institution which are only and or substantially financed by the government grant exceeding 50% of the total receipt, or having annual receipt not exceeding 1 crore in the financial year. Second exemption is also this 1023 exemption is subject to the compliance of the conditions which are on the similar line to those prescribed under section 11. That is, you have to get yourself registered, you have to spend the income 85% of the income during the year, or if not spent, you can accumulate it during the period of 5 years. Another important exemption is the donation received in the form of corpus donation. What are corpus donation? Corpus donations are those donations which are received with a specific direction from the donor in writing that it shall form part of the corpus of the trust. And recently the Income Tax Act has amended this provision by providing that amount of corpus donation cannot be utilized. You can just utilize the income generated out of the corpus donation. The donations would not be received unless the donor gets some tax benefit. So that's why the provisions under the Income Tax Acts are there, that if the donor gives a donation to an eligible institution or recognized institution, which is as per section 80G of the Income Tax Act, he or she will get the deduction equal to 50% of the amount of donation during the year. And there is another provision also that if any amount is contributed by to an approved scientific research institution, then 100% of the amount contributed is allowed as a deduction. But this will be helpful to those entities who have a business income, because deduction under section 35 is available as a business expenditure. Another important point with respect to donation to be kept in mind is the provisions regarding anonymous donation, which are considered as taxable. What are anonymous donation? These are the voluntary contribution without any record of identity, which are received as which are considered as an anonymous donation, that you don't have the information about the donor or their address or their PAN number. So if you have received such sum, or after receiving such sum, if you do not keep the record of the donor, then it may be considered as anonymous donation. It is exempt in case of trust which are only for religious purposes. Otherwise, anonymous donation is taxable at the rate of 30%, exceeding the exemption limit. And what is the exemption limit? It is the higher of 5% of the total donation received, or rupees 1 lakh. So this can be explained like this, that if you have received 100 rupees as donation during the year, and out of that 100 rupees, say 40 rupees is the anonymous donation. So you can get exemption up to 10 rupees. 30 rupees will be considered as anonymous donation. On 30% tax will be required to be paid. And balance 70%, 70 rupees, the tax will be liable as per normal provision. So you can get the exemption as per section 11. Coming to the second type of donation, that is donation by corporates. And this is a very important provision brought out by the government under the Companies Act 2013. That spending on corporate social responsibility, which is an obligation as per the provision in the Companies Act, and it is forming a part of source of fund by the NGO in healthcare sector. To which companies this provision applies? The company having a turnover of 1,000 crore or more, or company having a net worth of 500 crore or more, or company having a net profit in the year of INR 5 crore or more. So any of this company fulfilling any of these criteria, it is required to contribute at least 2% of its average net profit during the immediately preceding 3 financial year for CSR activities. Now for CSR activity, how they can implement? They can by themselves implement, or they can implement through eligible implementing agencies, or joint implementation with one or more companies. So for us or for NGOs, the benefit of this provision can be taken by working as an implementing agency. So in the next slide, I have briefly mentioned the requirement to act as an implementing agency for CSR activities. Public agencies with established track record of at least 3 years of undertaking CSR activities are eligible for undertaking the CSR contribution. This entity can be Section 8 company, or public trust, or a society, or it should have been or it is registered under Section 12A and 80G of the Income Tax Act 1961. So in any NGO fulfilling any of these criteria can work as an implementing agency for CSR activity of the companies. Another important amendment which has been brought out by the government for controlling the activities of CSR by implementing agency, that these entities which want to undertake CSR activity have to get themselves registered with Ministry of Corporate Affairs by filing Form CSR 1. Once they're registered, such entities will receive the registration certificate. Whether you are an eligible implementing agency or not, so it will depend on the activities which you are undertaking. So activities relating to malnutrition, promoting healthcare, including preventive healthcare, is a part of CSR for receiving contribution. So for the participants of this conference, if you are undertaking this type of activity, you are eligible for receiving CSR contribution as an implementing agency. Coming to more stricter regulation about the donation or contribution received from foreign source, which is the, I think, most difficult act to comply with, and becomes, I think it is becoming difficult for the NGOs to receive the donations or contribution from foreign source. The applicable law is the Foreign Contribution Regulation Act 2010, which regulates the acceptance and utilization of foreign contribution or foreign hospitality by certain individuals or associations or companies. It prohibits the acceptance and utilization of foreign contribution or foreign hospitality for any activity which is detrimental to the national interest or national security, and provides for matter connected therewith or incidental thereto. FCRA permits the receipt of foreign contribution by NGOs subject to following condition. It must have a definite cultural, economic, educational, religious, or social program, and it must obtain FCRA registration or a prior permission from the central government, which is the Ministry of Home Affairs. Foreign contribution, it means a donation, delivery, or transfer made by any foreign source. So it can be in various form, currency or security, that is also permitted. Acceptance of contribution, as I said earlier, two requirements: registration or prior permission. Registration, it is eligible for a period of 5 years. Contribution received cannot be used for speculative activities and admin expenses exceeding 20% of the total. And once cancelled, you cannot get yourself re-registered for a period of 3 years. Another option available is the prior permission, that if you are receiving a donation for specific purpose, then prior permission can be obtained for that purpose. Then contribution received cannot be used for speculative purpose also. I am not going into details of the requirements for prior permission or registration because of lack of time.
Thank you.
Just highlighting the compliance requirement. Compliance is annual returns to be filed. You have to open a separate bank account with the State Bank of India designated branch. Any change in the name, address, and names is to be intimated to MHA within 30 days of change. Any change in the office bearers, also more, which is resulting to more than 50% or more, is also required, cannot be made without the prior approval of the ministry, and audited accounts and report has to be furnished. Another important restriction which has now been brought is that the entity receiving the foreign contribution cannot onward transfer the foreign contribution to any other person. In respect of government grant, an important point to be noted is the NGO Darpan registration, which is now mandatory for NGO to apply for government grants, which is and track the status of their application. It also helps in improving the credibility and goodwill of the NGO. There is no annual compliance relating to this. However, NGO have to update the latest governing body details as and when there is any change. This is also an important compliance which NGO has to bear in mind. Coming from financial aspect to other regulatory requirements relating to operation, justly slightly touching upon is the obtaining license under Shop and Establishment Act. You will also to comply the labor laws if applicable relating to PF. Sorry?
We have to speed up.
Yes, just at the last slide. Just GST, donation received not liable, and healthcare services by clinical establishment and medical practitioner is exempt. Just key takeaways: building up image or goodwill. This will be a regulatory requirement help in building up the image. It will ensure that you have to ensure that donation received do not get frittered away in taxes, ensuring utilization for object of the NGO. Investment has to be made in a specified manner, and compliance to avoid any penal action. Thank you.
Kaushik bhai, heartiest congratulations. I must tell you, I've seen many presentations on NGO, CSR. This is one of the finest, most comprehensive, and most accurate presentation. Congratulations. We have almost covered everything concerning NGOs under all the laws in the most perfect manner. My heartiest congratulations. I'm sure the participants have a number of questions, but we'll wait for other presenters so that we can make up for a little time. I hope possibly you are available till then.
I think I may have to leave.
Okay. In that case, if there's any burning question from a participant, Dr. Yes, we can take 1 or 2 questions.
The question will pop up in our, so everyone can ask the questions from there, and that would be popping up. So it might take some time. So till time we can go ahead with the further sessions. And
you can go in the chat and ask your question. Possibly will be pleased to answer. And I'll request Dr. Yash Patel to give the contact detail of Kaushik bhai if anybody has any question later on. And I know Kaushik bhai is a very unassuming person. He'll be very happy to answer your questions whenever we require, because he is somebody who wants to help the NGO sector in the best possible way. You are welcome to reach him whenever you have any doubt. But Kaushik, I also request you to provide me a copy of your presentation.
Thank you.
I'll preserve it. It's really a very well done.
Thank you.
With this, thanking Shri Kaushik Bhai for very
There
good
is,
presentation. We
Bhushan
invite,
sir,
yeah.
there is one question from Mr. Rajesh ji.
Okay,
He is one of
Rajesh.
our organizing secretary
Sure.
also, and the scientific content is one of his background.
Okay,
So he
Rajesh
has
Bhai, please
provided.
go ahead.
Thank you, Yash bhai. Kaushik bhai, very useful presentation. I learned a lot of things. One question regarding NGO Darpan. NGO Darpan registration is only mandatory from the perspective of receiving or working with government projects, or otherwise also it is beneficial?
I think now it is becoming mandatory everywhere, because if you are applying for FCRA also, they want it. So
Okay.
any support which you require, and I think it will increase the credibility.
Okay.
It's a very simple formality,
Uh,
and it is maintained by Niti Aayog of the central government.
okay. And same is with the CSR 01 form, which you
But,
mentioned.
it is also a very simple form, and immediately you are getting the registration. Not much detail to be filled in.
Okay. Thank you, sir.
Thank you, Kaushik bhai, once again. We invite Ms. Susmita Mitra. You are available, ma'am? Yeah, she's there. Now you can speak on mandatory CSR. Some part of CSR, Shri Kaushik has already covered. If you could cover more practical parts, that'll be appreciated. Floor is yours, ma'am. Please go ahead.
Hello, everyone. Today I'm going to talk about fundraising. For any NGO, it is a big factor to raise fund for actually doing the work. Now, courtesy Government of India, we have started with the CSR, Corporate Social Responsibility, which is really helping the NGOs. So let us go into the whole process, like what are the plan and how it has happened and how it helps the NGOs. So corporate social responsibility, it is actually going beyond the charity, legally requires the company to act upon its obligation to integrate social, environmental, and ethical concerns into the company's business process. And I'm very proud to say that India is the first country in the world to enshrine the corporate giving into law. The law started Companies Act 2013 of any company net worth more than 500 crores or turnover 1,000 crores or net profit over 5 crores has to spend at least 2% of the 3 years average net profit on the CSR activities. The rule came into effect on 1st of April 2014, applicable to Indian companies, branch, project offices of foreign companies in India, activities as specified on Schedule 4 and as amended from time to time. So it is mandatory for any company having the same criteria as is been shown above to spend 2% of their last 3 years profit for CSR. So companies has to constitute a CSR committee, three or more directors. And CSR committee has to formulate CSR policy of the company, identify activities to be undertaken, allocate resources and monitor the policy, recommend the policy to the board. So each and every company can choose their own line of charity, and accordingly they can start forming the rule. If the company fails to spend on CSR, it has to disclose the reason for not spending. Penalty for non-disclosure is 50,000 to 25 lakhs or even imprisonment up to 3 years. Activities that qualify in Schedule 4 are contribution to the Prime Minister's National Relief Fund, ensuring environmental sustainability, eradicating hunger, poverty, and malnutrition, improving maternal and child health, measures for benefits or armed forces, promoting education, sports, health and family welfare, prevention and early detection, protection of national heritage, and slum area development. So you can see this is cover all the important activities, philanthropic activities. Normally the NGOs and even other organizations, they intend to do. Benefits for the corporates also. Today's consumers are socially conscious, gives a competitive advantage and boosts employees' morale. The populations are more, conscious about doing something good. So we often see some companies' advertisement where they are promoting that whatever you are buying, 2 rupees or 3 rupees will go for a particular charity, like for education, for rehabilitation. So that even it promotes the product, gives a good image of the company, gives a competitive advantage, and also boosts employees' morale. The employees of the company also feel that yes, they are doing something good along with the commercial activities. Now, more spending, positive effect of the legislation, more spending. Private sectors combined charitable spend increase after the law's enactment from 5,115 crore in 2014-15 to 8,691 crores in 2018 and 19. Mainstream charity brought CSR into the boardroom. Now, what are the shortcomings? Non-compliance by more than 50% of countries' top 100 companies, collusion with the charities that refunds for a kickback, scale back on donations by some corporates to the legally required 2%. I would like to explain that there are some companies who had always been spending a substantial amount of their profit for donations and for charities. So now they have become, bound by this 2%, not more than that, which used to be probably more earlier. Inequality, bigger charities with bigger visibility and credibility attract more donations, leaving out the smaller ones. All the companies, they would like to be shown themselves as association with big charities rather than the small ones. Here, what is happening is the smaller associations or smaller, NGOs, they lose the chance of, leveraging this advantage. Small charities are unable to fulfill, as I mentioned, bureaucratic and operational compliance. Now, this process of CSR is, very, very detailed. In details, there are many things which needs to be submitted. And naturally, for the smaller charities, they do not have that much of capability or that much of, support to have a proper projection of their plans. Geographic bias towards charities in the industrial progressive state. Again, the visibility factor comes in. The companies would like to be, associated with the charities which are on the industrially progressive state, leaving out the small areas. Government-led projects are preferred to gain goodwill, and corporates rigid in supporting specific causes. As it was mentioned, that one can choose the cause. Now, many big companies, they have specific areas of support. Some help, some support the eye, operation, or looking towards, for the blindness. Some support probably the girl child and health. So there are different causes taken up by different companies. Corporates are creating their own NGOs. That is also one thing happening. So they are keeping the spending of 2% within the companies also in a way. corporate choose to support their employees. If any employees have their own NGOs, so naturally company would prefer that. Minimal administration charges are allowed. In case of disaster, CSR funds are diverted to these causes only. In recent times, COVID and cyclones. So that is also mandatory government rule. Now, recent changes. New registration is required from Ministry of Corporate Affairs to get approval for registration of entitled for undertaking CSR activities. For example, my NGO is Cancer Patients Aid Association. We have been taking the advantage of CSR since last few years. But now we had to again register ourselves to the Ministry of Corporate Affairs to get the approval for registration of entities for undertaking CSR activities. FCRA collections are subject to greater scrutiny nowadays. All FCRA donations funneled to a single State Bank of India branch in New Delhi, which is resulting huge log jam caused, deadline missed, and risk of donors losing interest. Now, what needed to change and improve? Greater freedom to charity, corporate partnership, lesser regulations and oversights. Strategies for being more inclusive into the stakeholders. Now, CPA holds even to involve the stakeholders and employees. So this is also important, that to be with the company, the corporate, the NGOs or the charities needs to be connected with the relevant corporate. What compliance for the NGOs are due diligence. This is a very, very important factor. The charity and transparency of financial statement, number one. First, a proper transparent financial statement needs to be submitted, along with the verified data and statistics of past projects. The analysis of past projects also should be there, that how much amount was asked for and how it has been utilized. This is an utilization certificate is a must. Maximum value and goodwill of the donor. Measurable, perceivable and tangible project. As I had mentioned that for small NGOs, it is becoming difficult to get encash this opportunity. One of the reason is they do not have enough actually support to get this done. Many NGOs get this done through a professional organization, but there again they are spending money. Effective and efficient sustainable project, very, very important. Not only a project needs to be submitted, but also it is to be shown how it will help and how it is going to work, how it is going to be sufficient and sustainable projects. These due diligence are very, very important. Initially, when one NGO or company is being approached for CSR funds. Implementation and reporting project, create a personal relationship, initiate employee participation, effective implementation as promised, and provide periodic progress updates. Create a personal relationship with the companies who is spending the donation, and employee participation is also very, very important. Effective implementation with the due diligence, that is important, and provide periodic progress updates. Now, for example, for us, we do submit periodic progress updates to the companies for different causes. Agree on method and frequency of reporting, timely and professional financial reporting, and provide utilization certificate from a certified auditor when project ends. Now, different companies have different ways they want the report in a different format. Like we are actually using the funds for 2-3 companies. Now, from the same cause, for the patient support cause only, but one company wants in a definite way where to be projected and to be sent the statement. Another company has a different way. So this needs to be very much added. Now the question comes, such an important protein, such an advantage, why everybody cannot take the advantage of this? There are few things which needs to be taken into consideration how it goes. So that there only the NGOs are missing out. Failure to factors in the administration costs in earlier days, continuity with the same donor. Actually, this is the problem we had faced. We have never factored the administrative cost in early days when we started availing this particular support. And continuity with the same donor, corporates difficult at times. Sometimes the donor, they do not want to continue after first and second phase. Same projects, some projects are more popular other than the others. Another, again here the question comes, the visibility. See, for example, for CPA, the patient support is much more important rather than awareness. We approach the corporates with making projects. So if we support patient support and also awareness, but actually awareness is much more important, or as much as important as the patient support. But that is not been supported by whatever is visible, that is the patient. So the most attention goes for the patient related activities. Change of procedures and recording system to comply the process and produces, but it subsequently helped out proper system in place. See, when we started, we had really started without considering many important factors. But as we progressed over the years, we have understood what the company wants. It is very important for the NGOs to understand the requirement of the company. What kind of project they would prefer, number one. Make a proper project, and with, of course, which can be sustainable, which can be at least gives a proper view of the result, and also a proper recording system, and also proper statements to be submitted, especially the utilization certificate. Actually, for us, for CPA, change in the procedures and to comply, this has subsequently helped our process also. So our projects mainly are adaptive cancer patients, head and neck patients, breast cancer patients, early detection camps, cancer awareness in progress, and towards zero cervical cancer HPV vaccine. Among these, as I had mentioned, adaptive cancer patient is the most popular. Head and neck patient, of course, some organizations have come forward, but we are really not getting much money for awareness programs, which is also equally important. And recently, the zero cervical cancer HPV vaccination we have started, that is also, of course, getting attention. So the basic point is everybody needs to form a proper project and submit to the corporates, and then follow up with each and every step. So I think this is the way we can really take the advantage of CSR. And I think each and every charitable organization should be taking this advantage, which is really been very good, and you get much better amount, much more amount with the normal donation. Thank you. If there's any question, please, you can go ahead and ask me.
Thank you very much, Susmita ji. It was a great presentation. You really covered up each and everything in a very meticulous way with the latest information. And I'm sure many of the people who are listening, they can use CSR as a very good source of funding. It's going to be almost 50,000 crores, which will come to the kitty. And with the corporate performing much better, the money will increase. So it's up to you. Sky's the limit. As Sushmita ji rightly pointed out, there's a procedure, there are restrictions, there are formalities, and there are a lot of guidelines which need to be followed. And her presentation is definitely fantastic. And appreciating her presentation, now we go to the next speaker, Shri Prabhat Sinha, who will talk about social media today. Another, Prabhatji, is a very wonderful subject. In fact, future belongs to social media. Let's see what you have to share with the participant on social media. Floor is your, Shri Prabhat.
Thank you, Dr. Punani sir. It's so great to see you again after many years, and to both the chairperson, Mr. Mukesh sir and Dr. Punani. First of all, thank you for this opportunity. And before I start, I also wanted to thank Dr. Mayur Patel, Dr. Yash Patel, Dr. Sushil and Rajesh ji for this wonderful platform. And I think this particular platform itself shows the use of virtual and social platform that we are connecting from so many different places and cities. So that's a true testimony. Now, just let me know when you can share the slides.
It's visible. Yeah. Go ahead. It's visible, Prabhat.
So the whole topic is, this is one subject which is either very easy or very difficult, because everybody feels is an expert in this. But let me put this as a disclaimer that I'm not an expert in this. Whatever I'll be sharing with you is the experience of many other social organizations, civil society organizations, and some of my experience working with the civil society organization or working with corporate managing or handling communications in past few years. So what we want to achieve is a positive change. Now, when we talk about positive change, is social media is a wonder pill? That's the question. Now, let's start with an apple, because it's a conference on diabetes. We have a lot of sessions on lifestyle management. So it's all about apple. Now, when we think about apple, unlike any other fruit, the first thing that comes to our mind is not this apple, is this apple. And whoever is listening to this conference, I think one must go and read the whole evolution of this apple story. Why this is a bitten apple, how from a rainbow color to this color of apple, it's a beautiful story. But what is most important is, when we think about apple, is the trust, experience, knowledge, brand, and uniqueness, which makes this apple, the device or the company or a brand, the best in class. Now, since we are talking about this apple, so I thought I will bring 6 apples to you. So I will talk about 6 apples which I borrowed from somebody. But before that, I'm not going about what social media is. There is enough material available, but just 2 slides on this. The first is that social media is about social and media. So ultimately, it's a media. The platform is social. And we always have to keep reminded about it, that it's a media. It is not only about how we use WhatsApp or Facebook. It is a little bit more about that. But now when we are talking about civil society and social media, there is one thing which is very common. If you see how social media works, is many to many. Now it is not one to one, it is not one to many, it is many to many. And civil society, if you see, also is more social. The whole genesis, the way it works, is many to many times. It is not one to one or one to many. But what is most important is, and what we will be talking in next 5 minutes or 6 minutes, is that the personal use and professional use. First thing is that we have to distinguish this both, because many times we mix how we use our own Facebook account with our organizational account, how we use our organizational account with our personal account. So as we dress for the occasion, our social media handles, channels have also to be used in a professional way if we are using it for professional use. Now, we have seen 2 wonderful presentations, and one is about to come, and one of it was resource mobilization, second was more about governance. But for majority of the civil society organization, it is one of these three purpose or maybe something else, because of which we will be talking about amplifying voice or resource mobilizing or connecting with the community. Now, coming back to these 6 different apples, what I thought I will discuss with you. The first is the content. And when I say content is the king. Now, in any media, when you read a newspaper, when you read a news story, it's the content which makes all the difference. Similarly, whether it is a Facebook post, whether it's a WhatsApp message or a virtual event content or a website content, it's the content which is going to make an impact. Do we give enough thought on the content? Because we may not have to pay for that content many times. It is easily made. You can copy, we can paste, we can do multiple things with that. But we have to remember and continuously work on content. And organizations who put focus on content, they have a better reach, they have a better impact. The second, which is most important, is channel. Now, there is plenty of different channels that exist, whether it is Instagram, whether it is Facebook, whether it is Twitter. Now, sometime what we like, or a channel on which we have we are a user, we trust that more. If I have been a Facebook user, I feel Facebook is the place. But is Facebook is a place for everything? If I want to do policy advocacy, or if I want to listen what is happening, maybe Twitter is a better place. If somebody wants to engage with a younger crowd, then maybe Instagram is a better place. But for example, I don't use Instagram much, even for my personal use. But my trust on Instagram will always be lesser compared to, let's say, Twitter or LinkedIn or Facebook, because I myself has not used it. But when I'm using it, any of the channel for my organizational purpose, that time my own biasness should not be there. It should be the right channel for the right audience. It's like putting our vote to the right candidate or to the right party, because then afterwards you cannot do much. The next apple is consumer. And when I say consumer here, it's the person or the individual who is receiving the information. Majority of the time in healthcare, when we communicate, it's the behavior change communication. And the communication has to suit to the need of the consumer. And it has to be a mix of the right channel and the right content. If it is not generating any action, as my previous speaker was saying, that only awareness is not going to make much difference. It has to be awareness, but little bit more from awareness to some action. The next one is ultimately, whether it is any media or anything, it is about skill, it is about a person, it is about a department, it is about a function. And that's why it is about communicator. So this C talks about the communicator. And it is very, very important to find a right communicator for the organization. In smaller organization, one person does everything. But if ever you want to have a volunteer for your social organization, for social media, you can look for some right volunteers who can come forward and help. The next is the cost. And what I'm saying, why I'm saying cost is because this is an investment. Social media, if you want to use it, like earlier when we used to print a content, a brochure or anything, we used to be very, very particular about finding the right agency to print the content, do the content writing. Same way, social media is now all paid. If you are relying on the organic reach, it has a very, very poor reach. Now, from 10 rupees, you can start amplifying your reach, whether it is on Facebook, LinkedIn, YouTube, or any such forum. So it's an investment. It cannot be done free of cost. There are expert agencies who do it in a better way, but you can start doing it with a very lesser cost. Even with 2,000 rupees, you can start promoting your post or so when you are making a project proposal, a campaign or disease awareness campaign, what I wanted to highlight is that do put a cost for amplifying or going beyond organic and paid promotion of your campaign. The last apple, but not the least, is counting, is monitoring the performance. It is not about posting a content on your channel, but to continuously measure that how these channels are doing it. If you're putting something on YouTube, how many people are watching? How many? What is the engagement rate? There is enough statistics available in many of these channels itself. There are certain platforms where you have to pay a little amount, but you see that which region, which city, what time people are. Recently I was reading somewhere on Instagram or something. 6 o'clock morning is the right time to put a post. So globally, they analyzed 1 million of posts, and they say that 6 to 7 a.m. is the time when most people have engaged on conversation. Now it is, for me, I may feel that 6 a.m. is a too early or a too late, but based on analytics, this is what the number comes. And then you also have to kind of align your or stuff with this. Now, before I close, just wanted to wrap up with 2 slides. One is that, the virtual platforms could be good, bad, or ugly. It is how we use it. There was a time before COVID, I think, it was less used. Then we started using it. We have started using it more. We also started abusing it to an extent. But when we think for a purpose using a media, it has to be optimal use and a very effective use. This platform, I think, is one of the examples how it is connecting people, how this particular thing is being live telecasted on I think on LinkedIn. The reach is huge. It is connecting people, and that's how I just wanted to send a huge good wishes to everybody who are engaged in making stronger and stronger impact. So thank you so much, and look forward to hear the next session. Very interesting session, and thank you again for your time.
Thank you very much, Prabhat. Nice to see you after a long time and to see you in a different avatar. And I'm so glad you thought of 6 apples. Maybe you can add 7, 8, and 9 apples also. Credibility, sustainability, transparency, etc. Those are the new apples which are very, very important in the NGO sector. Unless you have the credibility, unless you have the sustainability, survival is difficult. But I must appreciate all the 3 presentations were just excellent, very informative, and very well presented with very good PowerPoints. I congratulate all the 3 presenters. Now, if there's a time, Yash, if there are some questions to Prabhat or to other 2 speakers, Susmita or Kaushik Patel, you can ask them. I'll go by. Time is already over, Yash. It's now your choice to.
So I'll ask Dr. Neera, who is master of ceremony for the event. She'll just help us around. Yeah, support us.
Thanks, Dr. Yash Patel. Thanks, Dr. Punani, Mr. Punani, and hi, Prabhat. Nice to see you. Great connecting again. Wonderful talk by all the speakers. Punani sir, I think we'll wait for the questions in the chat. If it comes, we will get them answered individually. And
Sure.
Let's move on to the next session. Thank you so much, Punani sir, to you and all the speakers.
Pleasure always. Thank you.
Thank you.
Thank you. Bye.
Thank you, everyone. Yeah.
So we move on to the next session, that is living with diabetes. And for this, I would invite our chairpersons, Ms. Jaz Sethi, founder and director of the Diabetes Foundation, and Ms. Nupur Lalwani, founder, director, Blue Circle Diabetes Foundation, certified diabetes educator and certified pump trainer. Over to you, chairpersons.
Hello, hi, a very good evening to everyone. And on behalf of Nupur and myself, welcome all of you to this next session, which is very interesting. And I can say, I think for Nupur and myself, because we both are people who are living with diabetes. So to have this session is very important in conferences like this to really go into the life part of living with it, not just the clinical part. Nupur, would you like to add anything to that? You're muted.
Nupur, you are on mute.
all the mess that could happen today. So thank you once again for having us. And I think I'd just like to echo Jaz's thoughts. It's very, very important to have people living with diabetes participating in these conferences. And we'd like to thank the organizers. So I think back to you, Jaz.
Thank you so much. So to kick off this session, I think we're going to delve into a little bit about, the whatever we hear about living with a juvenile condition like type 1 diabetes, about marriage, will they get married, the stigma associated with it. And to have it, we have our first speaker, Dr. Archana Sarda. She is the MD consultant diabetologist and founder of UDAN, an NGO for underprivileged children living with diabetes. And today she's going to give us an insight into marital issues in people living with type 1 diabetes. So Dr. Sarada, the floor is all yours.
Thank you, Jazz. And what could be a better way to present with two lovely girls that I'm almost totally in love with, Jazz and Nupur, who are absolute examples of what we see as a good life and champions with living with type 1 diabetes. So I give you both the hosts today as role models for my UDAN kids, and I'm happy to be here with you. And thank you very much, organizers, for this very unique conference, very unique topics, and so relevant. It's so heartwarming. I've been following throughout, and it is absolutely something which is so relevant. I think that is the word that I'm looking for. Thank you. So I'll just be sharing my slides. It's a very short talk, but something. Yes, is the slide visible?
Yes, it is.
Okay, so we are talking about marital issues in people with type 1 diabetes. And this is something I just wanted to share, that I did not want to make it a scientific talk as in the data, etc. This only comes out of my own experience of 20 years. And we have now 900 children with type 1 diabetes. Of course, many of them are now grown up. And this is in the semi-urban and rural Maharashtra. UDAN today has 125 of these 900 children who came to us as kids are now married, out of which 77 girls and 48 boys are married. 110 of these young couples actually have 1 or 2 children already. This presentation today is based on real experiences, and the photos are shared with their permission. So I just wanted to see, these are a few couples. I mean, out of that many, these are the few photographs I had, and they've been posing happily and sending them over the WhatsApp to us. So that's what I shared here. So lots of couples. So is life as simple as these radiant smiles look in the photograph? So what exactly is the issue? So this can be premarital. I think this starts from planning a marriage, then marriage, and post-marriage. So I will just take it as challenges in matrimony. What is the perception and what is the reality? And I am going to try to be brutally truthful here. So we're not going to mince words in saying and painting a rosy picture where it's not, but we're not going to be unnecessarily gloomy and unnecessarily create a scenario which does not exist. So I just wanted it to be a very, very clear-cut, stark, honest situation, which is there on the ground. And I'm sure later Nupur and Jazz can validate or contradict or whatever they wish at the end of it. So I'm challenging it with few problems. One is the physical fitness. The other challenge is the medical fitness. Third challenge is medical expenses and sexual health. Living in sync with the partner and family. Once you're married, then the childbearing safety, because that comes as part of the whole marital challenge. I mean, I would not really want to say it here, but a girl child especially comes 5-year-old detected with type 1 diabetes. And the first thing parents ask, will she get married? Will she have kids? And will her kids have diabetes? I said, look, she's just 5. We'll think about her diabetes first. But that is how it works. So that is how important it is in our society. It's not just a medical thing. It's an entire psycho-social, emotional platform that people look at. Then type 1 diabetes in the offspring. And that is why I made it red, and that is the social discrimination. So we're going to talk about this one by one and very quickly. So physical fitness. So very, very straightforward. The perception, the questions I get asked every day, that youth with type 1 diabetes are not physically fit to meet the demands of marriage, which by, I suppose they mean all the household activities, the shopping, the caring of the guests, the cooking, cleaning, whatever it involves after a marriage. So adulting in general. So they feel they're not just physical fit, by which they mean they do not have the energy and they generally cannot carry out all the responsibilities. But the reality here is absolutely straight. They have as much energy, as much capability as any other person to carry out the routine activities of a married life. I mean, if a person is lazy, they can be lazy without type 1 diabetes as well. But definitely type 1 diabetes does not stop them from carrying out these activities. So physically, they are fit. Medical fitness is something we must look at. So the first perception which we often have is that having diabetes make them fall ill repeatedly with doctor's visits and hospitalizations. So when people come and ask me whether they can have, they have been offered, a matrimonial with a girl who has type 1 or a boy, that is the thing they ask, that is she going to fall ill again and again? Is it going to be going to the hospital again and again? Then the person with type 1 diabetes has a disease. So this is, why should we marry a diseased person? And that is hence a constant medical stressor, as if you are living with a disease and there's always a thought of illness around in the family. That is another medical fitness related perception. And the third perception that people have, that that person is not going to survive long or will have lots of complications. I get people coming to ask that if we get married to this girl or boy, then what if his kidneys fail tomorrow? What if he becomes blind? How long, many years do we have? So that kind of thoughts do come in. It sounds very scary and probably very depressing at times, but it's true. That's what I get asked. So the reality check is that a person with type 1 diabetes just needs to follow some basic care. And emergencies are very rare and treatable. I mean, even in my rural areas, once they were detected with type 1 diabetes, there's hardly any hospitalization. They don't really need to go to the doctors. They're just capable of managing themselves. It's a part of a daily routine, the way people brush their teeth and etc. That is the way they check their sugars and they manage it. Of course, they have to be empowered for that. A girl or a boy is not ill. They are very much capable of self-management. It's just a process in place. It's not an illness. However, survival and complications today with the care is definitely not compromised anymore. Now you have been celebrating 70 years of duration of diabetes, 80 years, 90 years, and this is like wonderful. But again, if you honestly compare with a person without diabetes, statistically, the risk is higher. And this is something we cannot ignore. Now, another thought that comes in after the medical health is the sexual health. Often there is a perception that in a man with type 1 diabetes, a fear of erectile dysfunction due to diabetes, because that is something they read about all the time. And also the fear of inadequate energy to perform. So I get this kind of questions a lot. And these are not only by people who they're going to get married to, but also the person themselves. They fear that if I get married, will my sex life be normal? Will I be able to keep my partner happy? And I think it's a justified concern in anyone's mind. In a woman, the inability to participate equally in a sexual activity is a concern on both ends of the partner. The reality is both men and women's sexual activity is absolutely normal. Loss of libido can be experienced with uncontrolled diabetes and inadequate nutrition. This is a well-known medical fact, which is totally treatable with care. So otherwise, per se, there is no real issue as it comes to sexual health. Now, a very important concern in marriage, especially in arranged marriage, sometimes, people don't like to talk about it, but secretly they will come and ask us because it's expensive. So one of the perception is that it's exorbitantly expensive to maintain a person in good health. So they feel that, okay, in arranged marriage especially, they'll say, oh, that's a lot of money I'm going to spend every month on my wife or husband. And another thing is that's going to be hospitalization. So that's going to be a lot of money required. Again, expenses during pregnancy and delivery will be higher than the routine normal. Here, I think it's very important for someone who's going into a marriage of this kind that yes, it does have a certain cost per month for marriage. It has to be catered for. Later on, one cannot just put up their hands and we don't have money for your treatment. That is something that should be talked about. Whatever is the cost, it will depend on what you use, whether you're on basal pullers, you're on pumps, whatever is the cost, it should be talked about. Whether it's my income or yours, doesn't matter. But the cost should be talked about. Hospitalization and expenses are there, but it's very rare with education. I mean, that can happen to anyone. It's like an accident. Antenatal care would be definitely more demanding with frequent monitoring and follow-ups, and hence a little more expensive than the routine care. It's very important not to hide these things so that one knows where that fund is going to come from, so that one does not receive a compromised medical care later on afterwards. That money is important. Another very important issue is the living in sync with the partner and family. You got married, everything is fine. But there are so many things happen beyond just the couple in a family. You're expected to participate in household gatherings. You're expected to go for functions. There are fastings and feastings. There are some pujas in which you cannot eat. There are so many things that happen. Partner expects somebody to come impulsively. I have a girl whose husband, she has type 1. Her husband used to suddenly say, let's go for a movie. And she used to say, oh, wait, I have to check my sugar. I have to take a bolus. I have to eat something. I cannot go at 8 o'clock, So he says, just choose another show time. And she said, no, I want to go now. So he wanted to take her out. He wanted to go partying. And she had her schedule. And he used to say, you always say no, because you have to check your sugar, because you have to take your insulin shot, because you have to eat. So that really creates some disharmony between them. And that was not very comfortable. And a person is also expected to sync their meal times in the family. I have girls who got married and their mother-in-law feels the entire household should be fed and only then can you eat. Sometimes the family doesn't expect that. The girl feels that let everyone eat first and then I'm going to eat. How can I eat before everyone? So it's very important to do that. So what is very important is everyone has to talk about it. The decisions have to be together. Impulsiveness is fun, but it can take a toll on her health or his health. So everything has to be just shared, talked, understood, and I'm sure there are ways out. There's so many ways out. There's so much flexibility one can offer, but this is a reality. So the family has to know that there are certain thoughts which have to be taken care of. You just can't get up and go. That is important. And last point which everyone asks about is childbearing safety and type 1 diabetes in the offspring. So a woman with type 1 diabetes cannot bear a child. That is what people say. And then the child born will have type 1 diabetes, both of which are absolutely not true. A woman with type 1 diabetes can bear absolute healthy child. I have more than 100 grandchildren in Iran, so to say today. And the chance of type 1 diabetes in the offspring is 1% if the father has type 1 diabetes and up to 4% if the girl has, the mother has type 1 diabetes. So 1% if the girl has and 4% if the father has. So this is the official statistics. I have yet to see type 1 diabetes in any one of my patients or cases that I have to see. So last point is the sole social discrimination. So my thought here is, let's be honest, discrimination comes from lack of awareness. So let's educate people truthfully. Let's have both sides of it. Again, arranged marriages are very specific in their requirements. And they even want the color, size, shape, caste, creed, so much. So diabetes, of course, matters to them. So let's be honest. Let's explain the science to them. And if they're okay with it, let them talk to your doctor. And that's the best way. Everything is transparent. You know everything. I get at least one call a week about a potential match. And we are very honest with them. And many of them do get married, knowing everything. So it's very important to be honest. In a love marriage also, it may be love, it may be really a relationship, but it's very important to make sure they really understand the connotations. Just knowing that it is type 1 diabetes is not enough. Sometimes they cannot imagine what it feels like to inject yourself 4 times a day. I had a couple who the first time when he saw his girlfriend actually injecting, really freaked out. He said, I can't live with this all the time, it's hurting you. So, it was out of entire love, but he could not bear it. And it took a long time for that relationship to get strengthened. So for them to understand. So I think people should really gel together, go out, see pricking, see checking, see eating, see bolusing, everything to get a feel of what that life is going to be like, even if it is a love marriage. So love is often not just enough. It has to be all aspects. So discrimination will go away if we are honest, we are practical, we share. And last but not least, this is Sanika and her husband. They just got married last week. She is my type 1 educator. She herself has type 1 for last 15 years, and she recently got married to her childhood sweetheart. So marriages are made in heaven, but we have to wait for the right partner. That's not the end of the world. So wait, but do it right, do it well. Thank you so much.
Thank you so much, Dr. Sarda. This was, it's always wonderful to hear you and, all the amazing things that you share. It's just like a burst of positivity and power that comes onto the screen. And I just want to take a moment here to, acknowledge Dr. Sarda since the beginning. And I remember having this conversation with her a few years ago at another conference where I tagged along with her. And she said that, a lot of doctors, she is one of the few doctors who speaks about these psychosocial issues, when it is as easy for a doctor to just stick to the scientific part of it. She's talking about living with diabetes as well. So heartfelt thank you from not just Jazz and me, but the entire community. You have a whole, like, literally country of diabetic kids, T1 kids. So
fan club. There's a full fan club.
I love you all.
So thank
Any
you.
thoughts? I mean,
I absolutely, I just would like, I mean, I know we are taking questions at the end, but just a note over here, I've heard a lot of people say that if I have type 1, I have to only get married to another person who has type 1. And what are your thoughts on that, just to break that bit?
I think it's absolutely your choice. You love a type 1, you marry a person with type 1. You love somebody without type 1 diabetes, you marry that person. And in arranged marriage, again, it's as a process goes. So absolutely not. Out of my 100 or more kids, I think only 1 or 2 are type 1 couples. Everyone else is not with type 1 diabetes.
Yeah.
Life is good.
Yeah, absolutely. Amazing. Thank you so much. It was amazing. It was absolutely stunning.
Thank you.
All right. So our next speaker is Dr. Krishnan Swaminathan. He is the consultant endocrinologist and president at KMCH Research Foundation and the founding trustee of Ideyangal Charitable Trust, which is based out of Coimbatore. So over to you, Doctor.
Dr. Krishnan, can you hear us? Hello, Dr. Krishnan.
So while Dr. Krishnan comes onto the screen, I just want to let you all know that he's going to be talking about financial rehabilitation. Dr. Sarda also covered this point in marriages and diabetes, which I think is really, really important to consider, because there is a huge financial implication in living with diabetes.
Hello, Dr. Krishnan. Log out. Ho.
Looks like there's some internet issue.
Yeah, Dr. Krishnan is just having an internet issue. Yes. We'll wait for a minute or two.
Can we move to the next topic and then we can have that topic?
We could do that. Do we have Dr. Daniel?
Listen, is he available? Nirav, can you confirm that Dr. Daniel is there or not?
No, sir. Dr. Daniel is not joined. We're having a record.
Sanket has joined. Sanket has joined. Sanket may take the lecture. That is the 4th one.
Right. Shall we do that then?
Yeah, I'm fine with it.
All right. Perfect. Okay. So I think we move on to the 4th topic of the day. So we have Dr. Sanket Pense over here. Right. He is a consultant diabetologist, Diabetes Clinic and Research Center, Srinivas in Dhantoli. And he's going to be talking today in hurdles in career and possible solutions, because we've heard this quite a lot of times that if you have type 1 diabetes, you cannot do this particular job or you're not fit for this. And I think as people living with diabetes, we often get a little bothered and annoyed when we hear that. We said, if we have a degree, our health condition shouldn't matter too much. So Dr. Sanket, over to you, and we would love to hear this talk.
Thank you so much for this opportunity. I'm really glad to be a part of this wonderful conference. Let me share my slides first. Are my slides visible?
Yes, they are.
So, Jazz City said that my topic is hurdles in career and possible solutions. And like she said that my talk will be pertaining to type 1 diabetes only and nothing to do with type 2 diabetes, because type 1 diabetics, they face a problem or hurdle in their career development and also in employment. And when we refer to any textbook of diabetes or medicine, we always see that type 1 diabetes management is always insulin injection, which is the treatment of choice. It is also said that monitoring of blood sugar, screening for complications, diet and nutrition is also part of treatment. But the most, I think this is the 50% of treatment, and 50% or more half is psychosocial support, which is required for many patients from time to time, rehabilitating patients, making them self-reliant so that they can have financial independence, supporting the parents, giving them motivational intervention, and also preparing patients for various life events is equally important. And I believe that if we address all these issues, it has an indirect impact on better glycemic control. So all this is also a part of treatment of a type 1 diabetes patient and should be addressed by the treating team. Now, most of us has seen this movie in India. It is Three Idiots, and the entire theme of this movie was revolving around development of career of an individual. It is often decided in India that career is this boy or this girl at the time of birth will become a doctor, engineer, etc., etc., or join the family business, etc. And it is an extremely stressful phase of one's life, especially in India, because most of the times career is decided by parents and other people and not by the individual themselves. And if we add type 1 diabetes to this, then the hurdles are magnified by leaps and bounds. That is what I believe, and that is what I will talk about. So I will look at two case stories of my patients. One is a 17-year-old boy from a small town in Madhya Pradesh who was newly diagnosed with type 1 diabetes with the typical symptoms. And his father was entirely worried about how he will do in his life, how will he manage his diabetes, is there any other option from insulin? But his only worry was whether he will be able to pursue his career in army, for which he had been undergoing physical transformation for past 1 year. And as we know that army he can't be pursuing, so his dreams were shattered with the diagnosis of diabetes. That was his only worry. He was repeatedly asking whether his insulin will be stopped and whether he will be able to pursue his career. And the second story is of another 18-year-old girl who has been a bright student throughout her life, standing first in every class. She had diabetes for 10 years and she was also managing her diabetes very well. Now, at the end of her 12th year exams, she faced a dilemma. She got admission for engineering in IIT Mumbai, which is one of the top 5 institutes, versus VNIT, which is a very good institute, but not in top 5, but it was in her hometown. So there was no other problem, but finally she went for the second option, which was not the topmost option, but that is her hometown because of only one reason, that was presence of type 1 diabetes. So her parents were little apprehensive whether she will be able to manage her diabetes, whether she will be able to pursue her education, etc. So these are the problems that most of our patients face. Fortunately, both the patients are doing well today, and this I'll proceed further. Sorry. Yeah. So the relationship between type 1 diabetes and job, employment, occupation is a two-way. That is, occupation also has an impact on type 1 diabetes, and type 1 diabetes also has a negative impact on occupation. And it has been studied in the Swedish childhood registry, which showed that there is a negative impact on employment, and the earnings can be reduced by 9 to 10% for both men and women who are young adults with diabetes. And if the duration of diabetes is more, if the age of the individual is more, then the impact is even more pronounced. So lesser the earnings if the age of duration of diabetes is more, or if the age of the patient is more. And they found that there were several mediators responsible for this impact. One was the direct effect of diabetes due to repeated hypo or hyperglycemia, fluctuations in sugar levels. The patients required more sick leaves and hospitalization, leading to absenteeism. Type 1 diabetes is associated with lower school grades, more school dropout, and less likelihood for pursuing university education, again impacting the career and job opportunities for an individual. And patients are more likely to opt for safer occupations where the time duration or working hours are less, where they don't have to pursue a field work, and probably then such jobs will pay them less. And certain occupations, like I said, army or pilots or pursuing loco pilots, etc., all these jobs are not possible for an individual with type 1 diabetes. And another problem that has come forward is concealment of type 1 diabetes at workplace, which was put forth by the Finnish study, where almost 20 to 30% of patients in a developed country like Finland, they conceal their diagnosis from their colleagues as well as managers. And the patients, they reveal that they don't want to look different from others. They want to be a part of the system. They don't want to get stigmatized. Or what will happen if, because of diabetes, if they lose their job, then will they get another job? So all these thoughts were mentioned by the patients in this study. And but there are several perils or important implications of concealing diagnosis of type 1 diabetes at workplace. For example, patients in our OPD, we see that they are likely to skip afternoon dose of insulin because they are at work, or they insist that they should be given twice a day insulin, which is not very ideal for type 1 diabetic patients. So this can lead to a poorer control of diabetes. Secondly, whenever the patient's blood sugar drops very low, if he develops a severe hypoglycemic event, the colleagues are the first people to attend to such a patient. And if they are not aware about it, then they are likely to think that the patient is either intoxicated or he might be having some serious illness, and his treatment correction of sugar levels can get delayed. This can have serious health complications, health consequences. So it is important that considering diagnosis or revealing the diagnosis to your manager and few important colleagues is very important and should be emphasized to a lot of patients who are pursuing their career and job. And some of the observations from our clinic, we have seen that girl child with type 1 diabetes, the hurdles are amplified. Many times preference, education, pursuing career, pursuing education out of their hometown is preference is given to siblings who are non-diabetic. And many patients, they are likely to fail their medical assessment if their blood sugar levels are found to be high. So all these hurdles are faced by most of our patients with type 1 diabetes. And I will look at some of the possible solutions now. So I will highlight some of the attempts that we have done at our NGO Dream Trust and some solutions which can be done by all of us. So at Dream Trust, we started providing educational scholarship to school children to prevent school dropout. And we have given school educational scholarship to almost more than 150 children. And this has led to a steady decline in school dropout rate from 60% in 2 decades back to almost less than 10% now. And these are some of our success stories. One can see that someone is dentist, many of them are nurses, they are pursuing sports as a career, etc. And the other aspect that we have looked at is rehabilitating young adults who did not pursue their formal education, dropped out of school. We provide them funds to start their own small scale business. And more than 100 such individuals have benefited so far. And these are some of the examples where they have started their own dairy business, tailoring business, or cloth business, etc. And they are now completely independent and financially independent. They are supporting their parents and their families. And as caregivers, providers, NGO support groups, and individual physicians, pediatricians, one should include motivational intervention and motivational interviewing for most of our patients who require, who are in the phase of adolescence, planning to pursue their career. And one should identify which patients will require some type of more experienced career counseling. One should also provide psychological support so that patients are able to cope with their, they develop coping skills, they are able to counter depression, and there should be easy availability of mental health professionals. Now, this is very important that last 2 decades have seen an exponential rise in the awareness of type 2 diabetes among the general public all across India. But the awareness of type 1 diabetes has not increased as such. And if we, all the NGOs, government, everybody, even parents of type 1, they start increasing the awareness about type 1 diabetes, then the acceptability of these individuals will be much better in the society, and more likelihood that patients will get a better job, as well as other aspects of life. And in US and UK, type 1 diabetes has been classified as a disability, because of which they get several benefits, such as they get protection, they cannot be probably removed from their job also, or they cannot be discriminated against, they get free eye checkups, etc. So there is no such provision in India, and there is a small movement happening probably in India, but not yet, which is also like approaching the government to include type 1 diabetes as a disability, which will provide more benefits to individuals with type 1 diabetes. And so with this, I would like to give my key messages that raising awareness in the society can help us to improve better, give better chances to type 1 diabetic patients. Implementing a law, probably making it a disability, can give some provisions for type 1s. And at the level of NGOs and physicians, psychosocial support, career development, career counseling is very essential. And probably free medications should also be provided from the government so that all that expenditure can be diverted to development of career and job or business of an Indian individual. Thank you.
Wow, thank you. Thank you so much, Dr. Sanket. That was very, very well explained. And I think Nupur and me, we have heard stories of discrimination in workspaces. So I think you very beautifully outlined what can be done, but what would be your one like key message to somebody living with type 1 diabetes who is in an environment where they have been discriminated against at work? What would be your just 1 or 2 tips for them?
Yeah, if they are facing discrimination, like just in the previous speaker said that we can overcome hurdles. Dr. Archana Madam said that we can overcome hurdles by more discussion, being open about it, and talking to people. Probably people are not educated what is type 1 diabetes. Type 1 diabetes absolutely like any other individual who is just taking some insulin shots, and their entire life is absolutely normal. They can go through all the various life events just like anybody else. So we just need to educate those people who are unaware about it, and hence they have their own notions about it. And that is the only way, probably by more openness, more discussion, that we can counter this kind of discrimination.
Yes, lovely. Thank you. Thank you so much. Nupur, over to you.
Thanks, Jazz. Thanks, Dr. Pense, for those wonderful points, and thank you for the work you do through the Dream Trust. I do follow, on social media, and lovely work. Thank you. Next up, we have Dr. Krishnan Swaminathan. He's the consultant endocrinologist and the president at KMCH Research Foundation and the founding trustee at Idayangal Charitable Trust in Coimbatore. Dr. Swaminathan will be talking to us about financial rehabilitation. So over to you, Doctor.
Due to technical reasons, Dr. Krishnan has dropped out, so we will go to the next talk. Over to you, Nupur.
Next up, we have Dr. Daniel. He is the assistant lecturer and specialist in conservative dentistry and prosthodontics. He's the faculty of dentistry as well. And he's the mentor at the IDF Young Leaders Program, which we all know about. Dr. Daniel is going to be talking about psychosocial issues, challenges, and how to handle them. So, Dr. Daniel, over to you.
Hello, everybody. Thank you very much for the kind invitation from my colleagues and from my great friends from India. And it is my pleasure to speak about psychosocial issues and challenges and how to handle these challenges in diabetes. My name is Dani Aveg, and I'm a dentist, but also I live with type 1 diabetes for more than 10 years. And I'm working at the Semmelweis University, Budapest, Department of Prosthodontics, and I'm also volunteering for International Diabetes Federation. I work in the Young Leaders in Diabetes program as a mentor. So this is a very important topic, and I think that all of us have these challenges during our life with diabetes. Let's go through my topic and let's see what the details are. When we talk about diabetes stages, the most important stage is the diagnosis. When we get all the information about our disease, it needs a time schedule when we accept the condition. Some of us is easy to accept, and some of us it's very complicated, and this acceptance of the condition causing further complications or other problems, which I will detail in the upcoming slides. And after we accept or we are dealing with our condition, we can plan our future and we can get with it, and we can live with diabetes. If you look around the literature and the academia, this topic is a core element of the diabetes care, psychosocial care for people with diabetes. On the slide, you can see a position statement of the American Diabetes Association, who are describing a lot of clinical symptoms and also behavioral symptoms, for example, mood and anxiety disorders, psychotic disorders, and it has a lot of influence on the mental issues. So mental problems can be occurring, and the stress because of the diabetes management and other factors are very, very important. So for us, we need to understand that if we are having or living with diabetes, there are a lot of factors from jobs to family support to blood glucose management, which can influence our mental issues or mental status. And these factors are very, very important. If we move forward, we can see that not only the American Diabetes Association, but other countries, for example, the UK, has also a lot of studies and a lot of educational outlets about this vicious cycle of depression, for example. So diabetes and depression, mental status are working together. And we can see that only the diabetes is also causing some problems which increasing the anxiety, the depression, and for example, poor diabetes management and diabetes-related complications can worsen this status. The depression has a lot of stages, for example, lethargy, lack of motivation, extreme mood swings, low energy, and indecisiveness. These are partly associated with hyperglycemia. So if we have a bad situation, both extrinsic and intrinsic factors, we can see that the diabetes control can be also worse. And there is a bidirectional relationship between behavior and depression, and I think also with glucose levels. There are a lot of studies which has evidence that people with diabetes experience higher rates of mental health issues, both in type 1 and also type 2 diabetes. And statistics says that depression affects 1 in 4 adults with diabetes. In my lecture, I try to find reasons behind it. And I also, because I live with diabetes more than 10 years, I would like to give you some advices from my experience, how we can decrease the chance to have mental issues. And some people, so almost 25% statistically has depression because of diabetes. This is a very important issue, and I think that it has to be examined more. When we move forward, we can see that NHS England, which is a huge medical association, diabetes and mental health is also a very important topic, and they also have a helpline. So if you have problems with diabetes, you are able to ask help, and you can ask help from NHS England, or you can, this is Diabetes Australia, they also have emergency line in case of you have serious problems and you don't have anybody to talk with. This is also something which is a crucial point. I think that in some point you need to ask help if there is any problems, if you are not able to handle your disease. And I think that communities like your local association, your doctor, your type 1 diabetes community is able to help you. And if you have problems with your insulin, with your blood glucose, and you have questions, because all of us have questions with the nutrition, with the insulin dosage, with the blood glucose meter, with the lifestyle, you are able to ask. So people are living with diabetes longer than you, has maybe wider experience, and together you can be stronger and you can help each other. what are the problems which can also be a factor? I think the age of diagnosis is very important. So if you are diagnosed in a younger age, it's more complicated. I was diagnosed when I was 19. So when I was 19, I was in a situation when for accepting this disease was not too complicated. However, it was also a big shock for me and my family. So this is the second point, that family and friends support is very important. If you have this support, everything is much easier. You need to have a proper job or a proper education. So because of diabetes, everything is a little bit different from that point. And then you need to find that kind of job and that kind of education or part of the work where you feel yourself comfortable. I will detail this more later. Lifestyle is also very crucial, so you need to take care about your lifestyle and do your best to keep your blood glucose levels in the proper time range. Blood glucose levels and access to insulin, access to diabetes technology, the hyperglycemia and diabetes technology is very, very, very important. And also living a healthy life is something which has to be a focus on your life. I would like to give you a short example of my story. So I was diagnosed with type 1 diabetes, not in 2019, in 2009, sorry, so more than 10 years. And my family helped me a lot. We immediately changed our nutrition. So the diet was changed for the whole family. There was no two options on lunch. My family changed their lunch for the way I have to eat it. So everybody ate the same, which helped my family also to live a better quality of life. They had a better nutrition, but I didn't see that, for example, my brother is eating different food, and this helped me a lot. However, I didn't expect this. My family did it for me, so it was something which is very emotional for me, and they helped me a lot through my process. We ate more vegetables, and my mother cooked with less carbohydrate, and we had meat and low carbohydrate and vegetable rich food. This is very, very important. And diabetes also had an influence on my education. I was used to be a surgeon. I studied for general medicine, but after I was diagnosed with diabetes, I changed my plans and I transferred myself to dentistry. And now I work as a dentist, which gave me independency, which means that I can have a break even between two patients. I don't need to stand hours long in a surgery room or operational room, which was back at the time not possible. We didn't have the sensor, for example. And as a dentist, it's easier for me to handle diabetes. And I suggest you also the same. So try to find the proper job for you and concentrate on the education. I will show you what I mean. So this is a very important slide. I would like to share with you that on the left side, we are seeing someone who is climbing the Mount Everest, and in the right side, somebody who is doing average sports and having an active lifestyle. So this is very, very important. I believe that with diabetes, we need to understand our limits, and we don't need to push our limits until the end. So climbing to the Mount Everest with diabetes is maybe not a good idea. However, there are some people who are challenging themselves and trying to go to the Mount Everest, but I think this is out of conform, and it's very, very risky. So we don't need to climb the Mount Everest, but I think that it's very useful to have an active lifestyle and do sports in an average way. So we need to choose the right circumstances when we are living with diabetes. This will help our social and psycho-social issues. When we are having questions about work, I think we need to find the best possible job for our condition. So our condition, of course, not limiting ourselves, but in a way we need to consider that we have to find a job which is in a safe environment. We are doing no night shifts. Because night shifts are a very bad influence on blood glucose levels. I did a lot of night shifts in the university when I finished and I was a resident, and it has a bad effect on my blood glucose levels. And this is just something which we need to avoid, no night shifts. I think heavy physical work is also not necessary. So if it's possible, then we need to find some job which has no heavy physical content. And I think also that there is a risk working in a kitchen or working in a restaurant or a confectionery, because a person who has a diet control or having a strict diet, it's not good if we are moving around the kitchen or moving around the confectionery and seeing that carbohydrate rich food and cakes. Maybe we need to avoid this, but these are just advices from me. For education, we also need to plan carefully. And if you choose the higher education, this is an option to have a better environment. So if you are living with diabetes, I think that maybe the best advice is to concentrate on your education, your studies, and try to get in the higher education, or find an education which give you a good chance to have a good job. I think languages and skills are very, very important. And I think that earning a degree or having postgraduate studies in maybe a PhD, this is also something which is like a passport. So you will have a job after you finish your studies. Maybe in India, maybe in other countries, if you are good in language, the world is not limited. You can work anywhere in the world. I think that this is also something very important, that instead of Mount Everest, climb your educational Everest and get as much education as possible to have a better and probably a more comfortable life for yourself. I think that I live as a dentist. I work as a dentist. It's very, very good for me, and I can mount my Everest. I can climb my Mount Everest in dentistry. Of course, there are other challenges, and I think you can speak openly about your metabolic status, because we have a responsibility to educate our friends and our community. Having a partner is providing us stability in our personal life, and I am very lucky because I have my family support, my brother's support, and my wife Doris' support, and my friends around me who are also very supportive. If you are looking for help, I think diabetes communities are very important. Your local associations, international diabetes camps or courses provided by the IDF, just like Young Leaders in Diabetes program or Blue Circle Voices, and it can help you find someone who is helping to assist you and having the same insulin, blood glucose meter. And if you have problems with something, it is easier to ask a friend than a doctor. Young Leaders program is an example of this, and if you want to join, you can search your diabetes association and they will help you to join this program. Thank you very much for your attention.
Thank you, Dr. Daniel. That was very wonderful and very motivational, not only as a doctor, but also as a person living with T1D. I think it's great advice that you've shared. And I especially like that part when you said, it's not necessary to climb Mount Everest, even if you do whatever you pick in your life, as long as you have that work-life balance and you're happy, that is enough as well. Yes. So if Dr. Daniel is around, a quick question for you, Doctor. So what kind of communities did you have while you were diagnosed?
Hello, everyone. Can you hear me?
Yes.
Sorry for this noise, but I'm in a car at this moment. First of all, welcome everybody in this Congress, and this is a huge honor to be here. And my friends, Dr. Patel, who invited me. I think the most important community is around you. So local diabetes and the local type 1 or diabetes communities are very, very important. And they can help you to find the right direction to your volunteer work or your skills, which can help your community. So I think that you should join and you should give back to the community with voluntary work, what you can offer to this community. And I think it will be successful.
Absolutely. Thank you so much.
Thank you so much. And now, hopefully, we do have Dr. Swaminathan with us over here. He is a consultant endocrinologist and president of KMCH Research Foundation. He's also the founding trustee of Idyangal Charitable Trust in Coimbatore. And he will be talking about financial rehabilitation for those with type 1 diabetes, since we know that there's a huge financial burden to those who live with type 1 diabetes. So, Dr. Swaminathan, over to you.
Thanks, Jez. Are you able to hear me loud and clear?
Yes, we are.
Great. I hope I'm third time lucky. I went
yes, third time's a charm.
And I'm in a dark room here, so you may not be seeing me properly. I still remember talking to you a couple of months ago. We had a good chat one day, and yes. Thank you, Yash, and the whole team for the invite. And I have got nothing to do with finance.
I think you're stuck, Dr. Swaminathan. Is he stuck only for me or is it for everyone?
No, for all, I think. Even I can't hear you. Yeah.
Okay. And zero in finance, my wife keeps reminding me that. So I'm just going to try my best to try and help our patients. Can you share the screen now? Yeah. Can you see the screen?
Yes, we can see it.
Audio is okay?
Yes, it's fine.
Right. So I talk on behalf of Idyangal Charitable Trust. It's a 12A, ATG and a CSR approved trust. And I'm going to talk about the financial rehabilitation part of it. So the next 10 minutes or so, I'm just going to outline what it is to be poor, because we have a huge rural catchment area and have type 1 diabetes, 3 small stories, and our experience at Idyangal Charitable Trust. And I keep telling this story all the time. I never get bored about it. So after 16 years in the UK, coming back to a place like Madurai, this 7-year-old boy was actually declared dead at a government hospital. And his glucose were more than 800. He was in cerebral edema. And these parents were bringing this little child in an auto for his final rites. And I was working in a corporate hospital. They were passing the emergency. And I don't know what made the dad get an intuition to bring this child to an emergency. And his mother behind, you can see in the photograph, he fell on my feet that day saying that, "Doctor, my son Arjun has got his 8th birthday in the next couple of days. And I think I'm the only mother who's going to have his birthday and his death anniversary on the same day, doctor. We don't have any money. I don't even know why we came to your hospital in the first place. Please help." So on the cardiac tracing, he was in pericardiac arrest. His heart was not completely stopped yet. So we started resuscitation. And on his birthday, he had a rebirth. And this is the photo that we took on his birthday with balloons and all the things around. On the first time, the mother had tears of joy. And this was a present coming from Arjun every year from then on. He's now 13 to 14 years old, doing extremely well in his education as well as insulins. And I keep thinking that there are certain things that money can't buy. While we are on the financial rehabilitation part of it, as doctors every day, we think money is all, but no. And this is the next story of Manigandan and his heartbreaking umbrella. Again, for want of simple money to buy the basic insulins, this child had end-stage renal failure, didn't have money to buy the insulin. And by the time he was 20, he unfortunately had to leave us. And this was the present from his dad 6 months later with a beautifully written note to me. "Dr. Swaminathan, Manigandan wanted to give you some present every time we came here. But now that he's not here, this is a small gift on behalf of Manigandan." And I really think as doctors And as people interested in type 1 diabetes, we should stop these stories from happening. And the last story, Satya Prakash, this boy, again, 25 years of age with end-stage kidney failure, again, due to lack of finances, poor insight into diabetes, lack of education. By 25, he had a renal transplant, and unfortunately that got rejected. They had to sell their house. We from the trust supported him as much as we could, but he held my hand to die. And there were three things he asked. Number one, doctor, thank you for all Idengel supporters for supporting me over the last 2 years. Number two, please take care of my child. Please support her education till college. And number three, ensure that there are no more Satya Prakash's, doctor. You've got to work day and night to prevent this from happening. So we are really passionate about making a change. What is the pain of a poor family in India with type 1 diabetes? The average dad's earnings in our part of the world is somewhere around 8,000 to 10,000 per month. If you're going to give the best analog insulins, it's going to be around 3,000 per month with 1,000 rupees on consumables, finger prick, glucometers and everything. One DK admission in a corporate hospital where higher chance of saving life is around 1 to 1.5 lakhs. Kidney failure is around 7 lakhs per month, and we can't put a cost for a child's life. So how are we going to change this from happening? So a lot of times people look the other way around and say, there's nothing I can do, but I think we can do something about it. So we really need some Indian solutions to Indian problems. That's the reason why any meetings I go in a dhoti rather than a coat or suit. I think in India, we've got to use the dhoti. So what is the current scenario in government hospitals where most of these poor children are being seen? There's very suboptimal diabetes education. And again, I'm not blaming the system. It's very difficult from their point of view as well. And insulins are given in vials and syringes, which are very painful. And a lot of our severe diabetic ketosis admission is for want of a 5,000 rupee fridge at home because they don't know how to store their insulin. It's kept in hot temperatures, and children are on around 100 units of insulin per day with glucose of 500 to 600. Most of these poor children don't have any glucometers. They come once every 3 months to check their glucose. Major admissions with DKA, and we don't have any data or registry to know how much are surviving and what the issues are. And this is Shaktishwaran with end-stage kidney failure, but he recovered really well with our support, and we need to prevent this. So what are the focus areas I think we should all be concentrating on? The immediate short-term insulins and consumables, because trying to get government to supply these things in pen-filled cartridges is going to be a long process, but we've got to start doing it. I really believe health insurance is one way forward. I'm going to say how we have got around this. Insulin pump therapy for deserving children, we are very passionate about it. We have supported more than 200 fridges now, and that has reduced our admission rate by around 80%, just supplying a fridge to the home. And again, as Pensi team pointed out, educational support is very important. We need to support them with placement as well. And we can't do everything. The ministry, the central government and the state governments have to do it as well. Charitable Trust about 3-4 years ago with around 8 to 10 children. And this is us yesterday at Tirupur Government Hospital, and this is Coimbatore GH. So we have taken over all the government hospitals in our area, and we are supporting close to 100 children from government hospitals. We are giving them the best insulins, all in pen-filled cartridges with 4mm needles. We are giving them fridges for all those homes without a fridge. We are giving a free glucometer. It's a state-of-the-art glucometer with 50 glucose strips per month and a 24/7 telephonic support. We've got 3 phone numbers that they can call, and every day we call them. And it's just amazing what changes we see. Again, this is a kid, Padma Priya. She lost her eye because of mucormycosis, because of poorly controlled diabetes, now holding a HbA1c of 5.5 on basal bolus insulin. So it can be done. And I've spoken with the Star Health Insurance Medical Director, Dr. Prakash. He's a MMC alumni and senior of mine. So it's a very unique program, and I'm very happy for anyone to get in touch with me, because all our children are covered by Star Health Insurance for 2 lakhs per annum. So they waived off all pre-existing conditions, including type 1 diabetes. And that's 2 lakhs for any admissions, irrespective of diabetes or no diabetes. So this kid, Ramya Bharati, was saved because of the Star Health Insurance. She had severe DKA. Vasanta Sri lost her ear, but we were able to save all these people because they all have the health insurance cover. And please let me know if anyone wants to join hands with me. And again, this is Ramya from Coimbatore GH. This is her house. They've got a small hut, living with a grandmother, no parents. And she was again declared at a government hospital here. So we went to her home. We educated them. You can't get a fridge because there's no electricity. Thatched roof means no electricity. You can't get in a line. So we went to a nearby shop and put a fridge there. We trained the whole village on insulin injections, and now she's doing fantastically well. So just a simple helping hand with a few little things make a big difference. So again, as I told, our fridge program is pretty big. We have given more than 200 fridges across the state. And insulin pump therapy, I can confidently say that we are the largest in the world in terms of insulin pump therapy for rural underprivileged. So we've started around 140 insulin pumps for the poorest of the poor. So these are all our children, all given up school for 2 years, glucose of 500, 600 and HbA1c of 16%, now doing fantastically well on pump therapy. So we support them with insulin pumps, along with the around 8,000 to 10,000 rupees per month cost as well, month on month till such time they get gainful employment. And first time we are seeing tears of joy amongst parents. So Darshini, for 6 years had type 1 diabetes. She couldn't wake up. This kid would be crying all the time. And now she had early diabetic nephropathy as well. With the insulin pump, you can see the glow in her face, and all the nephropathic changes have completely reversed. Swati had 15 admissions with DKA over the last year in government hospital, and she's doing extremely well as well. So we have always been used to being saying no, no, no in India. And I really think we should change it to say, yes, we can. So these are all our advanced insulin pump program. Now our rural child from 200 kilometers from Coimbatore can say, uncle, this is my basal, this is my bolus, this is my ICF, insulin carbohydrate ratio, and this is my insulin sensitivity factor. So they are super smart kids. Their IQ seems to be much higher than any average kids that we see. And again, supporting college education is very close to our heart. So we are supporting around 25 girls, especially with type 1 diabetes, with college education. And again, this is me meeting Dr. Harshvardhan before the COVID. He had sent it to the NCD ministry, but because of COVID, we are not able to do it, but we are working on it at state and central levels. So I just want to finish my talk by saying that I really think there is a huge amount of work that we can do, immediately focusing on insulin and consumables. Health insurance is a big area. Pump therapy, I think we are getting there in terms of supporting many rural underprivileged children. Fridges is something I want all healthcare professionals to think about. Not many doctors ask whether you've got a fridge at home. Educational support, placement, and ministry level intervention. So at this point of time, please visit idayangal.org. 350 underprivileged children across the nation are being supported. We are supporting in Punjab now, Maharashtra, Gujarat, Kerala, Karnataka, and Tamil Nadu at this point of time. So anywhere you see a poor child with type 1 diabetes, do let us know. No caste, creed, religion, or state. All is one. 1.2 crores worth of analog insulins per year. 2 crore worth of insulin pumps, annual insurance cover, educational support. We are supporting a lot of government hospitals, and we run the Attitude Club to make sure that these children lead a normal, healthy life. So I just want to finish by saying that instead of saying you must be the change that you want to see in the world, we have to live the change that we want to see. And we are seeing such amount of positivity. I really believe doctors, farmers, and the industry should do more to try and reduce the financial burden of our families. Excellent diabetes education is the #1 priority. I think just doing that, even forget the insulin pumps, just teaching them how to inject their insulin, how to recognize a hypo, how to store your insulin, reduces the financial burden in a big way. And at the end of the day, we are mere mortals. We need ministry level intervention to try and change the landscape of type 1 diabetes in India. Thank you very much for your attention.
Thank you so much. I think before anything, I would just like to salute you for the work you're doing. And I think we always say that there are stories behind the statistics that we keep hearing. And I think it's very important that you shared those stories with us today. And you're right, this shouldn't happen to anyone who's living with type 1 because we keep saying that health is a right. It's not a privilege for a select few. So thank you so much, Dr. Swaminathan. I think that was very inspiring to all of us. And if we can, I'm sure, I think Nupur and me will be getting in touch with you and seeing how we can work together or hold hands and do this together. I think the insurance thing you said is a big eye opener for all of us, and I'm sure we'll get in touch. Nupur, any questions? Again, just absolutely stunning. Thank you so much for giving us that inspirational boost that we needed today.
Thank you, Jess. Thank you.
Yes, I totally agree with Jazz. Doctor, thank you very much. And I'm really so glad, like Jazz said, third time lucky. We are really privileged to have seen your presentation and know more about the work. Just nothing except a big thank you from both of us and the community.
Totally.
Thank you, Nupur. And all I'm requesting is let us partner together, as Jazz rightly said. I think if we join hands together, we can completely change the landscape in India. At least start making a change. Thank you.
Absolutely. Right. So that was our session. Thank you so much. It was absolutely stunning. And I think Nupur and me both enjoyed this session very much. Nupur, closing words from you?
Big thank you from Jazz and me, especially because this conference really focuses on the NGOs in diabetes care, and I think it's a really unique and wonderful concept. So thank you, Dr. Yash, Dr. Sushil, the whole organizing committee, from us, from the people living with diabetes. And as we saw in a lot of the previous presentations, to be people-centered is really important. And I think this conference is exactly that. So a big thank you.
Thank you so much, both the chairs. You were really, your hats off to you for your enthusiasm and involvement. That was really infectious. Thank you so much. And I really want to thank the speakers. That was very pertinent discussion we had in the last session, because the career, the marital issues, psychological issues, they are very ingrained in the type 1 diabetes. And being in corporate, even I can share that I'm saying is different and doing is really different. We have seen people who were PhDs with type 1 working in the corporate world. I mean, you hear and say most of the time, okay, this they can do, this they cannot do. So discrimination is one thing that we really need a lot of efforts to overcome that challenge. Thank you so much once again for the session. Let's move on to the next session. And for this important session, I would want to invite the legends in their areas, Dr. Pankaj Shah, Vice President, Gujarat Cancer Society, Trustee Sadvichar Parivar Ahmedabad, and Dr. Mayur Patel, Chairman and Chief Diabetologist, Swasth Diabetes Care and All India Institute of Diabetes Research. Over to you, sirs, for the next session.
Thank you very much, ma'am. I am just listening the whole session for last 1.5 hours. And I feel that whatever the field in the diabetes awareness is being done, we must try to get it replicated for the cancer awareness also. I have spent most of my time, about 45-50 years, in the cancer awareness. And for the diabetic awareness, now as a trustee of the Sadvichar and the president of Sadvichar Parivar, my priority is health. And in health, the priority is the senior's health. And the senior's health, one of the important aspects is the diabetes, blood pressure, and other diseases. So with this, I feel I'm really I'm thankful to Mayur Bhai and Rajesh to thought of me and involve me in this particular NGOs related diabetic care. And we are probably doing them almost the same thing. Why not to do it together? And there are points also here in this particular session. I request now Mayur Bhai to initiate the session with the introduction of the first speaker, Dr. Mayur Bhai.
Good evening, good afternoon, good morning to all. It is always a proud and pleasure to co-chair with Dr. Pankaj Shah. He is a Padma Shri awardee for his dedication to the field of cancer. Now we are starting the session 10, Diabetes Prevention and Awareness, a big task ahead. We have speaker Iriana. She is Associate Professor, Vice President, International Diabetes Federation for the year 2019 and 2021. She is international expert in diabetes. Now I'll request Dr. Iriana to present her talk.
Thank you so much. Thank you so much. Do you hear me?
Yes.
Okay. I'm very happy to be part of this conference. Thank you very much, Dr. Patel, for invitation. And I'm very happy with this conference because NGO is main things in our work. And as you say, why we cannot do together and make better outcome. I'm very happy with this conference because I see a lot of young speakers. It's great opportunity for them and for us also have the passion and feeling them enthusiastic and new idea. It's great. My talk, just a moment, I share my screen. Right. Happens. Right. Sorry, something wrong. Could you share my screen? I don't know why. Sorry for this.
We can share your screen, but it is showing email rather than a presentation.
But it's strange because we check everything. 1 second. I try.
You need to share a Zoom window, madam. Yes, this window. Down.
Yeah.
Dr. Iriana, if you require, we can share your presentation and you can just present it from your.
One second. If I cannot, because we checked before and everything. Just cool. So that's all. All right. Okay, please share my presentation. Thank you. Next slide. We speak about, I'm Irina Vlasenko. I'm Vice President of IDF, and also I'm a pharmacist, Associate Professor of National Medical Academy Postgraduate Education in Ukraine. And also I people who live with diabetes type 1, 25 years. In this case, I know a lot of personally and a lot of diabetes, and try to we spoke about professional career, and I try to use my diabetes for my career also. It's possible. Next, please. You see the significant economic growth in development countries has consequences. This major urbanization, mechanization, ingress of multinational food companies, increased affluence, and this everything is to change to lead to change to physical activity, greater push power, fast food, and food choice behavior. This is in big influence on our risk factor, lack of exercise, unhealthy eating, and overweight. Next, please. And now we have this situation with diabetes. At rapid escalation of type 2 diabetes, the burden of complication, both macro and microvascular, is substantial. The syndemic of diabetes with IHV or tuberculosis are prevalent and predisposed to each other. Screening for diabetes in large population may not be cost effective now, as we have like this study. The cost of diagnosis in scarcity of health staff posts are hardless in the diagnosis and treatment of patients, lack efforts for prevention of prevention diabetes, and quality of care is largely poor. Most patients do not achieve treatment goals. A delay is shocking high cost and non-availability of drug and insulin. Next, please. And future, we cannot smile because it will be increase in number of people with diabetes. Next. And economical impact on diabetes is big impact. And you can see and you can read in IDF Diabetes Atlas that analyzes this situation and also some prognosis that you can see that 2045 it will be twice but from my side now it's even will be worse because COVID situation change our also economic and financial stability. Next, please. And my strong opinion why I'm happy with this conference because change situation we can only by multidisciplinary approach and eradicate diabetes. And now I want to share with you innovative and low cost approach. Next, please. First of all, we must change or reform health system, build the political commitments and addressing health system constraints, development public policy in health promotion and disease prevention, creating new service delivery models and ensure equity in access and payments, having consistent guidelines for prevention and management of diabetes. Next, please. I got this, what we can use for our advocacy. This document, which was launched in April 2021, the Global Diabetes Compact. And yesterday, I especially maybe got this information because I'm involved in developing this document that they update these documents and what we can do. And you can use these documents. Then they recommend to strengthen and monitor diabetes responses with national NCD programs, including voluntary global diabetes coverage targets for 2030. Next, please. And also new documents which now NCD Alliance has drafted a global charter of meaningful involvement of people living in NCDC. The charter is an advocacy to mobilize governments, agencies, civil society, and relevant private sector to put people first. And now it's a draft. You can be involved and say your opinion about this. Go to this page. Next, please. One of initiative and low-cost approach and use health. According to the WHO, there are up to 7 billion mobile phone users in the world, more than 85% of the world population. Over 70% of them in low and middle income countries, very important part. And mobile technology holds great promise to transform healthcare organization by bringing clinical workflow, patient vitals, and healthcare delivery to the point of care. Next, please. And if you see a look on delivery technologies in diabetes, how many points we can improve and advancements in health delivery technology is significant opportunity to achieve better efficiency in diabetes care and increase patient involvement in diabetes self-management. Next, please. Another initiative, low-cost approach at delivering healthcare to the doorstep. Now it's big problem. I think it's in many of countries that many of people have not medical care, unfortunately, in the rural village and so on, big country. And I want to say, show that the Mobile Diabetes Center project was launched in Russia 2002, 20 years. They worked and the diabetes-related healthcare could be delivered at the doorstep of the underserved population. And patients with diabetes can be examined and get consultation from all specialists. Also, patients are invited to diabetes self-management school, and they work 20 years. Next, please. Also, mobile diabetic retinopathy screening and treatment models can be readily replaced for remove on rural area in developing countries and are cost effective. You can see we have this project in Ukrainian and to see the world in color. And it's great opportunity to check people with retinopathy in rural area. Next, please. This is mobile. Next, please. But now it's very important and modern innovative care models. Task shifting, provision of basic care and assistance by other health professionals. We use our resource very good, the doctor, because it's main person for patient, and also we great involve nurse and educators in patients care, diabetes care, but pharmacists we not involved too much, and I think it's a big problem, but we must improve the situation. Next, please. A lot of publication which show that a lot of input by pharmacists. Next, please. You see pharmacist is first line next to patient. This is I take from the Diabetes Canada Association. And there we must work together. Next, please. But unfortunately, communication doctor, pharmacist, and patient, and not so good now. And research shows that physicians are not yet aware of the role of community pharmacists as member of multidisciplinary healthcare team. There is lack of social and professional acceptance of community pharmacists and true healthcare professionals among primary care physicians, and the lack of knowledge about community pharmacist services. Next, please. But next, please. But pharmacists can do a lot for prevention. This promote awareness about diabetes, screen, test, refer patient to the doctor in time, promote lifestyle changing. Next, please. And the role pharmacists in patient safety. But I want to underline support of prescribing medication by a doctor and pharmacists as assistants of doctor. They cannot prescribe. Next, please. And this is World Diabetes Day in Pharmacy, which I organized maybe 20 years ago after this big network in Kiev. And this is great opportunity and awareness about diabetes, and also make screening and find people who has diabetes but don't know about this big problem, this type 2 diabetes. And now I involve my students for this great event. Next. And I come to IDF Global with this idea to improve collaboration for better outcome with International Pharmaceutical Federation. And now we have better communication, and now we involved in them documents. It's very important because we know about diabetes, but maybe not. And it's great if we have collaboration. Next, please. If you speak about prevention in intensive lifestyle intervention, diet and physical activity, and lifestyle modification. Next, please. But of course, I want to show this low-cost approach strategies using legal framework or government's action, including taxation. IDF framework for action on sugar that we support WHO conditional recommendation to reduce recommended sugar intake to 5 of daily energy intake. And this is a very important, our strategy, the public health campaign to educate people about the health risk association with excess sugar intake. And there is significant link between health information and food choice. Next, please. And this is very important part that food labels are important for people. People should know how to read food labels and consult them with making food decisions. This is must do doctor, pharmacist, and nurse and educator. Next, please. And I want to underline about about type 2 diabetes in youth. Type 2 diabetes is on the rise among children and teens. When youth develop type 2 diabetes, complications arise and accelerated pace. The risk of death is twofold higher for those who develop type 2 diabetes under the 20 years, new study. And yesterday we celebrate International Youth Day. That this year it's the name of transforming food system, and National Nations say that we need for youth to make informed decisions on food choice through the increased global education on the healthiest and the most sustainable options for people and the environment. Next, please. Of course, we recommend physical activity. We know this. Next, please. But this is must be from beginning. But lifestyle intervention is very big and slowly process. Next, please. What we can do with this collaboration with Diabetic Association, not government association, because public events are effective mechanisms for motivating people. I cannot missed this, lost this information about this, my favorite project, like football. I'm a big fan of football. I was director of the big first DAI Euro, maybe you know, and it was from start Ukrainian Diabetic Federation organized international championship in football for people with diabetes. And now we have 21 teams from 21 countries. Next, please. And finally, I will not repeat this this low cost approach, but very important collaboration between healthcare professionals, diabetic association, not government organization. Thank you so much. Next, please. And let's beat diabetes together. Thank you so much for your attention.
Thank you, Dr. Iriana. A very, very informative talk. And IDF is doing a great job and always at the forefront as far as the diabetes awareness and prevention is concerned. We'll keep Q&A session at the end. Now, next talk is by Dr. Mohan. He's a good friend of mine. He doesn't need any introduction, but he's MD FRCP, PhD SC, double DSc, and Chairman and Chief Diabetology, Dr. Mohan's Diabetes Specialty Center, Chennai. He'll be talking on reaching the last miles with diabetes awareness, feasibilities, and learning. He's the best person, I would say, in the India and even at the global level to deliver this talk. Dr. Mohan, please.
Thank you, Dr. Mayur Patel. I'll try to share my screen. I hope you can see my screen.
Yes.
So thank you, Dr. Mayur Patel. This is indeed a very unique conference because you have brought all the NGOs together. And as we heard from the previous speaker and from the others earlier, how much of diabetes care is really being done by NGOs and the civil society, and now with people with diabetes themselves. rather than the old concept of a physician sitting and writing a prescription. While that is also very much needed, I think diabetes care has now moved into the community. And so from that angle, I will try to speak something on 2 or 3 experiences of ours after thanking you, Dr. Yash Patel, and all the other organizers of this very important meeting and congratulating you. I'm going to talk about 3 things, and I'm going to talk about translation of research into action. And since you had talked about awareness, increasing awareness and prevention at community level, all these 3 projects were done in Chennai or in rural Tamil Nadu. And so I'll talk about these 2. The first 2 were done in Chennai city itself, and all have been published. So the first project is called as Prevention, Awareness, Counseling and Evaluation of the PACE Diabetes Project. And none of these 3 were funded by government. The first 2 were funded by an NGO in Chennai. And the third one is also funded mostly by an NGO, but also from other NGOs from abroad as well. And I'll explain that as we go along. So let's talk about the PACE project. So in the PACE project, the whole idea when we started this, as you can see, it was published in 2008. So it's about 12, 13 years ago when we did this project, was to just raise the awareness about diabetes. That's the kind of time a little earlier when WHO said diabetes should go public. That was a, that was a kind of slogan given by WHO. So we said, okay, let's really make it public. So we said, let's take diabetes awareness to 2 million people. At that time, the population of Chennai was 4 or 5 million people, if you take the inner Chennai. So we said, let's half of them at least, let us do that. Of course, half of them are children. So virtually all adults with diabetes, all adults living in Chennai. So we carried out free blood glucose testing to 76,645 individuals. And we did it everywhere, you name it, schools, colleges, offices, parks, beaches, mosques, temples, churches, you name it, we were there everywhere. And we did this massive program. We also trained 232 GPs because we felt that to carry this forward, we need to have the primary care doctor trained. So 232 doctors were trained. And in the community-based prevention program, which we piloted there, we took 2,000 people. Now, to cut a long story short, we had the awareness program, the awareness about diabetes, simple things like, have you heard of a condition called diabetes? Are more people getting diabetes nowadays? Can diabetes be prevented? Can it affect body organs? Now, these are questions which I asked before the PACE project as part of our cures study. And the same representative sample of Chennai, we now conducted this massive program, and the results were very encouraging because that's why the PACE, the E part of it, the evaluation part of it comes here. So you can see, have you heard of a condition called diabetes? There was a modest increase from 75% to almost 81%. But look at people getting more diabetes now, there is a big jump. But look at prevention of diabetes. Before we did this, only 1 in 5 people in Chennai actually said that type 2 diabetes can be prevented. They didn't even know that after DPP was published and after IDPP was published and everything. Now almost half of the people in Chennai know that it can be prevented. If you don't even know it can be prevented, how are you going to prevent it? And then can it affect body organs? And people said, what organ? It's just sugar, isn't it? So from 20%, it went up to almost 50% of people who now know that the eye and the kidney and the heart and the feet and the nerves can get affected. So that was a massive increase in the numbers. I'm not going to go into that. We have 3-4 publications on that, but I'm quickly, in the interest of time, moving on to the second one, which is the Asiad colony success story. This was our first epidemiological study that we took up, a very small one, about 1,000, 1,500 people in 2 colonies, residential colonies in Chennai. In Tirumangalam, we selected a middle income group, and this is how people would live there. Flats, some of them have cars, some of them have 2-wheelers. And so that's a kind of typical Chennai. About 80% of people in Chennai would live there. So it's representative of Chennai. Then we left the upper income group people out because they can fend for themselves. They really don't need us to go and teach them anything. They'll go to US for treatment. They'll go somewhere. So we took the lower income group. And this was a slum where we didn't expect much of diabetes at all. We thought they have more of, cholera and diarrheas and TB and alcoholism and infectious diseases. And we didn't expect them to have diabetes. You can see the conditions, living conditions here is vastly different from the socioeconomic status is very different. That's a low income group and that's a high income group. Believe it or not, at that time in 1996 or so, there was no study which had looked within a city at two different socioeconomic groups to see what is the prevalence of diabetes. So we called it as an intra-urban study. Our hypothesis was that there will be more diabetes in the middle income group because they have, they eat more, they are probably more obese, they have less exercise, they're more stressed, and all the things associated with diabetes. We were not wrong. In fact, 12.4% of people at that time, the paper was published in Diabetic Medicine 2001, 12.4% of people in that colony had diabetes, whereas it was only half in the low-income group. We didn't even expect 6.5 in the low-income group. We thought they'll be near zero, but we're quite surprised that they had 6.5%. Now, this low-income group was not really interested in diabetes. They had all their other problems they had. For them, day-to-day living itself was a big problem. So talking to them about prevention of diabetes was too early in those days. I'm talking about 20, 25 years ago. So we said, let's focus on the middle-income group. After all, that's where 80% of Chennai lives. And let's focus on this. So we had made a trajectory. And we said, okay, you know what? Because the prevalence of diabetes only 2%, 4%, 8%. Now it's become 12%. Who knows? It may go to 18%, 20%. So why don't we do something by way of mobilizing the community, and can we prevent diabetes if we do that? Now this is the colony, and just next to the colony was an empty ground. The place where I'm showing you there was an empty ground. It was a completely empty ground. So we said, because the people said there's no place to walk. Where will we walk? There are no pavements in Chennai. We'll get run down by a truck if you walk on the road, and so on. So we said, what are you going to do with this piece of land? Oh, that's for our next colony to come up. We're going to build Asiad Colony 2 there. We said, why don't you cancel Asiad Colony 2 and build a park there? So they went to the government and they asked money from the government. Government said, we have no funds. We can't build it now. We have no funds at all. So then we had several sessions with them. And we said, why do you need the government? Can't you do it yourself? Can't we all raise money ourselves and build a park? So they liked the idea. And then they said, there'll be places for children to play. Now your children don't have place to play. You don't have place to walk. It's not safe. There's too much of pollution. Why don't you do that? It was a unique experiment and it worked. For the first time that I know of in India, people pooled money to build a park themselves. And it turned out to be a beautiful park, as you saw, one of the best. They were not only built it, they also maintained it. And there was music played, and there were poetry written there, and so one of the most beautiful parks, because it's built with love. So then the next question came. Okay, this is all, you're going away from diabetes now. You become a politician now. You're building parks and you're building what's this to do with diabetes? No, they didn't go away from that. The whole idea was, will it change the behavior of people? Will more people do exercise? So what happened was that we went back to that same colony. We had done the survey earlier, and 13% of people were doing some form of physical activity before this park was built. After the park was built, when we went back 3-4 years later, this had jumped to 52%. So half of the people in the colony now, plus others from outside, were now using the park. So this represented a 277% increase in exercises. And when we published this then, this became a WHO story, that people built their own park, and it was written about extensively in newspapers, magazines, and then more and more parks. People started building more parks. Another 3 parks were built by residential colony. The government, then election was coming. The government realized, oh my God, people want parks. The government said, we'll build 100 parks for you now. The same people who said we didn't have money, now from not having no money, they built 100 parks. And they said, we are going to rebuild another 100 parks. We'll repair 100 parks. So this one colony led to 200 parks in Chennai coming up. Chennai became a city of parks, and a lot of people started walking. The entire culture of people started changing, and more physical activity started coming. And we've done a lot of studies on that. Now, this is the prevalence of diabetes, which, as we had predicted, this was around the time when we went to the Asiad colony, and we had predicted that the prevalence of diabetes would cross 20%. And quite rightly, over the years, the prevalence of diabetes did go up. So we then asked the question, okay, what did this building of the park do? Did it slow down the prevalence of diabetes in that colony? Can we now go back? It's a real life experiment. It's not a randomized clinical trial. But if we study colonies nearby, And if they have very high prevalence of diabetes, then if the prevalence is lower here, this must be due to the change in physical activity. So around that time, some just few miles away from there, similar looking colonies when we studied, same socioeconomic group, it was around 20%, 22% of diabetes had already increased. So we said, now let's go back to that Asiad colony and see what is the prevalence there. And we are very happy to find that from 12.4% earlier, there was only a modest increase to 15%, a small 24% increase. You may say, why did it increase when you had the activity going on? When they were older, it's the same people whom we are studying. They're 10 years older, and age is an irreversible or a non-modifiable risk factor. So there was a little bit of increase. Now let's go back to that other colony, the poor colony. Okay. Now there you remember the prevalence was much lower, 6.5%. So we said it's not fair not to test them, although we did nothing, but it becomes a quasi experiment. So let's go and see what happened to them. So we thought it may be about 8%, 9% using the same formula. We thought it may be around that. We were shocked to find that it had jumped from 6% to 15%. Now what's happened here? From 12% to 15%, 6% to 15%. If you look at it this way, it was double the prevalence now. Now it's equalized. So two things had happened. One is we said the good news is that because of otherwise in the rest of the colonies, it was 22% there. So due to this increase in the physical activity and some change in the diet as well, we're able to slow down the progression of diabetes in this colony. But the bad news is that we had left the poor people behind because we thought they didn't need it, and we were wrong. Now we know it's unethical to have done it. At that time, of course, they were not willing. 10 years had passed, and in 10 years, their lifestyle had changed. They had started getting scooters and two-wheelers, and they started getting bank loans. They had started, so their lifestyle had changed, and now has increased so much. So this is an example of prevention of gain. Prevention of the gain in the prevalence of diabetes was achieved through a real life experiment. This experiment has been widely quoted everywhere as what people themselves can do to change their lifestyle. The last one I'm going to talk about is a rural area. Both the things I talked about were urban areas. We felt we have to do something for rural people. So this is the Chunampet Rural Diabetes Project. Why should we go to the rural areas? Because 75% of India lives in rural areas, whereas 75% of the doctors practice in the urban areas. So there's a complete mismatch between the doctors and the population. And in rural areas, you have additional challenges like socioeconomic constraint, poverty, illiteracy, lack of access, transportation problems, and of course, lack of specialized diabetes care facility. Now, how do you ask doctors to go into a village and now you settle down there and you do private practice there? Nobody's going to do it. Many of these villages don't have electricity. They don't have water. They don't have proper schools. So doctors will not go. So that model is not going to work. So what's the model which will work? So we came up, we said, we have to have the 6A test and make it positive. That is, make diabetes care available, accessible, affordable, appropriate, acceptable, and accountable in rural India. If you're able to do that, then we have succeeded. There was no model. There's no model we could copy anywhere in the world in the rural area. So we said, let's develop our own model. So the model was the Chunampet model. Why Chunampet and where is Chunampet? Chunampet, now for those of you who don't know India, that's South India. If you don't know Chennai, that is Chennai. And the next district to Chennai is Kanchipuram district. And the blue dot there is Chunampet. It's just one village in Chunampet. Now, why did we go to Chunampet? I could not even pronounce it first. Why did we go to Chunampet? The zamindar, the owner, he owned the whole village. That's how it was in the olden days. One man owns the whole village. Thousands of acres he owns, okay? And this guy was a bachelor. So he called me one day and he said, Mohan, come and see me in Chunampet. I said, where's that? He said, you don't know Chunampet? I said, I don't know Chunampet. He said, okay, you come. It's about 120 kilometers, drive down, come and see me. I said, why would I come and see you? I want to give you land, man. I'm going to give you a few acres of land. So you come. Oh, okay, then I'll come. So I went and talked to him and he said, if I give you about 9 or 10 acres of land free, what will you do? So I said, what do you want me to do? And he said, what will you do for my people of Chunampet? I said, you know what? Give me some time, 1 hour. So I went outside and sat there and dreamed up the whole Chunampet model. And I said, you know what? We will transform Chunampet into a model for the whole world. Okay? There is no such model and we'll develop one. So he liked it. He gave the land. The moment he got the land, we went to the World Diabetes Foundation in Denmark and said, can you give us a van? Because only through this van, just like the previous speaker showed, the van, the diabetes van, a similar van we asked for. And then the Indian Space Research Organization gave us a satellite through which to convey the images. So that's a van. And so World Diabetes Federation and our institution, Rural Diabetes Project, and that's the satellite. So inside it, we had everything. We had Dopplers and bathymetry and eyes and everything. And so what we did was we went to these villages, and people live in huts like this. They're so poor. So we took the young men and women of those villages, trained them, because they're high school dropouts. They won't get a job even. So we took them, hired them, trained them how to do sugars, how to do blood pressures, how to do feet tests, how to do everything, and taught them how to get informed consents, to wear gloves, to follow all international standards. If they had diabetes, if we detect somebody to have diabetes, all they did was, the van is parked outside the house. They just enter into the van, and inside the van we can check their feet, we can check their eyes, we can look for cataract, we can look for retinopathy, take pictures. There's a retinal camera there, and the picture can be zoomed back instantly using the satellite into our main center 100 or 200 kilometers away. And here is our ophthalmologist, Dr. Pratibha, sitting in my center in Gopalapuram, talking to this lady 200 kilometers away, telling her what is diabetic retinopathy and what we should do. In the land that the Zamindar gave us, we built this building. How did we build it? I donated it. So my wife and I donated a sizable amount of our income and built that hospital. We registered the whole thing as a charity, so that not only now, but for any number of generations to come in my family, nobody will get 1 rupee out of that. The entire thing is charity. The first 10 years, we lost a lot of money because we had to keep on spending, and nothing was happening. People said, you're a fool. You're going on spending money in this, you're now going to make money. At the end of 10 to 12 years, slowly the project started making profit. As soon as it made profit, we plowed it back into the community and now extended it to more villages and more villages and more villages. The government of Tamil Nadu said, take it. All these villages are yours. You adopt them and then you take them. So now the results came, and this is the initial result. We've done much, much more since then. So the first 42 villages, and then we went around other villages just giving education. In these 242 villages, everybody was screened for diabetes. And then the adult population, about 27,000 people, we detected new patients, old patients, screen them all for complications. There's no rural data. So now we got data on retinopathy, neuropathy, nephropathy, peripheral vascular disease, coronary artery disease, everything was done. When they had diabetes for follow-up, we had the clinic where they could come for the follow-up and get either free treatment or highly subsidized treatment so that anybody can afford to pay. And then using the low-cost generic drugs, we were able to bring the A1Cs down from 6.3 to 6.5, 8.5%, from 9.3 to 8.5%. These villagers did not even know that they had diabetes. And from there, we are going there and then changing their diet and helping them with exercise, testing, and doing all these sophisticated tests, including retinal camera and feet and so on. This has been written about. The Lancet wrote about this when they did a series on India, 2011. They wrote about India and they chose this. And they said the Chunampet Rural Diabetes Prevention Project thus seems to be a good model for delivering preventive and therapeutic diabetes healthcare to rural areas. Very soon we had CNN, Discovery Channel, Le Monde, the paper, French newspaper, BBC, Jugaad. There's a book on innovation in India. It's not even on healthcare, it's just on innovation in India. They had a full chapter on this. And then even Business Care magazines wrote about it. Although they did write that this guy is a fool. He's still losing money, but he still believes in doing it, he said. I said, I'm not a fool and I'm not losing money. It's charity. We're helping people. So it's not a question of, you're doing charity, you don't talk about losses. It's whatever loss is there, you're making it up and you're doing that. But they said, no, we'll write about it because let other people be inspired to do that. So this became a big success story, and is one of the good contributions that we have done. But it all needs teamwork, and we have every member of this team. That's my daughter there, and that's me. But every other member of this team is from the local area. So we've taken local people and then provide the amenities. Our former president, Abdul Kalam, brought the concept of Pura. What is Pura? P-U-R-A. Providing urban amenities in rural areas. Pura. So once you have Pura in your mind, whatever you have in urban areas, take it to rural areas and provide it there. Then it becomes an instant success. But you need teamwork and you need passion. And you need to have a charitable disposition. I think if you have that, India's health problems can very much be, I've heard, Dr. Pankaj talking about cancer. If you can do it for diabetes, you can do it for cancer, you can do it for heart disease, you can do it for anything. And I think this is just one model, a demonstrable model. And I'm going to stop there. And if there are any questions, if there is 1 or 2 questions, I'll take it. Unfortunately, I've got another meeting after this. I've got 4 meetings today. So if there are any questions, one question or something I can take and I can run. If not, I'm quite willing to leave now and wish all the best to Dr. Mayur Patel and the rest of the meeting.
It was a really excellent, I think so, presentation. I have learned lots of things. For the rest of my life, I can even apply a few of the things, what I am doing now. And that reminds me of my days as a resident. In 1969, I was a resident of Dr. O.P. Gupta, a Dion in the field of diabetology and the pioneer of the diabetic surveys in Gujarat. And at that time, he was experimenting with the Ayurvedic drug and the allopathic drug. And he has done lots of projects like this in the past. And whatever you have done, my salute to you, sir. And to anybody who has...
I think Dr. Iriana had...
Mohan. Has to pass on his email ID. He can talk. And I think so this is for all NCDs. Why to talk of diabetes? It has to go with Shankar Jaikishan like this. Every 3 things together, diabetes, hypertension, cardiac, and cancer. If all these things be combined, I think we can do lots of things. And the idea of making facilities of the city to the urban area, that is probably the right way to do things. Asking young MBBS doctor to go to villages, instead making them comfortable in the cities, and those who are retiring and given extension, they should be given time to work with the motherland. Why not? These are a few of the things which can happen. Dr. Mohan, it was really excellent presentation.
Thank you. I think Dr. Irina had a question.
From Chennai, I always remember the lady, Dr. V. Shanta, the mother of oncology in our country.
Absolutely.
This, if Dr. Mayur wants to add anything to his very close friend, he is at liberty. But I think
the previous speaker has been trying to say something. Go ahead.
Dr. Iriana, yes.
Yeah, Dr. Mohan, I'm very happy to see you and the great presentation and explain how it works. It's interesting because in Ukraine, I used to say previous about retinopathy, we try to show government how it's possible to do. But unfortunately, in our level, we only show, we make this project for 2 years, and we have a lot of problem with result, because we check many patients, and finally not every patient come to doctor, not treatment. This also another side. But from my side, I have question. Maybe you have suggestion how implement this project, this pilot project, to government level, because as you say, it's a lot of resource, financial and people resources like doctors, but how is model implement to government level? How you think?
So thank you for that. I think there are some governments which have done it. For example, in the UK, the entire eye screening in Wales was done by the government. They took vans around and every person with diabetes was screened. And there are other examples of that. There are also other NGOs which can join. Once some 2-3 NGOs join together, they may say, all right, the next 20 villages we will take, or somebody else will take something. And for the government to do it, as I told you, for the public to build 1 park was difficult. The government makes up its mind. For them to do 100 parks is not difficult. It's just that initially they didn't think it's important. They didn't think they're going to get votes with that. The moment they realized people are doing it, they said, this is a vote bank. So now let's go for it. So you must get the government interested in it. Of course, one problem with the government is that every 5 years they keep changing. So by the time they do something, the next step will come and reverse all that the other did. This has happened in Mauritius, happened in many places. Good projects should not be stopped, irrespective of which political party comes into power. good projects should continue. And in my state, in Tamil Nadu, I'm very lucky that we keep changing the governments, but the bureaucracy doesn't change. In fact, the new government came now, the completely different opposite party. They kept the same health secretary. They said, you're doing a good job, you continue it. So I think if that kind of an attitude comes, then I think we can do a lot.
Thank you. Thank you very much. It's very important, your opinion. Thank you.
Thank you, Dr. Mohan. Always a great work. Very, very inspirational. And in real sense, it is delivered to the last mile. We thank you all for sparing the time.
Thank you, Dr.
Consent,
Thank you.
we won't prolong it for a long time. Thank you for sparing your time.
Thank you. Bye-bye.
See you then. Now, next speaker is Dr. C.S. Yajnik. Is again a good friend of mine. Is a director, Diabetes Unit, KM Hospital, Pune, India. Founder member of the current president of SNEHA India, that is Society for Natal Effects on Health in Adults. Founder member and trustee of the International Dohad Society, that is Developmental Origins of Health and Disease. And he is master and the basic researcher of the adult disease of fetal origin. Dr. C.S. Yajnik, please.
Okay, I think you'll have to let me share.
Your audio is clear. You can share, please.
Okay, thank you, Dr. Patel. And thank you very much for your kind words. I'm going to say something different. We have heard brilliant presentations from Irina, from Mohan about what is being done in increasing awareness and trying to reduce diabetes by intervention in adults. I'm just trying to raise a flag that it might be a bit too late. And we saw how Mohan saw diabetes grow under his nose despite his efforts. So we might be actually missing an important window. This is not at all to say that we should not do something in the adults, but the real issue is intergenerational, and therefore it's never too early. We can begin in one generation and see the effects in the next generation, or we can see the effects of what has happened to previous generations in the current generation. And that's why I have called it never too early, never too late. As I mentioned in my previous talks, mine is the only diabetes unit in the world which has mother and baby as the logo. And that's because of the firm entrenchment now in literature that mother's health before and during pregnancy is a major determinant of risk of non-communicable disease in the baby. And usually what plays on this risk is the later lifestyle. And we can see the modern Ganesh, who instead of traveling on the back of this mouse, is clicking the mice by lying down and with this plate of modaks around him. So the combination of research in my unit is about intrauterine programming and the lifestyle rapid changes that have happened. So this is what we learn or read in textbooks, that the susceptibility to diabetes is genetic. It's polygenic, so we can't do much about it. It's non-modifiable. So let us concentrate on precipitating factors. And that is how an average participant in the diabetes prevention trial looks like. 50-year-old, obese, and with impaired glucose tolerance. And I'm trying to say that so-called primary prevention, which we are selling, is actually treatment of precipitating factors. We can't treat his age. We can try and treat his obesity, and we can try and treat his IGT. And quite misleadingly, we call this primary prevention. It's an end-stage intervention. And what's more important, it's post-reproductive, so it doesn't benefit the next generation. If at all, it benefits the population for a short while, but only that individual. And this is how we look at natural history of type 2 diabetes, that changes occur much before. This is an old figure. We have now generated a fantastic figure after 25 years of follow-up of a birth cohort, which will be soon published. But what you can see here is that the glucose starts rising much before we diagnose diabetes. Insulin resistance rises. The beta cell tries to compensate for up to a certain time. And depending on either genetic or what I will show you epigenetic factors, then it starts crashing down. And I'm going to try and say that we need to act much, much earlier if we want to curtail the epidemic of diabetes. Diabetologia was the only journal who really listened to this. And 2 years ago, we had a full issue, special issue, dedicated to this concept of DOHAD, in which we contributed 2 major reviews. And the basic issue there is diabetes begets diabetes, but diabetes in history has originated in undernutrition. And we are today concentrating on overnutrition, which is the precipitating factor. And if you see these reviews in this special issue, you will learn quite a lot about exciting developments that have happened in last 20 to 30 years. So for current diabetes prevention programs, we are targeting pre-diabetic people. And I'm going to show you that it might be a bit too late. This is one of the seminal studies in the world where they showed that people who were born in the Dutch winter hunger, that was towards the end of the Second World War, had increased the risk of obesity as young army recruits if they were exposed in the first 2 trimesters of pregnancy. Similar time, reports came from Pima Indians in USA that if mother had diabetes in pregnancy, her children had much higher risk of obesity and diabetes later compared to mothers who never became diabetic, or even mothers who became diabetic after pregnancy. So genetically diabetic, but in pregnancy, not higher glucose, actually didn't increase the risk much. But if mother had diabetes in pregnancy, the child had higher risk. So both undernutrition and overnutrition program the fetus to get diabetes in future. And this is not genetic. This is epigenetic due to what we call fetal programming. And this was brought to focus by David Barker in 1991, when he showed in a cohort in England that low birth weight was a risk factor for future diabetes. And what he showed beautifully was that it was not an all or none phenomenon, low birth weight below 2.5 kg. No, it was a continuous association between birth weight and future risk of diabetes. So that if you were born less than 5.5 pounds, you had 40% risk. If you were born more than 9.5 pounds, you had about 10% risk with a graded decrease in the intermediate risk. And he called it thrifty phenotype. I can tell you, I suggested him the terminology, and that was, he published it next year. And he said type 2 diabetes is the outcome of the fetus and early infant having to be nutritionally thrifty. During my first visit, I also told David Barker the story of Abhimanyu, which I said yesterday at the inauguration of your conference. And David Barker quickly started believing his own idea after listening to the Abhimanyu story. So India, very peculiarly, is a double capital of the world. On one hand, in the diabetes meetings, we talk about India being one of the 2 capitals of diabetes. But for undernutrition in early life, India is the biggest capital, whether it's for low birth weight or for under 5 undernutrition. So today also in India, between 15 to 20% children are born low birth weight. And a very large number of children under 5 are still undernourished. And despite this, we are seeing this diabetes epidemic, and we are concentrating only on the later aspects of it, which might be related to later overnutrition. And therefore, life course history is very important. And this was beautifully shown in a Lancet article to which we contributed, published by the Public Health Foundation of India, which showed that diabetes increase in last 25 years, shown here in shades of red, was in the parts of India which are relatively undernourished, impoverished, socioeconomically behind, either have geographic or political difficulties, and they were the ones which had most increase in the diabetes, not the rich states. So this led to the concept of DOHAR, to which I have been a signatory as a founder member and now a trustee of this International DOHAR Society, which says that though we treat risk factors and morbidity and mortality of the non-communicable disease in end stages, the origin is really intergenerational in mother's health, and it's epigenetic. It is evident in the birth phenotypes, either as low or large birth weight, depending on whether you are studying undernourished or diabetic population. And it builds up during childhood and adolescence. And if we are trying to prevent it in adult age, I'm going to say it's a bit too late. You know the famous Pune maternal nutrition study, which I set up with David Barker's help in 1993. So we have now completed 25 years of follow-up of these children. And at 18 years of age, these village children, half of them were underweight, BMI below 18.5. Only 5% were overweight obese, so BMI above 25. 10% were stunted. But 27% of boys and 8% of girls had IFG. 10% each had IGT. 2 girls had diabetes. A total of 28.7% of these relatively undernourished children had prediabetes. And we have shown that this was largely due to poor performance of their beta cell function throughout their life, starting from very early childhood. So that when we did a multivariate analysis of factors predicting glucose intolerance at 18 years, what do we find? We found that short birth length and small head at birth was predictor of diabetes or prediabetes at 18 years of age. Mothers who were non-overweight predicted risk of diabetes in the child. Despite being non-overweight and having normal glucose tolerance, only 1% at GDM, maternal pregnancy glucose in higher range of normal predicted risk of prediabetes in the baby. Paternal glucose predicted for the daughter and adiposity in the male. So you can see the double burden of undernutrition in that individual, which actually predispose him or her to future prediabetes, poor intrauterine growth, a relatively undernourished mother who had a relatively higher glucose, probably because her mother had actually a similar syndrome, and paternal glucose for daughter. This should open our eyes that we are facing a very massive problem of double burden, which is not obvious, not taught at all in these medical schools, and we are concentrating only on the overweight in the adult. And in the same study, we had this stunning finding that fasting glucose at 6 years of age very predictably predicted glucose intolerance at 18 years. Fasting glucose at 12 years again predicted the glucose intolerance at 18 years, so that if you were in the highest quintile, that's the highest fifth of fasting glucose at 6 years, your risk was 3 times higher. If you were in the highest quintile at 12 years, then the risk was 6 times higher. Amazing. And this gave an under area curve of something like 0.75. Now, very interestingly, about 200 of these girls since 18 years have married. They have become pregnant. And we have done their glucose tolerance test in pregnancy. So now I am talking about a girl who was pregnant, but whom we have studied from before she was conceived, during her mother's pregnancy, and throughout her childhood, adolescence, and young adulthood. And how do we relate her pregnancy glucose? So we looked at highest tertile of glucose in pregnancy, because all the GDM criteria are very vitiated by some or other outcome. Like say current criteria are based on large for gestational age, and in India the problem is small for gestational age, but we still fall for that. So we took the highest tertile of fasting glucose, and what do we find? The pregnancy glucose of this girl at an average of 21 years of age was predicted by higher glucose at 6 years, higher glucose at 12 years, higher glucose at 18 years. So what we call gestational diabetes is not gestational at all. It's present from very early childhood, tracks very faithfully, and we struggle at 24 to 28 weeks to diagnose and curtail it. I think we might be doing damage, which we need to seriously investigate. The real time to do something is much earlier. Then we followed children born to diabetic mothers. And what do we find? That 15 years of age, 4% of them, 5% of them had diabetes, and 37% had pre-diabetes. So this is another side of the coin. These mothers, which were relatively normal weight before pregnancy, 22 BMI, actually had diabetes in pregnancy because they were undernourished in their earlier age. And their children also have increased risk of pre-diabetes and diabetes. And this should come out very soon in a journal. The other one is waiting to be published in Diabetes Care. So we have this double cycle, a double whammy in India, that there is an early life undernutrition in 70% of the population, and later life overnutrition, especially in those living in cities or even within villages where rapid transition is happening, like in the villages we studied. This is a family photograph 25 years ago, and this daughter here, which you can see, is now driving this scooter. So within 25 years, there is a dramatic change, and this daughter's plasma glucose is compared to her mother's. Fasting was higher by 10 milligrams, and 2 hours during GTT was higher by 35 milligrams. Within one generation, based on undernutrition in early life and rapid transition, we have brought a dramatic epidemic. And what we are trying to say is we should catch them at 45 years and increase their awareness and do this and that. I beg to differ. The natural history of diabetes should then now be investigated at very early time. And a Lancet produced a series to which we have contributed very handsomely. It says it begins before the beginning. And Mohan said this from clinic to community in an entirely different sense. I am telling you that diabetes and pregnancy diabetes need to be considered in community in young children. So now we can see that we have primordial prevention over and above primary prevention. And as doctors, we are doing secondary and tertiary prevention. I really don't want to talk about it because we talk about it in all our diabetes meetings again and again. In the NGO meeting, I would urge everyone, please open your eyes and concentrate and begin before the beginning. And I think many people, if they learn this, have now developed an expertise of dealing with the communities and can convert the message into a very different one. Instead of concentrating on the adults, we are going to concentrate on young, and we are going to concentrate on daughters more than the sons. So pregnancy becomes an experience for the two. That I think you should remember. And interestingly, if it is a pregnancy with female child, it becomes an experience for the three. Those who have listened to me before would know about this, that a female pregnancy, actually that daughter inside the womb of the mother has all the 1 million ova in her ovary by 20 weeks of gestation. So if you are actually intervening in this grandmother, you are actually trying to help not only her daughter, but also her granddaughters and grandsons. And therefore, it's a transgenerational programming. This is a very powerful model of prevention. So I think you need to think about this seriously. Now, yesterday, we heard this. We heard from his greatness that he said, you have to do it yourself. And this is what I have written in my clinic for last 40 years. It's there on the wall. की जो दुसऱ्यावरी अवलंबला त्याचा कार्यभाग बुडाला. It was said by none other than Sant Ramdas, Shivaji's guru. And yesterday I was stunned to listen to his speech where he said earlier the better. So I'm quite impressed by his understanding of the problem. And if we believe in him, which we all do for various reasons, I think he yesterday gave us a very subtle message that actually we need to go early life, which is what I have shown you scientifically. He said it from his experience and emotionally. And he said, do it yourself. And that's what your awareness and education brings out. So this is where I'm going to stop. I think I have told you enough that actually it is never too early. I'm not worried about late, but it's never too early. Thank you very much.
Thank you, Dr. Chitranjan. It was excellent presentation. And what I have at least take a message for me is to concentrate on the antenatal clinics across the country and make them aware about the concept you have developed and the nutrition in the young children and the overnutrition in the others. But I think so this is one thing which can be done if all the antenatal clinics across the country are being educated with the NGOs, which is run by Dr. Mayur Bhai and other people across the country, so many NGOs. Probably your concept has a real meaning in the prevention of diabetes at the earliest stage. Thank you. It was excellent.
Yes, sir, thank you. And you will perhaps read that many cancers are also now linked with disturbed intrauterine growth, especially the hormone-dependent cancers and the obesity-related cancers.
That's right. That's right. Yeah. And that is the reason many times I say that if you want to prevent cancer, you get in addition the prevention of diabetes and control of the hypertension and the control of the blood pressure. So these are all required to be nicely coordinated efforts so that we cannot have for each disease a different mechanism. With this now,
Dr. Yagnik
has to add anything?
Yes, Dr. Yagnik, great work, eye-opening, always a great work. One sentence I will tell, because you are doing the great work which no one can do. For us, following a patient for 1 or 2 years is very difficult. And you are following it for 25 years or more than that. Probably 40 years you are following the same family. It's a great work because a lady is residing somewhere, then married and going to somewhere else, and then another daughter that is married and going to the third place. It is very, very difficult, very, very difficult to trace and monitor them. So great work. We always, you are always a source of inspiration. Thank you very much for sparing the time.
Right. Thank you, Mayur Bhai. And I can proudly say our follow-up rates are more than 95%.
Oh, great.
Even into the third generation.
Sir, you have given the central core message from the conference. What should be done for prevention of diabetes?
Thank you very much. And Sadhguru said same thing yesterday.
Yes, sir.
Earlier the better.
Thank
now
you.
I have to introduce my friend, Dr. Dinesh Pendarkar, who is champion in the cancer control in the various districts in many states in the country. He has a first-hand information on the cancer control, and the organizer want how the cancer control can be considered as both the model of the cancer control, can it be applied to the diabetes control or not? And with this, I request Dr. Dinesh to present his presentation. Dr. Dinesh.
Sir,
Sir, can you hear us, Dr. Dinesh? Hello.
Dinesh. Nirav, help him.
Pendarkar, can you hear us? Hello.
Yes. Dr. Dinesh, we can hear you. Can someone call him?
Sir, I'm calling.
Huh?
I will call.
Dinesh, can you hear us?
So, Dr. Dinesh has a wonderful presentation based on learning from cross specialty, last mile delivery of quality diabetes care. So, building on their experience from district cancer care model in 8 states and 200 districts of India. So, how cancer care model in Indian based populations in 8 states and more than 200 districts, that expertise can be replicated in the field of diabetes care. And from learning from the cross specialty, we have eminent speaker Dr. Dinesh for the same.
He has started, we were not able to see, so he's redoing it.
Rajesh, we can go for the next speaker till the
Yes, I think so.
technology gets coordinated with us.
Yes, sir. We can go to the next speaker.
He has joined. Dr. Dinesh has joined.
Mayur may invite the next speaker and we can listen to Pendarkar later on.
Sir, Dr. Dinesh has joined already.
Dinesh has already joined. He was here only. Sorry, yeah.
hello, can you see my slides?
Yes.
Yes. Come on. We can see you. Yes. Good.
Can you see the slides now?
Yes, Dinesh.
You
So,
are well audible and your slides are visible.
So so don't worry. Thank you very much, Dr. Pankaj Bhai, and thank you for the organizers. So what we want to see how we can transfer some knowledge from one model to another model. So health of an individual basically depends on the patient, the society, and the health system. The health system constitutes of hospitals, physicians, and diagnostics. So health of an individual is an interplay of these three things. So health system definitely faces a lot of challenges. The health system has a challenge of infrastructure, not limited resources. There is a lot of financial involvement. The care involves cost. It involves financial inaccessibility. Many times health system is socially inequitable. You won't find poor people going to best hospitals. There's deficiency in manpower. We have a small number of skilled experts, but we got GPs in the rural area. And that number is also very small, as just somebody has said. Diagnostics is costly and accessible. So these are the problems which health system faces. As far as patient is concerned, he faces a problem of accessing the care. He can't buy medication, diagnostics, he cannot get hospitalization. Cost of travel to the hospital or to the physician, he loses money when he doesn't work. There is a non-availability of a good physician GP in a rural area. The specialist always is somewhere else, or there is social inequity again, and there is lack of health education and overall education. If we take the society as a member of the health, then there are societal challenges. There are financial constraints for the family and society to help the patient. Families are small. There's a time constraint to help the diabetes patient, for example. And then there are again educational barriers. So major challenges in nutshell are physician challenge and the expert challenge, the distance challenge, the finance challenge, the limited resources challenge, the society challenge, and the education challenge. So if we really want to deal with some model, some care of some disease, we have to find a solution to all these major challenges. Then only we'll be able to make a dent. So physician challenge or an expert challenge can be made by making available alternate workforce by task shifting. The distance challenge can be made by decentralizing the care, taking care to the periphery. The financial challenge can be met by strengthening government care, because government care, we know, is either very low cost or practically free in the country. If we have limited resources, the plan or the care model should be such that we should start with existing resources. The society and the family challenge will reduce if the care is close to home. Then the time required by the family and society will be less. And education, we will have to empower, and we need more people who can empower. So that's also a challenge. So what is the requirement of the day? The requirement of the day is a strategy to increase access to care, strategy to reduce cost of cancer care, strategy to reduce social and familial impact of cancer. So the need of the hour is we should have a scalable innovation. We should have an innovation which touches all elements, but at the same time, we need an innovation which can be scaled up. So if I come up with an innovation which has changed one whole village, it is not going to help. As somebody from Spain has raised the question recently, how do I convince my government? Because unless you make a scalable model which can go everywhere, then and then only we can bring a change. So what we did in cancer care, we delivered a model called Cancer Care Delivery Model. And the mission of this model was to bridge the gap in inequities in access to cancer care by empowerment of alternate oncology workforce at point of maximal access by the society, which is a district hospital, and leveraging existing resources. So objective of this model was to create and implement a new healthcare delivery model to expand and ease access, initiate cancer care services at lower most administrative level, like state-owned district hospital. And the other objectives were to create counseling services, help in detection, evaluation, help in chemotherapy, assist in prevention, palliative care, in public education and advocacy. The guiding philosophy was use existing state-owned system because it is most widespread, it is most financially economical. Go to the lowest level. So lowest level in healthcare unit in cancer was a district hospital. We knew the model has to have a physician as the cornerstone. The physician should be the pivot of the health system. And state should incur no immediate financial issues, because if you propose a model to the state saying that I need this much money, the model will never come up. And the rollout should be so quick that it is visible. If I plan a model which gives a result after 3 years, nobody wants such a model. If I say you start today and you will see the result tomorrow, everybody is willing to accept it. So what we did is, in this model, this is a very important figure, that we chose district hospital. So we chose district hospital, we created nodal cancer unit in a hospital, and we created a physician point of contact in the hospital. So now this organization was created and then was established using system and processes and a chemotherapy delivery. So this was done in a cancer unit. The system was empowered by techno mentoring. I will explain what I mean by this. By using a tuber board, by using telemedicine facilities like WhatsApp, EMR, telephone, and by visiting the districts through cancer camps. So this was the empowerment model, very extensively used. And the output we were planned and we are receiving is counseling of the patients, care of the patient, chemotherapy. We are creating a data registry, public education, and advocacy. This is all happening. So now, the same model I would like to transfer to diabetes. So I changed nodal cancer unit to nodal diabetic unit. I changed physician contact for physician contact for diabetes. Instead of tumor board, we can create a diabetic expert boards. We create diabetic camps to empower this unit. I'll come to this later. So what is the techno mentoring? So we chose one medical officer who was trained to understand cancer and look after the cancer patient. He was given a short-term classroom training. Then he is being monitored on site by frequent visit by an oncologist to their site. He is participating in CMEs. So the constant mentoring is happening. There is a web-based training happening for them. Telephone is constantly used, and most oftenly used is a WhatsApp mechanism to discuss literally every case coming to the district. So we select one medical officer, train him for a period of 1 month, establish a cancer unit in the hospital, and patients with cancer are expected to refer to this unit. The model was started in Madhya Pradesh in 2014. So the first training started in February 2014, and the model was launched from 10 districts and then expanded to all 51 districts of Madhya Pradesh. After Madhya Pradesh, Odisha took this model and they said, we want to do it in Odisha. And then we took up Odisha. Later on, the model has been expanded to multiple states of India. And this is just one of the quotes from Niti Aayog, which says, model of training of GDMOs to handle patients at the district hospital is a scalable model, as important element of task shifting, capacity building, and need to expand to all districts. So this is how we have expanded till date. We have trained 198 districts. You know, if we take the area of these districts together, it's more than multiple countries in Europe. And the population together here would be around 385 million in the districts which we have trained. So what we do is we empower them by different camps. You see below a hospital, this one is a hospital in Jaisalmer. This is a district cancer care unit in Jaisalmer. It's as neat, clean, air conditioned. So we did trainings in Gujarat, we did trainings in Odisha. So now we have done multiple trainings and the program has been rolled out everywhere. So what these doctors do, these doctors see cancer patients, help them in all their life cycle and do chemotherapy. At the same time, these doctors have been trained to do public education. So these are different photographs showing activities done by these doctors who have been empowered in their own district. So this is like Himachal Pradesh, this is Odisha, this is Rajasthan. So the doctors are really now working as advocates of cancer. The program has been launched officially as a district cancer care program by various states. So here are the 3 documents from Odisha, from Madhya Pradesh, and from Rajasthan. These are the official documents of the programs of these states. If you see these advertisements, these are the advertisements of various states telling that these programs are working in these states. If you really follow the advertisement in the middle from the government of Rajasthan, it says, during Corona, please don't be afraid of cancer. Go to nearest district hospital and you will be helped in diagnosis, consultation, and you will be helped in chemotherapy free of cost. Same thing in Chhattisgarh, same thing in Odisha, same thing in all other states. This is an important advertisement which lists the WhatsApp number of all the districts of the state of Odisha. This was during last year's Corona. The government publicized this, that a patient can directly call the doctor in his district if patient has a problem related to cancer or continuation of chemotherapy. This is one of the slides which shows from district Ujjain how our numbers increased during Corona in last year. So the district actually, when all other hospitals were closed, these all districts were working and providing cancer care. So this is a model which works even something else failed. So I have done presentations on this model as a new healthcare delivery model at Harvard also. And this is the latest advertisement released last week by government of Odisha. District Daycare Cancer Chemotherapy Center. These districts, we have retrained them into palliative care also, and free chemotherapy, palliative care by government of Odisha. So this is the level we have reached in now last 7 years. So let's start. So what we did was we created a district hospital, nodal cancer unit, and we created a physician by creating the facility, by establishing system. So there is a system, there is a file creation, how to record, how to process, how to make data. And then we trained this person by multiple technologies. We give him assistance by tumor board and other options. And the output we are getting is these doctors are now counseling, giving care, chemo, they're keeping a registry of the patient, they are doing education, they are doing advocacy. So they are playing all these roles. So now this is a model already functioning, giving all these outputs. So now let's believe that we want to take care of diabetes, which I really believe probably may be a bigger problem than cancer. So how do we do it? So again, we create nodal diabetic units. So instead of diabetic unit in a government district hospital, diabetes is a smaller problem in terms of knowledge. Cancer is a vast knowledge required. The number of patients is small. So instead of nodal diabetic units, we can actually go to sub-district levels, like maybe what we call a CSC or a PHC level, and create a diabetic unit there. Involve a local physician. Physician has to be the point of contact for diabetes. And then by creating these two things, then we create systems as how he records the data, how he creates the file, and then we empower him by technomentoring. So what I need is a person who takes care, who becomes a mentor. We create a board which keeps assisting this doctor by using WhatsApp, EMR, telephone, or by doing camps there. So camps are also used basically to teach this physician. So we empower him by this model, which is doable. One diabetic expert can take care of 5 to 10 districts. So he finds physicians in a district nearby him, trains him, gives them 24/7 backup, and then you can expect that this doctor will counsel them, offer them care when the patient is not going to the expert, follow diabetes treatment, create a registry, do public education. So now you will have multiple hands to do education at a rural level, and he will be the biggest advocacy of the diabetic program, biggest advocate. He will help the diabetic organization, association in creating awareness and everything. So just by doing minimal things with the least of investment, we can get a great output. So from this cancer model, we can actually transform to a diabetes model, which would be much easier than doing a cancer model. So in conclusion, care can be decentralized to increase quality access. We have done it in cancer, which is a much serious and technically challenging problem. Task shifting is feasible. A primary physician can be empowered to deliver specialized care. Feasibility rests on the principles of strong, sustainable mentoring. So what I need is a diabetic expert who is willing to mentor few GPs 24/7. Thank you very much.
Thank you, Dinesh. It was an excellent presentation and the sharing of your experience, how to control chronic diseases in a simpler way with involvement. I was fortunate to be part of your tumor board you had with the district hospital doctors. It
Thank
was
you.
to educate them in the best possible way. So we can do it. We can do it. I would like to share another ideas we had at a Gujarat, that is development of the health passport for male and female, in which there was early detection of the cancer, diabetes, blood pressure, recording everything. And this passport can be renewed every 2 years or every year. So people go for checkup for the diabetes, for the cancer, for the blood pressure, keeping their record in that particular passport. And it is available on our website of Gujarat Cancer Research Institute. Pendarkar, you have done a great job, spread to more than half population of India. You are proud of our oncology community. Thank you.
Thank you.
Thank you.
Thank
And
you,
now
sir.
I request Dr. Mayur to invite the next speaker.
Dr. Dinesh, thank you very much for a very good work and very good presentation. It's an inspiration for us to replicate in the diabetes part. Thank you so much.
Thank you, sir.
We conclude the session over here, and I'll hand over mic to Dr. Neera for further proceedings.
Thank you so much, Dr. Patel, sir, Dr. Pankaj Shah, sir, and Dr. Pandharkar, sir. Nice connecting with you all. Stellar presentations by all the speakers. Great to hear the work which is going on around in cancer and diabetes, both put together. Thank you so much, all of you. Let's move on to the next session, taking your organization to next orbit. For this, we have our chairpersons, Mr. Vijay Charlu, VP Sales and Marketing, Corona Remedies Limited, and Ms. Sri Rekha Srinivasan, Senior Business Director, GLP-1 Novo Nordisk India Private Limited. Over to you, chairpersons.
Hello, am I audible?
Yeah, you are. You are, Srinaka. Yeah.
Thank you. Thank you. Vijay, you want to take this one?
Yeah, it's okay. Anyways, good evening, all of you. It's a pleasure to be chairing this session of innovation in NGOs. So detection of diabetes has this 50-50 rule. The 50 rule is that the patient, 50% of the patients are not detected. And I think the NGOs play a very, very important role in accessibility towards greater patient care. And to further chair this session, I have the privilege of introducing the speaker for today evening. The first speaker, Dr. Sharad Pense. Dr. Sharad Pense is a MD consultant diabetologist at Dantoli, Nagpur. Sir is a managing trustee of Dream Trust, a charitable trust for diabetic children. And as far as I know, he's an icon in the diabetology field and has published books as well. And he's the author of Practical Management of Diabetes and Diabetic Food. So done a lot of work on this aspect. I would request Dr. Sharad Pense to take over this session and give us his views on the same.
Thank you, Dr. Patel, for arranging this wonderful conference of NGOs. And this is for the first time I am part of such conference. And I'll be talking in brief about how to uplift the NGO to the international standard from my experience of 25 years of running an NGO with the name Dream Trust. If we look at the burden of type 1 diabetes, India is second highest, has second highest population of type 1 diabetics, 184,000 children with type 1 diabetes in India. So we are second in type 2 diabetes, and second in type 1 diabetes as well. Every fifth child with type 1 diabetes in the world is an Indian. And from this 184,000 children, 70% are poor and 50% are girls. We have a wonderful campaign by our beloved Prime Minister, Mr. Narendra Modi. It's a wonderful project of Clean India. But if we succeed to some extent in this campaign, I am very sure that number of children with type 1 diabetes will increase. Now, the standard treatment at international level for type 1 diabetes is, as you all know, analogs, several tests a year, lab tests, and preventive program for chronic complication to keep the HbA1c in children less than 7.5%. And for all this standard treatment, it cost almost 12,000 rupees per month. Now, ground reality for type 1 diabetic children is most of the poor families find it difficult to commit quarter or even half of their monthly income for the treatment of a diabetic child. And this is why they try to find shortcuts, which they wrongly believe will make treatment less expensive. For example, instead of 4 injections, they will give only 1 injection a day. So they even stop insulin. The multiple problems in rural India, illiteracy, poverty, and most important, gender discrimination. Female feticide and infanticide are rampant even today. Everyone wants a loving mother, a charming wife, but nobody wants a daughter. And that's why the trust, our Dream Trust, gives top priority to girls with type 1 diabetes. The challenges are many with these type 1 diabetic children. Most of them in rural areas are poorly controlled because they take once a day insulin. Sometimes they miss insulin on a particular day. Infections are frequent and therefore they require hospitalization, which is very expensive. Because of inadequate insulin, they have growth retardation, they stop going to school, school dropout increases, and especially for girls, marriage is a distant dream, and therefore childbearing is almost impossible for these type 1 diabetic children. Where there is no electricity, storing insulin also aggravates the problem. And this combined effect has led to short life expectancy of unsupported rural type 1 diabetic girls. And let me tell you, the life expectancy of such poor girls is 2 to 3 years. We are celebrating 100 years of insulin discovery, and all of you have seen the picture of Leonard Thompson, who received the first insulin injection in Toronto, and the sea change that occurred in Leonard after receiving insulin. But even after 100 years, we are seeing Leonard Thompson's every now and then. Look at this boy. He's reduced to only skin and bones. You can easily count his ribs and see the A1C report, 24.4 A1C, one of the highest recorded A1C in the world. But after 2 months of insulin therapy, there is a sea change, as it happened with Leonard Thompson. Now you don't see the ribs at all. the birth of Dream Trust occurred in 1995. So we are celebrating 25 years of Dream Trust. And with the primary objective, very simple objectives where we have to ensure survival of this type 1 diabetes by giving uninterrupted insulin supply, prevent complications, growth retardation, promote education, encourage marriages, make them self-reliant, and these girls should lead life with pride and dignity. And that was our holistic approach to begin with. However, we didn't know initially we started financing from our own family income, but the number of children started increasing and it became impossible to bear all that expenditure and we needed support from outside. At that time, I wrote an article, Where Have All the Girls Gone? And that got published in United Kingdom in the magazine Balance. And believe me, just by publication of one article, the news of Dream Trust spread in entire Europe, especially German-speaking Europe, and the Dream Trust got the boost which it badly required. Now, this is how the condition of rural type 1 diabetic children are. Look at this poor girl, and in the background you can see the primitive hut where the living conditions. Now, how can you expect this girl to take 5 injections of insulin every day and do all those investigations, undergo hospitalizations at times? It's just impossible to bear the expenditure of treating one girl with type 1 diabetes in rural area. In 25 years of our journey of Dream Trust, the number of beneficiaries began increasing from 5. It has reached more than 2,300 now. We distribute insulin, human insulin, syringes, blood glucose strips, meters, pens, analogs to over 2,300 children. We also have new projects like we provide them travel grant to come to trust to collect their insulin every 4 months. We provide educational scholarships. We provide them bicycles to prevent school dropouts. We give treatment for other medical problems. We provide them clay pots for storing insulin if they have no electricity. And of late, we have started distributing even refrigerators. And we rehabilitate them. We provide them grant to make them self-reliant. We provide treatment for other allied medical problems. Now, this poor girl came with total blindness, and you could see from the distance matured, hyper-matured cataracts, both eyes. So we got them operated, put lens implants, and you can see the smile on the face of that girl. We started providing educational grants. These poor girls used to be common problem of school dropouts, but now with our educational grants, they are attending school, they look smart, they are studying and aspiring to become somebody in the society. Provide cycle was another project that we had in mind because these villages, the schools are at very long distance of 8 to 10 kilometers. And that's the reason why many of the girls drop out from school after 7th standard. So in 2012, we started with one donation of bicycle. And by 2020, we have donated 950 bicycles. The growth retardation problem has dropped down by 2020 very significantly. So the school dropout rate, the annual mortality, which was very high in the beginning of Dream Trust 1995-96, was very high. Now it is reduced to hardly, you can see very small spike here, and some of them die not because of diabetes, but because of accidents and other causes, allied causes of other medical illnesses. Earlier, marriage was distant dream for these rural girls. And once these girls start growing to puberty, post-pubertal age, if they don't marry, then they are a target for antisocial elements. So we started promoting marriages, and believe me, we could arrange marriages of several of these girls without hiding their diabetes. And we also promoted intensive glucose control, gave them 7 injections a day, blood glucose 7 times a day. And our fetal outcome rate in these girls is at par with international standards. To store insulin in villages where they have no electricity or if they don't have refrigerators at home. So we started in 2007 with 1 refrigerator, and by 2020, it has reached 250 refrigerators. After 2020, because of Corona endemic and pandemic, many projects had to take hold. We also educate and give motivational programs for all these type 1 diabetic children. And here you can see Sunil Gavaskar in my small clinic addressing children who are sitting on the floor. And Sunil made a wonderful talk, interacted with them and boosted their morale, gave them a lot of tips to lead life with pride and dignity. We also conduct a lot of educational programs in rural areas. We train the primary school and ASHA workers to give afternoon dose of insulin because parents go to agriculture farm for working. So the afternoon dose of insulin is many a times missed. Now we train the primary teachers and ASHA workers to give insulin so that there is no interruption in insulin therapy. We also have grants for rehabilitation, and we provide them livelihood by providing them funds there to start dairy business in villages for the boys, and for the girls we ask them to start daily needs center, small beauty parlor, or food snack corners in villages or nearby places. And you can see all these children have started these REACT projects with great success. Look at this Manda journey of 25 years. Manda came to us as a little girl in 1992, and in 2001, she was already 10 years old, and then she got married, she became a nurse, she got a job in government primary health care center, she got married, and she has a lovely son. This is 2013, and now she is happy with 1 child, and both of them, husband and wife, are doing extremely well. And the Dream Trust or all NGOs, if we work with dedication, we can certainly make the difference. You saw this picture on the left side with that little girl, and in the background of her hut, very primitive hut. Now this girl has grown up. You can see the brightness on her face, and this is that girl grown up with. When we go for home visits in villages, we visit them at home to see the local conditions, and you can see the smiling face of this little girl seen on the left side. Many of our patients have become achievers. They have become nurses, dentists, pharmacologists, and even Ayurvedic and other homeopathic doctors, dentists, and some of them have become senior nurses and making their livelihood and leading their life with pride and dignity. 2013, Dream Trust was awarded Best Charity at Berlin in Germany, and this award, Fuchsberger Award, was given to us by none other than Mr. Fuchsberger, who was the famous film star of Germany. 2 years back, he expired due to stroke. This is one of the longest surviving type 1 diabetes in our country. He is 86-year-old and has type 1 diabetes for 74 years. Recently, he received a gold medal for living with type 1 diabetes. I have been following him for more than 35 years. He's on 5 injections of insulin a day. In 2020, when we had a pandemic of COVID-19, everywhere in the world, there were problems of financial restrictions to the poor families. And in India, we decided to provide financial aid to 300 below poverty line families who had diabetic child. And we provided them 15,000 rupees per family. This is just to overcome financial crunch because of pandemic. And so far, you'll be surprised, we have provided 47 lakhs have been distributed to these 290 families, poor families. We are celebrating 100 years of insulin discovery from 1921 to 2021. And we are also celebrating Silver Jubilee of Dream Trust. The only ulterior motive, and I appeal to my chairpersons who are leading insulin manufacturing companies, that they have to see to it that no diabetic should die for want of insulin. 25 years of gratifying and rewarding journey I had from 1995. And to just give you a message, how to uplift the NGO, we have to have a very close rapport between donor, the NGO, and the end user. And there has to be a reciprocal arrangement, and it is to be very frequent and continue. The donors, if they get reply from NGO and see the results of end user, they continue to donate. Otherwise, they stop giving donations. So we have to be very alert in informing donors, informing our end users, and keeping a rapport between NGO and donors and end users very frequently. We should also publicize on public media, newspapers, Facebook, and other such social media. In 1995, I wrote an article, "Where Have All the Girls Gone?" That was in 97. And now I proudly say they are very much here and they are all smiling too. Thank you very much for listening to my talk. And if you have a couple of questions, I'm willing to reply. Thank you. Thank you very much.
So at the outset, let me congratulate you for that fantastic presentation, sir. Really a pleasure to listen to you after all this time. I think when it comes to type 1 diabetes, we learn and hear from you a lot about the science of type 1 diabetes. And today we've heard about another side of the problem, the social problem that is associated with type 1 diabetes. Really fantastic listening to you, and thank you for inspiring us. And we hope to work together on this problem sometimes.
Thank you. Thank you.
Not too sure if there are any questions on the screen here. I'll take the opportunity to introduce the next speaker. The next speaker, Dr. Kristen Van Acker. Dr. Kristen Van Acker is an MD PhD and is head of the multidisciplinary diabetic foot clinic in Belgium. She has to her fame the Lifetime Achievement Award of the DFSG and the EASD in Porto in 2017, and is also the 2 times board member for DFSG. Dr. Kirsten, over to you, please. I think you're on mute, Doctor.
Mute yourself.
Dr. Kristen, you're on mute.
Yeah, thanks. That's the first thing. Hello, everybody. Wonderful meeting. I stayed a little bit on your presentation, and especially when Dr. Sharat Pense was online, as he played a huge role on the diabetic foot world. It was nice to hear him, and being very nice to be with you for this invitation. I just check if I can share screen, because the last time it didn't work, but it seems, oh yes, it will work. That's great. Okay. Just 1 minute, and I think we can start, but not on the right side. I just have to retake it. Just 1 moment, please. It will go. If I take the first slide, that is always helpful. Here we are. Okay. So thank you for the invitation. Very original to make a kind of work together on the NGOs and to listen where are the obstacles and where are the successes. So very nice. I have no disclosures. The time I was on the lead in the DFOOT International, of course, I was related to the corporate partners, but you can find it online, but it's not of influence during my talk. This is a story I got from your place, and Sandeep liked to share a story with you, and such stories, I think all of us are very sensible to it. In fact, I started out with a simple blister, and suddenly I couldn't, before I knew I had to get below the knee amputation. To be very honest, I didn't take my medicine, so things got worse and I had to have an above the knee amputation. And this man has a message to us. He wants to tell us, to others who are suffering from diabetes, I suffer, so you better take care of your diabetes so you don't suffer too. This happened to me because I was careless. I had no access to care. And that's something, when you are on the international level, wherever you are in the world, this is things, as you heard from Dr. Sharat Pense, no access to insulin, no access to care when you have a wound is unacceptable. Some story I want to share with you is that when I'm now more than 30 years, I think 35 in meanwhile, active in the diabetic foot on national, international level, I've seen that the diabetic foot was like the Cinderella, nobody took care. And then suddenly over the years, just before the COVID period, it was not a Cinderella as it was so many years ago. But the COVID again made a change, and up to us to be flexible. That is what you know. Every 20 seconds, a limb is lost somewhere in the world as a consequence of diabetes. So it's a big problem. It's quite dramatic if we are all over the world. And what might touch me as much as it could touch me is when I was in lead, that 80% of the problems on this level are in the low and in the middle income regions. So that's not fair. And if you take the whole budget on the earth, on our planet, what is going to healthcare in diabetes, and we know the diabetic foot is a big part of it, it's also on economical level unacceptable. So there is a huge international responsibility, a huge one. And so I want to, for those who are not always in the topic of the diabetic foot landscape, give some history, because also on management, on international level, we have some obstacles to go, to overwin, and to have the right choices and the right decisions. So on the international landscape, International Diabetes Federation, forever were active for us, and were going up, going down, some work done on the diabetic foot. Another part on the international level where it was of huge importance is the World Diabetes Foundation they did in 2003 a huge step forward to education on diabetic foot programs. We all know that in 91, so many years after we have had the insulin, let's be honest, work done by leaders like Karel Bakker and Andrew Bolton and Nicola Schaper and others to have the work done on the international level, to have symposia on diabetic foot, and further on also a guidance group who lead us all over the world with documents related to research how to do further on. In the period of 99, I was responsible in the idea for a consultative section on the diabetic foot, particularly on the implementation side, and for several reasons of conflicts or of misunderstanding, we had some separations over the years. And the only important message I want to give already for those who are in the lead, to be united is so important. And we understood that it was hard for those who are more on the scientific side, that the implementation side is another knowledge and another skill. So that was a time that in 2017, after some little steps, the DFoot International was born. So going further on that, I think it's blocked here. Okay, let's see what is the international organization DFoot. With you, I want to go with some titles to guide you on what I think after so many years is important. First of all, a very solid governance and in the board a team spirit. So as I told you, without going in details, we have to overcome an international obstacle, and we want to be focused on the needs on the whole globe. So we decided in a rough water to make a team that was going further on the implementation of the DFoot world. And these are the people I took the lead with Stefan Moorbach, with Abbas, who you will hear later on in this symposium, Wilma Urbančić from Slovenia, and Neil Baker as podiatrist from UK. This was a real team. We believed we were all focused on the same vision, and we were like a family. And a board who is a family can do a lot. Once this is installed, you need a vision and mission statements. And so we declared our action focus are training healthcare professionals how to manage diabetic foot problems effectively and prevent amputations, giving healthcare professionals strategies to implement, develop and sustain food services, because guidance alone is not enough, promoting the recognition of diabetic foot specialists adapted to the levels of the different regions, of course, and all based, as I told you, on guidance, on guidelines, and the last published ones are 2019. So 4 years later, 2023, new guidelines will be published. In this vision and this statement we made clear in our NGO, we were very, very convinced that a guideline is a map showing us where to go, and that implementation is a journey involving fieldwork of real people with diabetes and real carers that have the concept we are serving a society and we want to have less suffering, and we will implement based on those guidelines. So if you have such a task to go for on 7 regions on the globe with so different cultures, priorities were clearly there that education on the global level, especially, remember, 80% are in the developing countries, is so essential to make a change. And this is some statement I will never, never forget in my whole life from the moment I'm in Tropical, was formed in Tropical Institute of Antwerp, is the concept of education and implementation. Give a man a fish and you feed him for a day. Teach a man how to fish and you feed him for a lifetime. So with this, again, here you see Dr. Abbas and Karel Bakker in a visit of the World Diabetes Foundation in his hospital in Tanzania. And here you see, and there you must be very, very proud as nation. This conference is in India, And the first steps of this education on a global level were set by Dr. Sharad Pense and by Vijay Viswanathan with people like Abbas and Karl Bakker. And these are the fundamental first steps of a huge program we developed later on. Step by step. That was the first in 2003. And as we clearly understood that it was so much to implement all this education about the diabetic foot with simple tools, we developed the Train the Foot Trainer courses from 2012. And as you can see in the logo, it's the same as a step-by-step, but we wanted to create a cascade of trainers. So train the trainer, and those trainers will go further on in their regions. And with this cascade, we have monitored thousands and thousands of people who are in the same, with the same skills and same knowledge all over the world, adapted to the regions. When you work on such programs, you need the vision, as I told, and you have to understand the pathology. And we all know that it starts with a person at risk. It can have an ulcer. If you have bad luck, it can become an infection. If the bad circulation is there, it's limb loss. And the further you go in the pathway here, the higher are the costs, and unfortunately, the lower the comfort of the patient is. So with this, we developed 3 parts of education: everything what has to do with prevention, everything what has to do with the active care, and even more important, everything what has to do with secondary preventive care. And so everything what we developed on education was based on that. What was quite central when nothing was installed in a place, we understood that a multidisciplinary referral team is very important. So we put quite some energy in saying what is a multidisciplinary team or an interdisciplinary team, how it is connected to other things, and then national programs can start. So here you see a little bit bigger the concept of the basic programs settled by pioneers of your country with the help of Abbas on the World Diabetes Foundation. And we took this over in the Train the Foot Trainer program with this cascade. To give you some ambience of such courses, it was a lot of hands-on, and we know this because I think it's all over the world now in this way done, that I don't have to repeat, but it's always nice, at least for me, to go back in time and to see these wonderful workshops and the smiling people who are happy to be teaching today and be teachers later. Then we understood that it was so demanding that we developed also e-learning programs, and that good we did, because with the COVID we learned such programs are even more important, and e-food care programs were developed. Just as this is a symposium on NGOs and philosophy on NGOs and how we are developing things when we are in lead, I think international strategy has to be complementary. You understood in the beginning of my term, there were a lot of struggles, and I will not go in detail in struggles of the past, but I do believe that if you understand there is so much work to go forward, that the only solution is let's be in complementary and not in opposition of each other. There's too much work. And if you have leadership on that level, that you try to understand how to be in complementary, how we all can gain, and we don't see the egos, we want to be focused on programs, then we are in very good mood. So therefore, we developed quite some stakeholders for the DFood International. And just to give some, we worked quite close with the World Health Organization, International Red Cross, very still active for the new board in function, nice progress on this. International Federation of Podiatrists, some help for the e-learning. It was an organization in France, in Geneva, the International Society for Prosthetics and Orthotics, and even the Rotaria International. And talking about fundraising, this is a wonderful win-win. Rotarians are all over the world, a huge network, and we may not underestimate their importance. This is one thing of bringing organizations together with noses in the same direction. It's a huge strength. And of course, then you are talking about awareness strategy. And if you talk about diabetic foot, you need the politicians behind you. And one of the big things I have learned from my mentors is if you don't have an idea about the costs of the pathology, you don't have an idea of the suffering, forget the politics. Money is the key to convince your politicians what are your data in your country. And again, a huge work is done with participation of Dr. Arumbal, who is also in the program with some others. We try to understand the economical package of diabetic foot. And guess what? If you look to what's the patient financial burden in a urban clinic expressed as months of income, India is suffering a lot on this pathology. And with this, you can also see what's the costs for the politicians, and you try to convince them to say, if you do good programs, you can gain money and suffering. As you understood from Sandeep, who was giving his suffering and say, please, I want to give my experience that others learn, we have a responsibility on access of care, on strategic planning. And just before the COVID, the investment of the International Society was closing the gap of available and affordable diabetic foot care. And this was one of my last tasks during my presidence of DFoot, is working on a tool with a young academic group of Europe, working on the fast track. And we try to understand that pathology has 3 levels of care: the easy ulcers, the more complicated, and the ones who are like a myocardial infarction or a stroke, that you need an action immediately, independent where you are on the globe. And this tool with principles of standard of care is now so many ways translated, not in language, but adapted to local situations in Taiwan, in so many places. You can't believe that. I'm very proud that we try to understand what is a fast track pathway for diabetic foot ulceration, what is the access, and what is the communication to patients. As I said, international alignment is important, and podiatry is in the recommendation recognized as important, but we are not talking about the same podiatry care in your place, in Belgium, in US. So we analyzed it with the International Society of Podiatry, and we wanted to understand what is podiatry adapted to different regions. And this was another project I was quite happy with in my term, is to develop the POINT project, which is published in so many publications, that we understand that podiatry has so many levels of podiatry, and that in countries where no podiatry is existing, that nurses can be trained to podiatry assistants, and you can go up over the levels to have, if it's necessary, podiatry as it is in the UK and in the US. But at least by analyzing it, we are aligned, and we have no confusion anymore what podiatry is adapted to regions. Last point before I will go to conclusion is, we have worked on so many places. This was on international level, on educational maps, and shoes were very important, we always said. But what a nonsense if there are no shoes. If you don't have adapted shoes, if you are in cultures that are wet, warm, and we are talking by a European vision, this doesn't work. So consistency, do what we are preaching. And again, your place played a major role with Viswanathan and others. We came together in his place. We saw his place where people were making very, very basic circumstance adapted shoes for diabetic patients. Now it's of course on another level. This took us to the program, what we called, I'm still very happy because some of you know I'm an ornithologist. I like bird watching, and the group gave to me this logo with a bird with shoes, Flirt Bird, footwear in low income regions. All together, the program is going all over the world, and more better even, on the World Health Organization, we put the shoes for diabetic and others on the priority assistive product list. And this was a huge achievement on global level. So you have programs in Pakistan, in other places where the shoes got more values and more development. Now, last, flexibility. Suddenly, we felt that the Cinderella was in diabetic foot getting less, and we were better known, and we were happy. And suddenly COVID came in, and we saw that the excess of care was totally difficult for patients because we put probably too much accent on the centers of diabetic foot care. And in our years, we forgot the proximity, the care close to the patients. And very wonderful international working group together with DFoot, with the new president at that time, developed new recommendations adapted. My personal interpretation of this is next year's, we have to understand how to decentralize diabetic foot care, empowerment of community-based healthcare. Telemedicine is, we have learned how important, look today, we are online, and empowerment of family and patient self-care. Much better than we did. And we have a lot of new papers published. I will not go through in details because it's not a topic of today, but this is immediately on the international level, a responsibility to understand the situation, to have experts together, and to react with a high flexibility with recommendations. So leadership means also in NGOs, don't resist change, embrace it, and look to opportunities. So, my dear friends, this may look like a sunset, but it's a new dawn. And the future to be close in your country depends on what we do today with another vision, a vision in progress. So without networking and creating ambassadors all over the world, in all regions with leadership is impossible. And let's be proud, this was a symposium in 2019, a huge attendance. We promoted a lot of regional meetings. Now the motor is themselves, the regions are an active motor. We have had our last Foot January Assembly in The Hague. The last one was online, but I hope really that the next one will be alive again online, together face to face, and that we can create more than 300 national representatives. We have a network of 200, more than 200. I didn't show the exact numbers today, but it's impressive. So visit the website, be united. And on the fundraising side, you heard from Dr. Charapense, if you do the job well, if you create enthusiasm, if you have the network and you give the return to your fundraisers and you put even, and looking now to my good friend Yasha, we didn't even included a photo concours, a photo, to get money for it. Be creative, find your way, and you will be successful with a global view. And for me, for my whole lifetime, especially for the lower income regions, because their need is much more important. Just to introduce you to the wonderful new board from the summer, chosen by the responsible people. Vijay Viswanathan is your global president. Abbas, those two have done an investment, enormous investment on the beginning of the story of implementation, assisted by Mariam Botros from Canada, Hari from Malaysia, Nicolas Papanos from Greece, and our wonderful Hermelinda Pedrosa, who did for over the years so much work. So a lot of dynamics are in. The most precious things, I'm happy that the countries who need to be in lead are in. This is my proudness as old president. So please, I hope to inspire you with a part of my work, on my lifetime work. And another art is a time to be there and a time to go. I will always be with you, but I'm happy to give leadership to new people who have a clear vision. Thanks for your attention. Questions are always welcome. Thank you.
Yeah, Dr. Christine, it was wonderful presentation. The entire sum up of the presentation, if I just put across, it's educating, training, and also support from a lot of people like the Rotary, the government, and a lot of other NGOs who are around. And as you told that you showed Dr. Vijay Viswanathan, who we feel proud that he is the current president of the DFoot organization. So that's also a proud moment for us in India. You showed that India has the highest issues, and then we have a president from India who is heading this. So certainly there would be a lot of good things happening in the future. I thank you a lot, and I think there are no questions currently. If we can go to the next session, let me have the opportunity of, thank you so much, Dr. Christian. It was wonderful hearing you.
Thank you. Thank you for being there, Dr. Christian.
Yeah.
Bye.
The next speaker online is Dr. Margarita Ochoa Maya. She is an endocrinologist and also into metabolism with Biocon Biologistics. She's from Harvard Medical School. So I am from Harvard Institute in terms of the leadership program. So she's from the medical school, so it makes a lot of simile with each other. So Margarita, over to you, and hope to look forward to a solution for a chronic problem, especially the precision medicine, to address the population needs in the diabetic patients. Over to you, Margarita.
Thank you, everybody, for attending my presentation. My name is Dr. Margarita Ochoa Maya. I am an endocrinologist, and I am the U.S. Medical Affairs Director of Biocon Biologics. I trained at the Harvard Medical School, Brigham and Women's Hospital. I'd like to talk to you about a contemporary solutions for a chronic problem using precision medicine and digital therapeutics to address population needs and improve outcomes in diabetes. Why is diabetes care so challenging? Time management is the #1 challenge for providers caring for patients with diabetes. The diabetes population continues to increase both in incidence and prevalence. There's a shortage of endocrinologists with longer wait times for appointments to address issues that require specialists. And we look at the cost of care for patients with diabetes as it is increasing. The direct costs, as expected by the IDF annual global health expenditure, it can go up to $845 billion by the year 2045 per year. And the cost of treating complications account for over 50% of the direct health costs of diabetes. That we need to add the indirect costs, which add an additional 35% due to premature death, disability, labor force dropout, and absenteeism. There's also intangible costs, which there's an impact on quality of life, increased diabetes distress, loss of independence, and increased cost to the patient. The cost of diabetes severely pressures the healthcare system. In the US alone, with 34.2 million diabetics, the US healthcare expenditure surpasses $300 billion per year, with direct costs going around $237 billion per year, and indirect costs approximately going for $90 billion per year. Estimated that the annual healthcare expenditure of a patient with diabetes is about 2.3 times higher than that for a person that does not have diabetes. This is also noticeable in high-income countries as well as middle-income countries, where we see that the expenditures are equally elevated. When we look at the standards of medical care in diabetes as presented by the American Diabetes Association in 2021, we see that the coronary vascular disease, as well as heart failure and chronic kidney disease, are in the guidelines to be addressed as significant issues that complicate diabetes. Hypoglycemia risk is right in the middle of the guidelines because, as we all know, as we increase treatment, there is the risk of hypoglycemia. We also have started to consider into the guidelines the importance of weight management, as it contributes to both diabetes care management and cardiovascular risk and chronic kidney disease. And lastly, cost was introduced into the guidelines, where when we look and choose for diabetes management medications, we have to consider cost and realizing the affordability and access of these medications. What I think in the future will be is technology going to get into the guidelines. And as we see, the pandemic has accelerated the use of technology, and most likely, as we are seeing globally, the increase of technology is great for diabetes care because it will help both the patient, the provider, and the insurance companies. A comprehensive evaluation and assessment of comorbidities is recommended, where there is a decision cycle for patient-centered management. You assess the key patient characteristics. You consider specific factors that impact choice of treatment. You make a shared decision-making where you both, the provider and the patient, agree on the management plan, implement the management plan, follow up with ongoing monitoring and support, and then looking at outcomes to then readdress and recreate a new plan with an evolution of care. In terms of education, there are 5 levels of education that can be provided to patients with diabetes. It can be done either face-to-face or virtually. And now, because of the pandemic, we have moved to a case where even the virtual appointments are being reimbursed. We look at outcomes in diabetes where they are more measurable, where we're looking at learning, driving behavior change, which drives clinical improvement and ultimately improves healthcare outcomes. We also know that by every 1% drop in hemoglobin A1C, you can reduce long-term diabetes complications and 43% reduction in lower extremity amputation or fatal peripheral vascular disease. As this explains, every move in the right direction is helpful for the patient and ultimately has an impact in the reduction of cost. As we all know, with the natural history of type 2 diabetes, with time, type 2 diabetic patients will present with beta cell failure and require insulin. Of the total population, of the total type 2 diabetes population, 80% of them are on oral medications and about 20% of them are on insulin. Those that are on oral medications, about 35% are not in control, and of those, about 10% will require transition to insulin. For the 20% of patients on insulin, about 60% of that population is not achieving goal despite the use of insulin. So there are some barriers here that we continue to have in caring for patients with diabetes. The greatest barrier to management and insulin is hypoglycemia. We do know by a study over 24 months, 8.9% of the patients experienced and recorded a hypoglycemic event. So what is significant here is that insulin and increasing patient treatment puts the patient at risk for hypoglycemia. Even for those patients that are on insulin, 27.8% were at target hemoglobin A1C less than 7 at 24 months. In the study by DIDAC presented in Diabetes, Obesity, and Metabolism 2017. So this also translates to the fact that as it is hard to get the patients on insulin, even when they start insulin, they don't achieve goal. What we know is the standards of medical care in diabetes talked about putting the patient at the center and not the population. This reflects the appreciation of individual differences with respects to how the patient presents and how they respond to treatment and what their comorbidities and risk factors include. This drives personalized, individualized medicine. In contrast, precision or stratified medicine, emphasizing tailoring diagnostics or therapeutics to subgroups of populations that would share similar characteristics and minimizing error and risk while maximizing efficacy. So if we look at the individual and at the same time manage the population, in diabetes, we can reduce costs and increase outcomes. How do we do that? We have to use a team approach. We have the healthcare ecosystem in which the patients have a desire to be seen and heard as a whole. They don't want to be just data. From the provider's perspective, we have concern about losing autonomy, staffing shortages, and how they will be reimbursed for their provision of care. And from the insurance perspective or payer perspective, they are now moving towards Affordable Care Act and pay for performance, where rather than paying per visit, they would provide the organization with a lump sum of money to manage and budget their population. These are called accountable care organizations. When we put the patient in the middle, we see that there are values for all stakeholders. And we also understand that with the pandemic, we have now increased the use of technology. This value from a provider perspective, using technology, it can increase efficiency, benefit coordination of care, maybe even address remote monitoring for patients that have limited access to the clinic, and then have earlier recognition and provider intervention with increased patient engagement. From the patient perspective, we can be individualized, foster patient engagement, modify behavior, improve outcomes and quality of life. And from a payer perspective, there will be pharmacoeconomic benefits in managing this population closely. With regards to the advocacy priorities, the American Diabetes Association in 2021 recommended to improve equity, access, and affordability, reduce costs, and address payment barriers to see where the issues are with related to access to healthcare and treatment modality, boost access to trained providers that focus on nutrition and prevention, increase commitment to research, and focus on underserved populations. I'd like to take a moment to talk about social determinants of health. Of course, we always talk about affordability and economic stability, looking at our patients' employment, income, their expenses, their debt, their medical bills, and their support. We want to encourage a stable community and physical environment that fosters increased exercise and proper access to healthy food, education based on literacy and cultural background, addressing food insecurity and access to healthy options, focusing on social integrating, and increasing quality at a healthcare system and community level. In terms of the patient-driven diabetes care of the future, in the technology era, we see now that we can use technology for coaching, for nutrition, for example, using food logging. We can impact adherence with medication reminders. We can use mobile health and telehealth appointments with a patient portal that can foster virtual visits if the patient cannot come to the clinic. We can use group visits to address affordability. There's also applications to use and track weight management, blood glucose management, maybe through the finger stick or the continuous glucose monitor. We do know that these barriers continue: the growing burden of diabetes care, the obesity-inducing lifestyle, the challenges in access, the low number of diabetes specialists, the high patient volumes, low adherence to treatments, inadequate motivational support for self-management, the discrepancies in treatment, low reimbursement, and high rates of complication that drive costs are all barriers in which we can use technology to help us address these and increase patient engagement and thus reduce hemoglobin A1C and improve outcomes. In terms of ecosystems, I want to go deeper with digital therapeutics. This is a journey I'd like to show you as you look at my slide. This is a patient with diabetes here who would then measure their blood glucose. It can either be done with a glucometer or a continuous glucose monitor. This would go into an application that would be integrated and might even give a recommendation on dosages. So for example, I put the insulin pump, but you can use connected pen caps. You can use applications that recommend dosages and then the patient injects the recommendation. But this is all within the patient. This would all go to a cloud database, which would then trigger either an in-person visit or a telemedicine consultation. And very importantly, it diversifies the attention with the use of the team, where we can use the medical assistant for remote monitoring, the associate provider for titration, maybe the primary care provider, then give more space for the specialist. Again, these are the benefits to the patient: better control, patient empowerment, reducing stacking and wastage. For the provider, task shifting, efficiency, more time to address comorbid conditions. And from the payer, streamlining endocrine care and enabling standardized diabetes care. We can also look at the member or the employer where they can see increased efficiency in their employees. I'd like to conclude with talking about the digital therapeutic clinical study, the TeleDiab 2 trial. It was a 13-month randomized control trial that evaluated the efficacy and safety of 2 telemonitoring systems. As you can see in my graph, group 1 was the traditional visit, where the patient came in insulin naive, type 2 diabetes, would be started on insulin, would have a follow-up after a month, after 4 months, after 7 months, after 10 months, and then after 13 months. And then let's go to group 3, where they would actually have a smartphone, and short phone consultations, which now this would be translated to a contact with an app on a weekly basis in this case. There was a physical visit at month 4, monthly visits, and then a physical visit at month 13. We see that at month 4, there was an average drop in A1C from baseline that was higher in the DTXR by by a reduction in 1.48% versus the control arm that came down 0.92% with the statistical significance. We want to understand that the control arm also was started on insulin, and this is the effect of the insulinization in that first year. If we look at it from an economic point of view, if we introduce telemedicine, as compared, this would be the traditional approach, where there was a visit in month 1, month 4, month 7, month 10, month 13. Here there was a visit, and then there were weekly teleconsults or use or engagement with an application. There was a visit on month 4, which could be done by a social provider as well as telemedicine. Then there were teleconsultations monthly and then followed up. We can see if we did the math, there is less visits and there's more cost. Here there is more visits and less cost. So we have improved efficiency, access, and increased patient volume from a patient perspective, and the provider perspective, more space and time to see more patients. There's an ultimate reduction in cost to the system versus what is paid. The solution. So why is diabetes care so challenging? We want to encourage a patient-centered approach using technology to unite patients with providers, utilize artificial intelligence to integrate personalized medicine with precision medicine, increase the availability of educational platforms, leveraging social media and influencers at the patient level, empower all providers to address the needs for the individuals while at the same time looking at the larger needs of the population, and maximize the use of diabetes centers of excellence that use technology, and then go even as far as using insulin pumps in patients with type 2 diabetes. We want to improve outcomes, addressing social determinants of health, using health economics and outcomes research to reinvest in the community. We want to educate and empower to foster engagement from all stakeholders, and then use geographic heat map insights to help each other drive precision economics and help our community with diabetes. Thank you very much for attending my talk today.
Yeah, thank you, Dr. Margarita. It was a wonderful session. And one learning out of your session, which is very, very important in this COVID time, is that mixing technology with physical visits actually helps save cost. So that's one thing which is actually half the cost of what the patient used to do when they used to visit physically. So whenever there is an adversity, there is always an opportunity. And I think this is what has created this. And hope we all go through this tough time very successfully and come out so that your patients, everyone as such, gets your treatment to the fullest. So thank you so much, Dr. Margarita, and it's a pleasure talking to you. Yeah. So let's go to the next session. Dr. Larissa Ramirez. She's the Medical Director for AstraZeneca International UK. And Dr. Larissa Ramirez is going to talk about TCOM building partnership-based ecosystem for patient-centered solutions. So over to Dr. Larissa. Thank you so much.
Thank you so much, Dr. Vijay. It's very nice for me to have the pleasure to share with you a little bit of what we are doing today across the emerging markets, because this is a building, we are building an ecosystem at the primary care setting. And, you know, it's just the beginning of what the future looks like for our primary care setting in terms of the management of type 2 diabetes. And, you know, having the previous presentation, you know, we couldn't set up the scene better because there was a clear understanding of the unmet need when it comes to the management of type 2 diabetic patients and how it's necessary and holistic management from the cardiorenal and metabolic perspective. So just give me a minute because I'm trying to put together my presentation. I'm just going to share my slides. Just a minute. So let me know when you can see my slides.
Yeah,
my
it's
screen.
visible.
Okay, thank you so much. So just as we were discussing before, definitely chronic diseases are right now a hot topic, if we may say it sort of a way. We are expecting a 50% increase in the prevalence of these kind of conditions like type 2 hypertension, chronic kidney disease, and heart failure for the coming years. And unfortunately, the majority of our markets, across international, including India, China, Mexico, Egypt, are countries that are having high prevalence of type 2 diabetes and its comorbidities. Just give me a minute because I don't know, I cannot find my slides. Here it is. So I'm so sorry for this. So building on our previous presentations, what we are really trying to do is to build a disease management platform that it's going to be focused on an end-to-end management model, really embedding the early prevention of cardiorenal complications related to type 2. But we are really focusing ourselves in the primary care setting. As our previous speaker mentioned, there are not enough cardiologists, endocrinologists, or even nephrologists to cover the amount of patients that we are seeing and that we are expecting in the future. So we are really building a regional footprint to try to consolidate above-line initiatives, increase the awareness not only across the healthcare professionals, but also across the patients and the carriers. And we are really looking to build partnerships externally with governments, societies, medical societies, other pharma companies, device companies, and startups. And you're going to see later on how we have achieved already these kind of partnerships that will help us to enable policy shaping across the different countries and really building the best healthcare management for these type 2 diabetes patients. So we have built 4 pillars for our program. We started almost a year ago, a year and a half ago, just with a crazy idea. And it started as a screening program idea. Then we realized that we had the evidence generation program in place. We put together a type 2 diabetes registry across international, and we started connecting the dots in a very simple way. Then the next thing that we needed to do was to start engaging physicians and really building advocacy among the awareness of the management of type 2 diabetic patients and those patients at risk for heart failure and CKD. So we have built a strong program, a strong educational program to really try to break clinical inertia when it comes to the management of type 2 diabetes and really build the advocacy for them to shape the management of these patients and also change their behaviors when it comes to the management of these patients. The third pillar that we have built, and it was a very natural step, was to really build on the patient activation. We have seen that social media has become definitely one of the tools that we have proactively been using to connect with our patients. So this, what we were really trying to do was to empower patients and empower caregivers to start the right conversations with their physicians, to really take informed decisions when it comes to the management of type 2 diabetes. And the fourth and the final pillar, it comes when we add each of the pillars that I've mentioned before. Policy shaping was the big objective of this program. We really want to drive national policies to increase the priority of early screening of diseases like heart failure and CKD, where if we can start the treatment earlier, patients will have an improvement in terms of the healthcare outcomes. Really trying to drive routine screen programs and advocating for early screening of cardiorenal complications. And at the end, really build a network of certified Take Care of Me clinics or cardiorenal and metabolic clinics across the different countries where we are piloting. I will highlight here that this is a pilot program, that it's really seeing a change in terms of how it started very small and how it has increased in terms of the local implementation and execution. We started our phase 1 with just 6 countries: Malaysia, India, Argentina, Mexico, Philippines, and Egypt. And you're going to see in some further slides that this has been really expanded and it has become a really truly global footprint program. When it comes to the end-to-end interventions, and again, highlighting the fact that technologies, it's not going to play, but it's playing today a key role for the patient and for the physicians, we have defined some specific tactics when it comes to patient activation campaigns using social media, Facebook, Twitter. We have started to use the also social media to communicate and build on educational activities. When it comes to diagnosis and the screening campaigns, I will show you in just a few slides how we have connected the patient journey and the ecosystem all together to try to make the transition or the movement of the patient as smooth as possible when it comes not only to type 2 diabetes, but also the early screening and really building on this holistic assessment management for cardiorenal and metabolic complications. When it comes to treatment, all starts with the education of the physician, again, to try to break clinical inertia, really building on the national guidelines and protocols at the hospital level, including the different stakeholders and payer being obviously one of the most important ones. And when it comes to the health economic outcome research piece, also we are building on the cost of not treating type 2 diabetes and really showing the impact that it has in the healthcare budget and how we do early intervention. This impact can be positive in the long term, not only for the healthcare budget, but also for the quality of life of patients. And when it comes to wellness, now we are really building this patient health concierge, if that can be called. Due to COVID-19, a lot of things are changing and patients don't want, especially type 2 diabetic patients, don't want to go out to visit the physician. But we have telemedicine, we have now new point of care devices, we have a whole cloud-based platform where we can build, and make sure that the patient has anything he needs or she needs just a click away. How has been our journey so far? So we kicked off this project in July 2020. We were signing the different MOUs and establishing a clear local operation guidance by August 2020. We started all the kickoff meetings with the countries, and we started to build on the local clinical model plan, connecting obviously with the local teams. In November last year, we established a partnership with an Indian startup called Tricog for the use of artificial intelligence in the management in the screening of heart failure. And we also signed a partnership with Abbott to use point of care devices that give us the opportunity to test patients not only for HbA1c and lipids, but also for UACR. We also build a strong investigators network to really embed all the data that we were collecting in the screening programs into the iCareMe registry and make sure that we have robust local data that can help us to create the awareness, for policy shaping in a strong way. We have built a risk categorization e-platform based out of the ESC, EASD guidelines and also the CKD EPI to assess the cardiovascular and the renal risk for patients that were considered type 2 diabetes cardiorenal naive. And then we were signing at the local level different partnerships with local societies, local governments, and local vendors as well. Our first patient despite COVID-19, was in November last year. During January and February, we were able to activate different centers across the 6 pilot countries. And today we have almost 7,000 patients despite COVID-19 challenges that we have faced across all the pilot countries. The one being hit the most was India, and India was a key contributor for us. But I want to thank here all the teams, not only locally in India, but also in the different countries that have engaged with the investigators, and also thank the investigators and everyone that has been part of this program, because what we have achieved is a huge success. Also, by February 2021, this year, our project was included in the Access to Medicine Index and Sustainability Report as one of the top contributions to the type 2 diabetes management. And this, it's a really proud moment for us, because, at that point in time, what we had was an idea and we were just implementing. And today, what you see today that I'm presenting is a reality. In the rest of the year, we have activated the different sites across the rest of the markets, and proudly enough, last month, I'm sorry, we are in August now. So in July, we signed a partnership with the International Diabetes Federation for their endorsement, not only for the registry, the iCareMe registry, International Cardiorenal and Metabolic Registry, including type 2 diabetes, heart failure, and CKD, but also endorsing the educational pillars, endorsing the Take Care of Me program, and endorsing the policy shaping initiatives that we are building out of this program. As I mentioned before, this is a truly international footprint. You can see here that we have 6 Take Care of Me evidence generation programs across the different countries, more than 51 investigators already included and engaged, and more than 7,000 patients already included in this initiative. 19 markets have launched the patient activation campaigns through social media. We have a program with specific 5 markets that have been actively engaged for driving policy shaping. We have other 5 markets that are part of the initiative with the health economic outcome research and the cost of not model to really show the payers the benefit of this disease management platform. And also more than 100 physicians have been trained, more than 4,000 primary care physicians had been educated across the different markets, and more than 50 primary care physicians have also become advocates and really are trying to change and to influence and cascade this information across the international markets. When it comes to the connection with the patient, we cannot speak our medical language. So we have come with a very simple, very visual social media campaign where you can see here, the suites of the different areas and the different countries, trying to really make sure that patients do understand what is behind the type 2 diabetes. Is not just about sugar. It goes beyond the sugar. The damage that the sugar can do, the sugar in your blood can do, can affect the kidney, can affect the heart, and really can have a long-term impact in your quality of life. This is just a couple of examples of what kind of activities we are doing, in the countries. I'm really sorry about the background noise, and how this can really impact in the long-term diabetes complications for these patients. We are really giving them also, and physicians as well, materials for them to educate patients. In the different markets, physicians, advocates are really driving, education to patients through social media. They are doing Facebook Lives, and we have seen that patients are really interested. And you can see here just a little bit of the reach that we have had with these campaigns in just one country. This is just Philippines data. We were able to reach more than 2 million people through social media. They have been engaged in a very positive way. You can see here that the interaction is also really high. The people are really engaging, and we have now more than 10,000 followers in our different accounts. So very successful way of activating patients through social media. And this is how, we are really seeing a change, and we see the new normal, and social media is definitely becoming part of our new normal. The next step that we are taking is using social media for medical education. So we, as part of the partnership with IDF, we're really going to be enabling, social media, so IDF can start connecting with physicians in the different countries. The other kind of activities that we are building on top of what I just mentioned before is really screening programs at the local level. This is just an example of Mexico, where besides the iCare and the Take Care of Me program, we are building patient activation through mobile screening tours. So it's not just about the patient coming to the clinics, but us, going out there and really looking for those patients that are not aware that they do have cardiorenal complications related to its diabetes. It's really interesting because obviously this is data on file, but what we have seen so far, it's that for almost our 7,000 patients, around 30%, 27% of these patients have shown renal impairment, and around 30% of these patients are at high risk or very high risk. Interestingly enough, we have moved these patients to the echocardiograms, and around 4% of these patients at high risk or very high risk for cardiovascular diseases were diagnosed with heart failure. There has been a huge work that we have done through our medical teams in the local markets to try to educate on the heart failure symptoms, signs and symptoms, early signs and symptoms. We know that this is a very silent disease, but we needed to corroborate our structural abnormalities seen in the different echocardiograms to the clinical status of the patient. And we have been very successful. And around 4% of these patients, as I mentioned, with high risk or very high risk, have been diagnosed with heart failure. So this is just a glimpse of what we are really trying to build, the changes that we are really trying to make, how we are building ecosystems and putting everything together, making sure technology, education, evidence generation can really drive a change in the way that we are managing our patients and the way that we are seeing the future, trying to improve quality of life, but also connecting to the health economic piece that it's really important for our different stakeholders. Thank you very much.
Thank you so much, Dr. Larissa, for a wonderful presentation. I mean, it is really heartening to see a lot of patient engagement programs that you're doing from Astra, and really makes a lot of sense because a lot of patients are undiagnosed, and there is a social responsibility to diagnose those kind of patients as well, especially the mobile van, which you've been using for diagnosis of complications, really appreciable. Ending with the session, we had this session of taking organizations to the next orbit, and wonderful it was from the time it went off from Dr. Sarat Painse, who did talk about his diabetic clinics, his type 1 diabetic patients. Then we had the diabetic foot expert who talked about how to manage diabetic foot through a lot of differential ways. And then finally we had a pharma company speaking about the ways to manage through pharma interaction. So it sums up actually the NGOs, the pharma companies, the doctors, all of them put together. If we can make a difference to the patient's life, I think that's more than what we could do for those diabetic patients. So thank you so much. It was a wonderful evening. And Dr. Yash, I hand over the session to you, sir.
Thank you. And what word comes down after these 2 days of sessions around is wow. There are plenty of paths had been explored, and there are plenty of paths needs to be explored. And we are, as a stakeholders of diabetes care, there are plenty of things happening around, and we see plenty of necessities are there where we can support and make a difference around. To the theme of this meeting and conference, necessity is the mother of invention. And when we talk about innovations, then we know the creativity is the father behind it. And we see plenty of creativity is happening around. And the real actions by those stakeholders and ourselves can make a difference around. To make the ending of these 2 days, I really thank my all faculties, chairpersons, delegates, and team members, organizing team, my organizing secretaries, scientific committees for these wonderful topics to build on. It is indeed pleasure that all of ourselves making in this integrity makes these sessions all live, all interactive. And yes, we miss out the integrity of time. That is all on the organizing secretary and organizing team to look for. To make the numbers out there, we were 1,537 delegates along with 363 volunteers who had joined these live sessions and make the difference in their lives, and they would be taking care to their communities. Yes, to make it in timeline, we have not taken the questions around, and that is where the interactions we are missing, and we are taking care on tomorrow. To make the tomorrows more interesting, we have sweet awards presentations in the early part of the day, starting from 1 p.m. Indian Standard Time. And those categories are well in the diabetes care categories, which we have the different award nominees to present for the awards, and the plenary sessions, keynote sessions, and the panel discussion. And ultimately, there are special guests who are making inputs or sharing the inputs and making difference to all the sessions we have. And to that note, I'll close this day and thank you to all of one. And thank you for being there from whole over globe and these different countries and making these sessions more interactive. Thank you all of around. Thank you, everyone.
Thank you. Thank you so much.
Thank
Thanks,
you.
sir. Mayur, sir. Good evening.
Thank you. Good evening.
Nice.